So very good morning. Please take your seats. Please come forward. So we should be in time, so we should start. So this is very important, very important workshop related to immunity unlocked, the modern allergy workshop. And the national national coordinator of this workshop is Professor Rajkumar sir, who is director of VP Chest Institute, New Delhi. And I am the local coordinator here, Dr. R.S. Kushwaha, Professor Respiratory Medicine, KGMU. So in this workshop, very important lectures and subsequently hands-on workshop stations will be there. And at the outset, I would like to invite Professor Rajkumar sir, with his permission, to start the workshop.
Thank you, Kushwaha Sahab, and good morning to everyone. Yes, and now this is the workshop on the modern allergy workshop. That's the title has been given. Or at the outset, I thank the organizers for giving us the opportunity for participation in the ICAAICON 2025. So without wasting any time, basically this workshop is planned in such a way that with this workshop, at the outset I must tell you that you are not going to become the allergologist. So this workshop is just to sensitize yourself. So because in our curriculum, we don't have a separate chapter for allergy and immunotherapy and so on. So it's just a glimpse, basically, just a sensitization that you know that what is allergy and how the diagnosis of the allergy are being made, and if needed, what are the modalities for the management, like the avoidance or treatment, maybe pharmacotherapy or the immunotherapy. Today we'll be mainly discussing on the immunotherapy. So, if you see the timetable and everything, so before lunch we'll have the lectures of different topics, and after lunch we'll be having the hands-on training, and this hands-on training will be divided into groups basically, and each groups will be exposed to different methodology, like your history taking, then how the skin prick tests are done, how the intradermal tests are done, and for the immunotherapy, how the skit is given or the slit is given. Yeah, directly मैं pen drive लगाऊं क्या? Yes sir. है जी? So, so briefly, I'll just go through whatever you are going to learn in whole day. This is just a summary basically. I'll not spend much time, but I will just read out the slides. The concept of the allergy diagnosis. What is the concept of the allergy diagnosis? A proper allergy history involves determining the symptom complex, any relationship to the allergen exposure, and a careful physical examination looking for the specific signs of the allergy. So the history taking is very, very important in whole procedure, whatever branch you are in, but if you don't take a proper history, it's very difficult to come to the diagnosis. So proper history taking is same for the allergy diseases also. You need to take a proper history and careful examination. So before that, basically what you need to have the basic concept of the immunology or immunotherapy. So this basic, after the basic concept you have, which will be dealt by Dr. P.C. Kathuria. He is going to tell you about the basic concept. And then basically proper history need to be taken. So the proper history will be dealt in the detail by Dr. Rajendra Prasad. So history is very, very important. Once the allergic disease is suspected by the history, then confirmatory test, and these tests are two types of the test, that is a skin prick test or the specific IgG test is performed to verify sensitization by the presence of allergen specific IgG antibody. So after you have taken the history, then when you decided that yes, this patient is a suspected case of the allergy, so let us go for the diagnosis. So the diagnosis investigation you need to do. The investigations are two different types. One is the in vivo and in vitro method. So details about these investigation will be dealt by Dr. V.K. Jain and Dr. Naveen Arora. So they will be telling about how to do the test, in vivo and in vitro test. So after you get the test, basically, it's very, very important that when you do the test, then you correlate with the history of the patient. So history correlation is very, very important. So once you have taken the history, then after that, what you need to do, you have decided that yes, it is a suspected case of the allergy. You started the investigation. The lab investigation has been done with you, and then again you correlate with the history of the patient. Because only positivity is just a sensitization. So once the positive results are there, if they are correlating with the history of the patient, that becomes allergy basically. So these in vivo method and in vitro method is very, very important how to go ahead, and these will be dealt, I told you, by Dr. Naveen Arora and Dr. V.K. Jain. You know, basically whenever you are going to do the test, you need the antigen. So standardized antigens are very, very important for your diagnostic purpose and of course for your therapeutic purpose. So that need to be also dealt, and that will be dealt by Dr. Naveen Arora. Then after that, when you have decided so where it can be performed and interpreted, skin prick test remains the primary confirmatory test because it is fast, safe, sensitive, minimum invasion, and results correlate with the nasal and the bronchial challenge. So basically when this is done, dealt in vivo and in vitro test, they will be telling you how to do it and which is better. But for all practical purpose, the golden standard for the diagnosis is the skin prick test. Of course, quantitative IgG antibody serology is accepted alternative. Where it is needed, that will be also done. And of course, I told you that SPT and or specific IgG are essential adjunct to the history and physical examination. So correlation you need to be done. Of course, in the research, for the research purpose and for in the tertiary centers, provocation test can be also can be done. Again, then after you have done, it's not moving. Hello, slides not moving. Anyway, so when you have already done the test, you have correlated with the history of the patient, and if it is correlated, then these patients are allergic to that particular antigens, and then you basically tell that you are allergic to that particular allergen. Now the two choices are there, either go for the avoidance or go for the treatment basically. So avoidance can be also done, and avoidance is very, very important component which is there. And then after you have decided that okay, we need to go for the immunotherapy, there are two type of the immunotherapy, skit and the slit. Advantages and the disadvantages will be dealt, and skit will be dealt by myself, and slit will be done by Dr. Nagendra Prasad. There are very important components like skin patch test, food allergy, drug allergy. These are also very, very, very important component of the allergy testing and management that will be dealt by Dr. M.K. Gupta, myself, and Dr. P.C. Kathuria about the drug allergy. Whenever you are going to do any test, basically, it's very, very important that you should be able to do the management, so your emergency tray should be there at your place so that you can deal with the anaphylaxis. So how to deal with the anaphylaxis will be also done, will be also dealt by Dr. Sonam. So I told you that you must know about the immunotherapy, skit or the slit, that we are going to tell you in detail and all those things. Of course, when you need to start your practice, you should be able to know how to set up the allergy testing clinic, and that will be dealt by the Dr. Gautam Modi. So these are the topics which are going to be dealt, and then after that there will be 5 stations will be made. I told you, history taking stations, then skin prick test, interdermal test, slit, and the skit. So 5 groups will be made, and they all will go for 15-20 minutes on the each table, and the faculty will be there to explain you. So to summarize, very, very important when you are dealing with the allergy and immunotherapy, history taking is very, very important, one. Second, how to choose the best allergen for doing the allergy testing is very, very important. The diagnosis can be made with the investigation in vitro, in vivo method. And when you do the test, if the test comes positive, then this need to be correlated with the history of the patient. If it is correlating, then it is clinically significant. Otherwise, it is just a sensitization. You don't have to do anything. When you are confirmed that the person is allergic to that particular allergen, avoidance should be done. Avoidance is needed to be done. And of course, if you plan to do the immunotherapy, skit or the slit can be also done with you. So this is the whole thing I have summarized into just 7 minutes. And with that, I will now request Dr. Dr. P.C. Kathuria, who is the renowned allergologist of the country, and he is going to tell us about the basics immune response to the allergic diseases. And he has got a national center at Delhi, and they are also doing courses for courses for 3 days. Basically, anybody is interested, they can contact him. And I think his life has been spent in the allergy and immunotherapy, stalwart of the allergy and immunotherapy. I request Dr. P.C. Kathuria to take over the mic.
Thank you. अच्छा हमारा लगाओ इसमें वो पॉइंटर pointer. It is so. Good morning, everybody. My greetings to all. Really, this is a proud moment for me. This is my parent institutes, where I did my MBBS and post-graduation. My topic has been to update the basic immune response in allergic diseases. If you trace back 1963, the Jalen-Kum classification was based on 4 types. Pointer ho de dijiye. But it was not a complete classification. Later on 1990, it was extended the type 4 reactions into the 4 types. But now a recent classification, which is Yaki 2023, has really revolutionized, which includes all the basic which were not knowing initially. It has been classified into 7 types, and we will have a discussion on this, each one of them. The changes which has occurred, that the type 4 classification, which was initially into 4 types, has been converted into the 3 types, T1, T2, T1, T2 and T3. And second, the classification which has emerged, type 5, that is the tissue-mediated epithelial barrier defect, and the type 6, the microbiome dysbiosis defect and the drug-induced inflammation. They were not included initially because at that time we were not knowing there are some other innate immune cells or there is some direct damage pathway to the tissue occurs. Now these are the 3 classification. Please remember, one is the antibody dependent, the second is a cell dependent or cell mediated, and the third one is a tissue mediated. So antibody, as you know, is the product come from the B lymphocytic activity, and it is of the 3 types, IgE and IgG and IgG with a complement activation. Now this IgE is an immediate reaction. All the acute symptoms, you see the urticaria, angioedema, anaphylaxis, bronchospasm, they comes under this domain. Even the drug allergy also comes. And here is the involvement of the mast cells. Mast cells degranulate. And the second is a type 2, where the drugs binds to the receptors of the inflammatory factor cells and then induce reactions, and the antibody recall the NK cells, the macrophages to kill, to do the apoptosis of the cell. That mechanism is called the ADCC, antibody dependent cell toxicity. Third one is a immune. Here the excess of the antigen it comes into the action and they form complexes with the antibody. They cannot be filtered out through the reticuloendothelial system. So what they do, they activate the neutrophils, and neutrophil comes and they produce damage. The cell-mediated is a new one. It is a T1, T2 and T3. Initially we were knowing the TH1 only. Then the studies came TH2 also. Then study came TH3 also. But who is activating these cells? And that was through the crosstalk with the innate immune system. Then the innate immune system it came, we know. Now the innate immune system has comes into the ILC1, ILC2, ILC3. Once the cytokines from the TH1, TH2, TH3 interact with the cytokines of the ILC1, ILC2, ILC3, they form damage to the tissue. And then both they act, then we call it as a T1 or T2 or T3. You see, these are based on the various inflammatory cells. Why they are separated from T1, T2 and T3? Because we have got different cytokines. In a T1, there is a interferon gamma, there is a TNF alpha, it comes, And the cells you see, they are separate. Macrophages, NK cells. You know the autoimmune disease, most of the autoimmune disease, they comes under this domain of the T1. And most of the infective disease, whatever the virus, microbes or other things, they comes in the domain of the T3. Here the cytokines are different. Here it is a IL-17. The Th17 also comes and interact with the IL-3 and they produce the damage. So these two are a autoimmune as well as the infective disorder. But the most important which we are here today is the allergic disorders. Allergic disorders, they come under the domain of all the IL-4, 5, 13. These are the cytokines which comes because of the interactions of the ILC2 and ILC and Th2. So these are the different classified on the base of the various cytokines we define. Now coming to the tissue. This was not there. Now with tissue we know damage occurs directly. Some of the drugs, some of the inflammations occurs directly. The first important is the defense mechanism in our system is the epithelial cells. Whatever may be the exposure to the virus, microbes, irritant, pollutant, or chemicals, or allergens, first defense is the epithelial cells. So whenever there is a damage to these epithelial cells, the cytokines which are called alarmins, IL-25, 33 and TSLP, they comes into the action. And this has been separated as a, which is called a type 5 EBD, epithelial barrier defect. Then comes the type 6. Type 6 is some drugs. Initially we defined, if you have heard that pseudo-allergic, anaphylactoid reaction, we were not knowing, confused, where we will put in the classification. Now this classification has put these pseudo-allergic, anaphylactoid of the reaction, like we take the NSAID, aspirin. These drugs, they directly damage to the epithelial. Now they are separated as a type 6, drug-induced damage. Another one is there, that is the type 7. You see, microbiome is very important for our system to maintain our immune system. There is a specific lung microbiome. There is a GIT microbiome. There is a skin microbiome. If there is any dysbiosis between this microbiome, then all the virus, microbes, or the irritant, they come into actions and they do damage. So this has been separately also under the type 7. So with this, we must understand that what is type 1. Here there are 3 phases. One phase is sensitization, and second phase is activation, and third phase is effector cells. Now what happens in sensitization? What is sensitization? Sensitization is the expression of the Ig receptors on the various effector cells, especially the mast cells, basophil cells, eosinophil cells. Now this sensitization is due to what? From the activation of the B lymphocyte. From the B lymphocytes become activated once the B lymphocytes cross-talk with the Th2. Why the Th2? Th2 comes because of the naive T cells has been transferred to the Th2. It depends on the type of the exposure. If this exposure is there, and these exposures, dendritic cell will take up and present to the naive T cells and further synthesize. So this is a pathway by which you can have a dendritic cell activations, and end product is IgE antibodies which synthesize, and the same percentage of the receptors on the various effector cells is called sensitization, because this crosstalk with the T cell, and that they say the plasma cells are activated and synthesize IgE. Now this story was there, that this IgE antibodies is a byproduct of the B lymphocytic activity, take permissions from the T cells through the presentations of the dendritic cells, which says that now you go there further for production of the Th2 production. Now this story was not complete even. What happened to the epithelial cells? Because first there is epithelial cell damage occurs. Now the epithelial cell says, I am the first, you are the second. Means epithelial cells induces first damage, and it further facilitate. So please take my word. Allergens are the initiator. Allergens are the perpetuator. Allergens are the orchestrator. And what the virus, microbes, irritant, pollutant, they are the facilitator. So whenever they comes into our system, they produce damage, and the first this epithelial cells damage, it talks to the DSC, so both these work together. This is the concept which is going on. Now once the allergic disease, we say it consists as a type 1, I told you, type 4 be epithelial, and type 5th is a EBD, the epithelial barrier defect. So this takes time, that early effect, then there is a late effect. Now coming to the, I told you this type 2, it is because of the phenomena of the ADCC. Type 3, it activates the neutrophils, but we more focus on this T2, inflammation disease. T2 inflammation disease, we now define whatever when you see the case of the rhinitis, asthma, food allergy, anaphylaxis, urticaria, eosinophilic esophagitis, these are the 7 diseases. We now say it is a high T2 inflammatory disease. Then you define which organ is there. First you should say it is a high T2 inflammatory disease because there are many comorbidities. They are associated with the many diseases. Allergic rhinitis, atopic dermatitis. Why? Because the cytokines, the pathology is also the equal. Because you see 80% of the rhinitis patients, they have got associated asthma. Why? Because they are the same cytokines. 9 cytokines, 9 inflammatory cells, and 10, 11 mediators, they circulate in our system and they activate which organ, it depends on the exposure of the allergens. IL-4 and IL-13 is the most important cytokines which produce damage in our system. So we have differentiated now all our respiratory allergic diseases into 4 parts. Number part is there. Is it a allergic eosinophilic? Means here the reactions will be type 1, here the reactions will be type 4B. The epithelial damage will be always there, but we depends on the which mast cells, which eosinophilic sex is problem. Both the cells are there, then we say that it is a allergic eosinophilic. Or we differentiate, it is a non-allergic eosinophilic. What is non-allergic eosinophilic? Means there is no allergens, but there is exposures to the irritant, virus, microbes, pollutant directly. Because here is the EBD is more predominant. And third one is there, that is a non-allergic, non-eosinophilic. Then we define that most of these patients, they are non-allergic. And fourth one is there, which is structural damage, that we will discuss. But once you should understand that what is the difference of a IG inflammation, or what we can say that what is, you can define it is a mild intermittent asthma. What is mild intermittent asthma? Mild intermittent asthma is there once in the tissue there is a mast cells, no eosinophilic, no cytokines, but they are primed. They doesn't work, but they are in the tissue. But only the MCD occurs, the mast cells degradation, you give LAVA and ICS, and the patients feel better. Here the damage is equal. The remodeling, what we call a structural damage, or otherwise ECM extension, the involvement of the air smooth muscles. It occurs, but it is less than. But in another way is there that non-allergic, where there is no allergen, allergen independent. Here the difference is there because now virus, microbes, glycolipids, pollutants, they produce more damage. So most of these patients, they are difficult to treat. They are called persistent asthma. Now the eosinophils has come. Now the cytokines, they are circulating and they produce damage to the tissue. And what about the T1 and T3? What they help? What they are doing in asthma? Because the T1 I told you is due to autoimmune disease and T3 is due to the infective disease. What they are doing? These cytokines, they act also with the T2 because some of the Th2 cells, if they pass into the airway tissue, they behave as an antigen and they induce interferon gamma and TNF alpha. So autoimmune factors do occur, but T3 do occur. Then what we define that? Then we define it as severe asthma. Once T1, T2, T3, they work together to induce inflammation. Already there is a pre-existing T2 inflammation going on. Then we call it as a severe asthma. Now the concept about the severe asthma is still unknown. Many pathways are there, but some of the pathways still work is going on. So this is a non-T2 where the damage is more, structural damage is more in a non-T2 inflammatory diseases. Now coming to the epithelial, I told you epithelial, the barrier defect, there are 2 lakhs chemicals in the environment, they induce damage to our epithelial and they get chance to enter, and the other factors like the which is not needed, they induce inflammations. Alarmins are the main, and then type 6 is there where the NSAID, other things they directly damage, and these cases they activate. You see here is the, what is that called? Prostaglandin E2, which is a potent bronchodilator. And if you give a COX inhibitor, then E2 becomes less, and the reactions they are associated with this, most of these aspirin activation sensitization have got these associated diseases. So this is a way. The 7th is their metabolic. Metabolic we see not only the external, because we are now taking less of the microbiomes acting. The other way there, the patients, the hormonal disturbance do occur, and this obesity, because if you have a less microbiome, the immune system development does not occur properly. And these children, now we see these cases, why the food allergy, drug allergy, or the respiratory is growing up because of the processed food we are taking. And so in short, I just give you, if you have a case of the respiratory allergy, it is the combinations of the immunological reactions, T1, T2, T3, EBD, and type 6. And so we define on the base of the which potent cells are there in our system, which is eosinophilic, mast cells, or which cytokines are there which is active. So whenever there is a already pre-existing inflammations, on exposures of this, patients will get severe asthma. They induce further damage to the tissue, because please remember, in respiratory disease, on one side we have got inflammation. At the another end, we have got a remodeling. So our aim as an allergist, immunotherapist is to prevent the patients not to induce further damage, so that we can prevent our patients to develop into a state of a remodeling. So it is not the allergen immunotherapy, but other you need avoidance. Along with it, you have to maintain the microbiome as well as the other symptomatic treatment. It is the integration of the pharmacotherapy, it is the integration of the allergen immunotherapy with our biological, where the patients we can get into the remission. With this, thank you very much for your kind attention. Yes, sir.
Any question to Dr. Katuria? If not, then thank you so much, Dr. Katuria. Thank you for a nice overview of the basic immunological mechanism. With that, we will move to the second lecture, which I told you that is very, very important that we get the good allergens basically. So for that, I will invite Dr. Naveen Arora, who is going to tell us about the standardization of the allergen. Dr. Naveen Arora is the emeritus scientist in IGIB, which is the ICMR, and he has done a lot of work on the basic of the allergy and immunotherapy, and he is the one of the part of our whole workshops which we are doing all over the country. Dr. Naveen Arora, please.
Yeah, thank you very much for the introduction. And I will thank the organizer for inviting me here to talk about some of the work which we are trying to look at it. Initially, what I'm going to say is, whenever you're talking about allergy, what you require is the allergens. And they are the ones which are required for your diagnosis and a therapy. And because they are all have to be collected either from the environment, or they have to be made in the lab. So these have to be very, very well defined proteins and well defined allergens has to be present in this one. And here I'll give you some of the flavors, how to standardize these allergens, how to know the allergens which you have it, they are going to have a good quality or not. So with this, actually, I'll start my talk with this one. So what are allergen extracts? They are usually the complex heterogeneous mixtures of allergenic and non-allergenic components, and there has to be needs standardization to have a good potency, so that they are similar from one batch to the other. And these extracts should contain both the major and the minor allergens, and is required for both diagnostics and immunotherapy. What are the sources of allergen? When you look at, they are the diverse sources. It's from pollen, different kinds, from fungi, the mites, the insects, the animal derived, the foods. And foods are becoming very important nowadays. What are the steps which we take it for the standardization? Is usually we collect the material and we process the raw material. And this processing is very important. We prepare the extract. We look at the biological potency by in vitro methods or by in vivo methods, either of them or both of them. Or what are the units we use for the standardization in the national and the international scenarios, and that how the standardization has to be done in that manner. When you look at the collection and processing, see, this pollen has to be first identified at a species level. Once you have the pollen, they are collected during the peak season, because every plant has its own environment, and how does it grow, how it flowers, that is how it has to be taken care of. After they are collected during either the natural shedding, or they have take the floral buds, or pollen can be collected through some of the vacuum collection methods which are there, if you have big forms of this one. They are processed either at room temperature or by a freeze drying method, which we say the freeze binding is the lyophilization, and we'll talk about this one in detail a little bit. Then they are purified. This is just like you sieve this material and you take out the pollen material and take out rest of the plant material. You look at the purity, and when it's 95% and above, what you have to use it for your making, either for the extract preparation of this one. And then they are stored at minus 20 degrees centigrade in the bottles. This is how to prepare the allergen extract. This is a single one slide. Usually how does the clinical persons do it, or the manufacturer does it. The buffer is usually the PBS, phosphatidylsaline. There are allergen extracts. They are either diluted 1:10 or 1:50 weight by volume. It can be an aqueous, it can be in glycerin, depends what do you require. It's you require for diagnosis or required for the immunotherapy. They are more stable, most of the allergen extract, if glycerin is present. When you say extraction time, it's different from place to place. Initially, it is intermittent. At 72 hours, people keep it at 4 degrees centigrade, and the intermittent shaking by hand. It can be continuous at 16 hours at 4 degrees centigrade, and continuous at 4 to 6 hours at, again at 4 degrees centigrade. Usually, 4 to 6 hours is sufficient for you taking out, 80% of the 90% of the protein extracts into the solution once you are putting it in the continuous manner. So all the companies have a different method of preparation in it, and there are a couple of 4 companies which are in India which are manufacturing these extracts. And after you extract the material, you clarify the material by centrifugation, and you dialyze it to remove some of the substances, or you can say irritants. You sterile it by filtering through 0.45 and then 0.22 micrometer membrane, and then you can store in liquid solutions or under aseptic conditions. When you look at the sterilization of allergen, this is actually one of the grass imperita where we have studied in the lab. So what we have done in here is, because this everything has to be collected from the nature. So once you collect it the nature, usually manufacturer, what does they do, completely dry this material at room temperature. So they keep it for the room temperature for a time, and it dries the material, and then they sieve it and then take out this one. So here we have used a different method of doing it. One is looking at, a freeze drying method, which I said ICA, and the other is to look at ICB, which is a room temperature method. The first panel shows the SDS page, the second panel shows the IG immunoblot. IG immunoblot is done with the patient sera, usually with the same extract which is there. So what do you do in here is, so ICA, which is the one which is extracted, the pollen were collected and they are lyophilized, and then pollen is taken out. In ICB, they are dried at room temperature and the pollen is sieved. And once you look at the SDS page, shows the number of protein bands in there. And what do you look at it here? See, ICA shows multiple protein bands, multiple components are there. When you look at ICB, which is, the material which have been dried at room temperature, it shows there are less number of bands when you extract the pollen. And what you look at, there are 4 manufacturers which we have taken the extracts from, and you can see they are very much similar to ICB, means they are all doing the same method of, purifying the pollens or processing the material at that point. And once you look at this is the SDS page, so looking at, many of these proteins which have been degraded, it shows. And most of the allergens which have been proteins have been degraded, and that is how you look at this one. And most of these proteins have been degraded, and they will be removed from the extract. This is the SDS page. SDS page, now here it is, immunoblot. It is looking at the patient scenario. It will tell you the allergen, how many allergens are there in the extract. When you look at the allergen extract, in this one, the ICA showed, multiple bands showing there are multiple allergenic proteins which are present. But when you look at ICB, there are, if you look at, only a couple of proteins bands which have been showing here, indicating that the material which have been processed, at freeze drying is usually better as compared to the one which is doing at room temperature. I think this is the same thing which we have done with the individual patient sera. Individual patient sera is, the one which was done is patient have been, the sera have been pooled, the last slide. Here actually you have only taken the individual patient sera and you look at, allergenic proteins. When you look at this, ICA, the freeze-dried extract shows you approximately 14 allergenic proteins, and this is approximately 16 patients. And when you look at, this is the NHS, this is a control which does not show any positivity here. When you look at the allergenic proteins with again the same patients, ICB which has been, the material has been dried at room temperature, you look at the protein number is 7. Looking at, you are losing many of the allergens when you are keeping your material at room temperature for a longer time. This is the in vitro studies we have done it earlier, and this is the study which shows in vivo. So we have done the skin tested the ICA and ICB, and this has been done at Vallabhbhai Patel Chest Institute itself, who is mostly the partner with our studies with the, and these have, the extract have been prepared and tested on 102 patients randomly. And what you can see is the ICA shows, 6 patients which are positive, and, ICB shows 3 patients which are positive. What does that indicate? Indicating that, once you have a good extract, you will have better positivity, and you will lose patients if your extract quality is not good in that manner. This is the potency which has been of the extract which have been done in the lab. What it shows, ICA, this is inhibition assay which has been done in vitro, and what it shows is, the one which is ICB, it shows 50% of inhibition at approximately 900 microgram, and the one which is ICA showed around 72 nanogram. What it shows is the extract which is dried, or the pollens which have been dried at room temperature has 10 times less activity in that. So coming to the fungal allergens, usually what they have done is, usually these fungal allergens, the cultures have been taken from IRI, either NCL Pune or the IMTech, or some people have their own in-house also at the same time. These can also be taken up by the purchase from ATCC or Central Bureau of this studies. So they are grown in a different kind of media around, between different temperatures depending on what kind of fungus it is, and it is for approximately for 2 to 3 weeks. You take the material, you kill the fungus, and then take out the material in that manner. This is the study I am showing you which have been published for Alternaria. How these different companies have made the same extract, and they have a different kind of a potency which is there. So what it shows is, these are the manufacturers. There are mostly, I think, US or Europe manufacturing companies. They have extracted it 1:10. You can look at the protein content when it has been taken up. What you do is, they differ between 0.03 milligram per ml to, you can say, 0.73 milligram per ml protein. So there is a lot of variation in the protein content. Carbohydrate content also varies. The main content is Alt-A1. Alt-A1 is the major allergen of Alternaria extract. And when you look at the quantity of this Alt-A1, it varies from 0.05 to 2.75. And relative potency also varies in a similar manner which is there. So what it shows, if the material is not good enough, even from a company which is there, you can say there is a lot of variation in this extract. So you have to take the material from a company which has a good sterilization method, and the material have a quality whenever you are testing and using for the therapy. At the same time, it is also recommended that from where you take the material, I think it is better to take the immunotherapy also from the same company. That will tell you the extracts are the same and have a same quality for the therapeutic part also the same. This is the similar kind of a slide which shows the number of protein bands, and again different companies. When you look at this, there are a number of protein bands differ from each and every company. Some of them extracted with aqueous, some after extracted with glycerin, and you can see, like Greer have a better profile showing better protein content as compared to the other. This is just shows the SDS page. So in summary, which is there, you can say fungal allergens, they are manufactured chemically, may have a different potency, and at the same time adding stabilizer as glycerol, or it somehow enhance the stability of this one. Similarly, insects, there are from different kinds. It's from the cockroach, housefly, mosquitoes, locust, moth. So these are some of the insects which because they all have to be collected from nature. So this is a study which have been done with cockroach allergens. Again, this is the reference extract which we have prepared it. we take all the cockroaches, and after giving them the treatment, we lyophilize them. And this lyophilized material was extracted, and it shows how does it look like. This is the reference extract for the adult, and nymph is the same, which is the children's of the cockroach. And you see there are lots of multiple bands which are there. These are the commercial extracts which you have, you buy it from the market. And you can see the differences between the extracts and the, the protein content at the same time, and the number of bands. Number of bands shows you, mostly how good they are or how many proteins are there. And this is this is a Western blot which shows the number of allergenic proteins. You can see there are multiple proteins and not many proteins in this one. Again, because these extracts were not stable, so we have tried to stabilize it. And the method of stabilization which we have done it, either we have used EACA. EACA is one of the protease inhibitor, or added sucrose to it, which is the same as glycerol, which is. And what it shows is, if you keep the extract at 4 degrees centigrade, there are things are little better. When you keep it at 25 degrees centigrade, 25 degrees, what I say is usually, these extracts have to be tested on the patient. Usually you keep it from the refrigerator and keep it for a longer time in the clinic, so that it can be used for the testing. And it has to be come to the room temperature before testing. So these, what it shows is, there are some of the protein bands has been gone. 4 is the formulation, where you have added some of the material, formulated material, and formulation is either adding these two, and WP is the wild without preservative. It's a now. So when you keep it, look at this one, 12 months. When you keep it 4 degrees centigrade, still you have little proteins. But when you look at 25 degrees, most of proteins have been degraded. So if you keep the extract for a longer time and use for the testing, they may not be good enough for the test. And also, if you get the things from the therapy, if they are very old extracts, the things may not be good enough. So in summary, I'll say the cockroach allergens contains proteases, and these proteins can be degraded. Commercial extracts have some questionable stability, and stabilizer may enhance the stabilities. So it comes out to be, what are the units which have been used for these allergen extracts? When you look at, so there are different units we have been. Noon units is the one which is, I think the noon which started is 1900 or so. They are usually obsolete. Weight by volume is the one which is used worldwide. In India also it is using mostly weight by volume at this moment. There is a PNU method. We look at the the protein nitrogen unit. This is also worldwide. AU is the one allergy unit. USA is the skin test to the endpoint. And BU is the biological unit. Again, skin test relative to the histamine. It's from the European and the Nordic countries. And IU, what we say, is the international unit as per the WHO. So we'll talk about each and everything here in the allergy unit is the one which is used in the US. And this is what to do is, you test on 15 individuals, the same extract. And whenever you give, this extract give you 9 to 11 millimeter of the reaction, what we say is 1000 AU. So these 15 patients are usually positive patients, and 11 to 13 give you 10,000, and 13 to 15 give you around 100,000 AU. So what it means is, so if you have, 15 patients, mean value is 12.9, it comes to be 100,000 AU, and 13.1 it comes out to be 10,000, and here it comes to be 100,000 AU. So what it shows is, these are the units which have been defined, which is there. But when you look at the 12.9 and 13.1, it is not much of a difference. So we have to have a question in that way, which is there. So we have to have different methods of doing it. Similarly, when you look at the BU or bioequivalent allergy units, here also it is tested in 15 to 20 patients. Here actually they look at the D50, which gives you 14 millimeter diameter, which gives 14 millimeter diameter, gives to be 100,000 BAU. So again, these are also done on a positive patients, and again, looking at 100,000 units, you back calculate and then try to look at what are the extract units. Usually these units are very well, when you're giving for the immunotherapy, they are very much important in that manner. So standardization of allergens, when it is done, usually it is done by in vivo, either by in vitro. When you say in vitro, it is RAST or ELISA or Behring specific IgE, again with the purified allergen or also with the the allergen extract. When you look at the skin prick test or random screening of this batch has been done, also looked at the by in vivo method for the allergen standardization. When you look at the allergen standardization in US and Europe, there are different methods which are doing it. In standardized allergen extracts, when you look at this one, they are already known allergen standardized and some are in the pipeline. When you look at the European system, it is an in-house reference. They make an in-house reference and they test it every batch with the same in-house material testing patient. In India, actually, it is under the control of the CDSCO and still we have a question mark, but usually it is 1:50 or weight by volume is the one which people look at the standardization here. So these are the US, these are the ones which you can say the standardized extracts which are approved by the FDA and these are available, you can purchase them from FDA. These are under some of the license which are there or they are the candidates which are extract for the standardization. But you look at the scenario actually in India being a tropical country, there are multiple pollens and multiple pollens are there. When you look at the the Europe and the US, the number of pollens and the number of other extracts are reduced in that manner. So these are some of the other allergen extracts which are available. I think the one which is in the market which are purchased. In Europe, how do they do it is you take a raw material, you document the primary material, the purification, how they do it, and then you make an in-house reference, start looking at the carbohydrate, lipids, protein, and allergenic composition and major allergen content. So once you got a new material, they compare the same thing with a similar type of methods, looking at this documentation itself, and then they look at the subsequent batches, if they are comparable to it or not. Actually, this is a study which have been done in Europe, what we say is a CREATE, and what they have used is to standardize some of the pollen material or house dust material using at purified proteins which are present in the purified allergens which are there. So BET-V1 is the purified allergen with the birch pollen, FILP1 is from the timothy grass, Oli1 from olive pollen, and house dust mite, DERP1 and DERF1 and 2. There are two kinds of house dust mite which are prevalent usually. So they look at these purified allergens and then they look at how extracts are good enough or not. In India, when you look at it, is still what we say is the weight by volume, but we have some IgE binding proteins for the allergens prevalent in India. And these are the sum of the allergens, pollens allergens which have been studied either at Patel Chest or Institute of Genomics at IGIB or in other places in India. And you will find a lot of allergens and looking at what are the important allergenic proteins which have been identified in those. That is for pollen. This is for some of the fungi which have been studied and some of the allergen extracts which have been studied with also with the insects and wheat dust. So in summary, diagnosis and immunotherapy depends on the allergen extract. Standardized allergen extracts will give you a better treatment or diagnosis methods. India lacks the FDA-like system. It requires allergen quality certification. Allergen manufacturers require multiple experts, usually botanists, taxonomists, entomologists, mycologists, pathologists to get the material and also to prepare the material for this one. Standardization of the quality depends on each and every manufacturer, how they do it and how they get the material. And immunotherapy regimen should be from the same manufacturer which have been used for the diagnosis, because it should be the same. Because let's say if the insect which you are taking it out, it should be the same insect. It should not be a different insect, because if there are different entomologists which are looking at the material, you will get a different material. With this, I think, thank you for your patient hearing. If you have any query, I'll happy to answer.
Thank you, Dr. Naveen. So if there are any query, any questions, any comments anybody wants to make, they are welcome. So thank you, Dr. Nabin. The message is very clear that if the standardized reagents are taken, the results are very good. And whatever you do, when you do the allergens for the diagnostic purpose, I think the message in the last line was given, the same allergen should be used for the immunotherapy also. And with that, I thank Dr. Naveen. And now it's very important taking the history basically. So how to take the history is very, very important, which in the beginning only I told you. Not only for the allergy, for any branch of the medicine you are. So here, slightly different. You have to become a detective, I think. And then you have to sit down, spend some time. And twice history is very, very important. In the initial phase, you take the history. When you decide about doing the test, you have done the test, the results are in front of you. Then you take the rehistory, revisit the history. Because you need to correlate with the test result and the history. So twice the history is very, very important. So for that, I will invite Dr. Professor Rajendra Prasad. I think here everybody knows about him. And most of the people are from this place only. So Dr. Rajendra Prasad has been the past president of all the societies I think we have in our country. Let it be ICS, let it be NCCP, let it be allergy, let it be broncho, let it be tuberculosis. And he has worked at this institute, then CEPI, and of course at Vallabhbhai Patel Chess Institute as a director. And in his tenure, we were the people who were there with him, and we learned many things from him. And I think if I start telling about Dr. Rajendra Prasad, and I am happy today to see three stalwarts, Dr. Rajendra Prasad, Dr. V.K. Jain, and Dr. Kathuria from this institute. So it's a memorable moment. And today only I came to know Dr. V.K. Jain is the senior of Dr. Rajendra Prasad. Sir, please continue.
Good morning. Thank you, Professor Rajkumar, and other dignitaries sitting on the dais. Some of my senior and many of our junior colleagues are sitting. Actually, my job has been made very simple, first by Dr. Naveen Arora and Dr. Kathuria, and he's my class fellow, let me tell him. And then what Dr. Rajkumar has introduced, my job has been made more simpler. Rather, my message, what I wanted to communicate, he has already communicated. Thank you, Dr. Rajkumar. I know Professor Rajkumar, who is a director of this place. We have a very long association, and whenever he used to come to KGMC when I was head of department, I always praised him. Because I have seen him working in Patel Chess. Luckily, I was probably instrumental in all the promotions in Patel Chess. So I have known him very closely. And then I worked, as he said, I worked as a director for 3 years, literally, in that institute. And he was one of my rather very close associate as a director. You know, director जब कहीं का होता है इंसान, हिंदी सब लोग समझते हैं, हाथ उठाओ, ठीक है, वेरी गुड. हमें लखनऊ है, तो वे 2, 4, 10 आदमियों को ढूंढता ना, सब काम डायरेक्टर थोड़ा कर लेगा. So he is one of my pillars there. Let me confess and let me say very clearly. My job is to make about what is the clinical issues in the diagnosis of. Before that, I think 4 or 5 people I can recognize are from this institute, and many of the students might be there, but I don't recognize. कुशवाहा साहब बैठे हमारे, V.K. Jain साहब हैं, कथूरिया हैं. We are from KGMC. And you must have heard in news that Professor Halim, who was around 95 years, he was our teacher. And he expired about 2 days back, at the age of 95 years.
I'll show you some more photograph because I'm paying tribute to him. He came as my own batch Golden Jubilee when we celebrated in 2022, about 3 years back. He was the chief guest. Rule in KGMC is the अब बच्चे लोग भूलते जा रहे हैं सब नियम. तो रूल है कि जो सीनियर मोस्ट टीचर होगा लखनऊ में वहाँ अवेलेबल होगा तो उसी को चीफ गेस्ट बनाया जाता. That's why he was. We are all sitting. This is Vice Chancellor sitting at that time, and then we have interacted. And I may inform you another thing. I was very lucky that I'm making a video series literally as an encounter with my teacher, and I was very lucky. I have included him as one of the teacher, because apart from teacher, he is a teacher par excellence, I must say. दोनों हाथ से डायग्राम बनाते थे, रंगीन चाक से डायग्राम बनाते थे. ब्रेन हम लोगों को पढ़ाते थे, शायद जैन साहब को याद आ रहा होगा. कुछ भी समझ में नहीं आता जब फर्स्ट ईयर में आए थे 1970. He was such a great teacher. And then not only as teacher, I have worked with him in TG hostel where he was warden, I was assistant warden, and finally I became warden for a very long years. So I have learned a lot from this person, not as a teaching, not as an oration, but as an administration also. Because when you work with such a great guys. So tribute to him, I must say, and so I'll come to my lecture. Timer लगा भाई कुछ? नहीं लगा है. कहाँ गए इनके? भाई बता देना भाई राजकुमार, प्लीज. बस मुझे बता देना, क्योंकि मैंने कहा था भाई टाइमर लगाओ. So I would again use 2-3 minutes. I'll start with, who was William Osler? William Osler was a main person who introduced clinical medicine in the world. And he says a doctor is a student till his death. When he fails to be a student, he dies. What we are doing today? पढ़ तो रहे हैं ना हम लोग, हमने भी पढ़ा आपके साथ, ऐसी बात नहीं है. So let me say, I was in Japan long back in 89, and I learned there one thing, that better than 1,000 days of diligent study is one day with great teacher. I'm not saying that I'm a great teacher yet, but I said these words for my own mentors. इसमें हलीम साहब की फोटो नहीं है, हलीम साहब भी इसमें हैं, लेकिन वो दूसरी स्लाइड में है. खन्ना साहब, अग्नोत्री साहब, जो लोग केजी के पढ़े हैं, उनका डर, उनका वो टेरर शायद अभी भी लोगों को याद होगा. So they all because what I am today because of these mentors. So, and my objective for maybe for 12-13 minutes, it is rest to me, is what is the relevance of history and physical examination. And history is a very important, I used to tell you. One of the publication I'm going to show you that I noticed a complaint of patients, खासकर यंगर जनरेशन के लिए. डॉक्टर साहब ने कुछ बात ही नहीं करी, सीधा सीटी दिखाता है तो और दवाई लिखता है. So history is very important, and it is published element that about 88% of the diagnosis, you see, if you read the second line, in a primary care were established at the end of brief but good history. And you know what do you mean by good history. So, जहाँ तक एलर्जी का सवाल है, मैं ये बताना चाहता हूँ, एलर्जी ऐसा कॉमन है. कल ही मैं कहीं बोल रहा था, चाहे इनके प्री प्रेस में बोल रहा था, मैंने कहा अल्लाह की मर्जी प्रेस वालों को बहुत पसंद आया. समझ गए कि तो अल्लाह की मर्जी तो है ही है, जो है तो अल्लाह की मर्जी से तो हर चीज़ होती है. लेकिन मैं ये दिखाना चाहता हूँ, ये हम ही लोगों की स्टडी है कि हर तरह का डॉक्टर एलर्जी वर्ड यूज़ करता है, एलर्जी टेस्ट एडवाइस करता है. उसको एलर्जी डिजीज़ है नहीं, वो तो एक अलग इशू है. एंड ये हम लोगों की कॉलेज में जब मैं KGMC में तभी स्टडी करी थी, जितने लोग एलर्जी के लिए रेफ़र होते हैं उसके आधे से कम ही लोग एलर्जी के हकदार होते हैं, उनकी नीड है उनको. व्हाट आई एम ट्राइंग टू से, एलर्जी तो हमारे ख्याल से कतूरिया साहब मैंने बता दिया, हमारे क्लास फेलो, इन्होंने बहुत अच्छी थी. इनके तो ब्रेन और ब्लड में जो है एलर्जी फंसी हुई है. क्यों भाई कतूरिया साहब, मैं सही कह रहा हूँ. ही इज वन ऑफ द लीडिंग एलर्जिस्ट ऑफ दिस कंट्री. एंड so I'll not define allergy, but another word I always say is the word is used, atopy. Many times a person is atopic. Atopy means the predisposition to get type 1 allergic disorder. Literally this means atopy. It means in such individual serum Ig might be raised, not always. So there are newer definition, I think many people must have dealt it, but I'll not. And you know what are the various allergic diseases? And starting from asthma and rhinitis, although it can involve any system, that's why we say why allergy clinics are established in many institutions into the department of pulmonary or respiratory medicine, because nasobronchial allergy is one of the major allergic focus. क्या है यार, कौन सा स्लाइड आ गई भाई? सो अगेन ये वही स्लाइड डाली है चारू, क्या दूसरी स्लाइड है? वही है, चलो अच्छा. Commonest type of allergen, when you talk of allergy, you must have heard just now what are the allergens. And common allergens are insects, mites, dust, pollens. These are the common in India. Another thing, as an allergist, if you want to practice allergy, you have to know the pollen calendar. In our time, there is nothing like a book, nothing like a pollen calendar, but very good thing that today we have all books written by many people. So you have not to mug up, but pollen calendar I say, because in the history, usually I say I saw this photograph. ये नीम का पेड़ हमारे वो जो पेरेंट विभाग है दूसरा वाला, उसके सामने आउटडोर के नीचे है. तो मैं अक्सर पीजी को यही पढ़ाता था पहले. कुशवाहा साहब हंस रहे हैं, शायद इनको भी पढ़ाया होगा उस टाइम, कि क्या पेड़ है ये. तो दिस इज ए पेड़ ऑफ नीम. एज ए डायरेक्टर इनके एंटीजन में था, रोज टेस्ट करते थे, लेकिन ज्ञान तो मैंने. आप देखिए ये सफ़ेद सफ़ेद फूल दिख रहे हैं, यानी पॉलन इसी टाइम निकलेगा. और ये किस महीने में फोटो लिया गया? अप्रैल के महीने में. तो इसकी माने पॉलन कैलेंडर इसका मार्च अप्रैल वाला सीजन होगा. So that is how you can recognize fauna and flora around you, and you see that when it flowers, and that becomes a pollen calendar. तो कोई बहुत रटने की जरूरत नहीं है. I'll skip. And diagnosis के लिए सबको पता है, history is a very important, and then there are investigations. I'll not cover them. So clinical diagnosis, again I say, is a very important. And clinical means history and physical exam. ये गायब हो रहा धीरे धीरे हमारे मेडिकल उससे गायब हो रहा. कई मरीज कहते थे डॉक्टर साहब ने आला ही नहीं लगाया था, देखा ही नहीं. अभी कल मेरे को एक लड़की हमारे एरा में देख रहे थे, मरीज अस्थमा का, वो बोला क्रेफ्ट है. तो मुझे मजबूर होकर देखना पड़ा. हमने कहा भाई तुम या तो तुम रंग का ही नहीं पहचानते हो हैं. हो सकता है अस्थमा में भी क्रैप्स हो सकते हैं, लेकिन चांसेस दैट ही वुड बी रॉन्ग. तो पहचानना चाहिए हिस्ट्री और फिजिकल एग्जामिनेशन. दैट्स व्हाई आई पुट नाउ पीपल आर calling me YouTuber, because one of the lecture was history, and this was on the demand of my old student जिनको हम लोगों ने पढ़ाया इतने सालों में. And so history, what I am trying to say is, nobody can doubt about the role of history in diagnosis any disease, particularly in allergy. What is the objective when we take history? First objective is whether patient has allergic disease or not. That is very important issue. And then it also discovers the underlying causes. So दो aim है. How you find that somebody may suffer from asthma, it may not be allergic. Somebody may suffer from rhinitis, it may not be allergic. But how you find out from the history, yes, this phenomena could be allergic. And that is, I usually say, the onset, usually allergic diseases starts from childhood. Usually there may be positive family history of allergy. यूजली देयर आर कॉम्बिनेशन ऑफ सिम्टम. आपने देखा होगा एस्थमा के मरीज को राइनाइटिस भी होती है, तो कॉम्बिनेशन एक्जिमा भी हो सकता है. And then seasonal variation, I have shown you the pollen calendar, and then finally geographical variation. Many times you must have seen the patient कि साहब मैं लखनऊ में रहता हूँ, मैं ठीक रहता हूँ, जैसे ही बेंगलोर जाता हूँ नागेंद्र प्रसाद जी के शहर में तो मुझे छींकें आनी शुरू हो जाती है. बेंगलोर का दूसरा नाम ही है सिटी ऑफ एलर्जी, इफ आई रिमेंबर करेक्टली. सो दिस इज जियोग्राफिकल. Symptoms will not differ from Lucknow, Kanpur, Delhi because same geography. Symptom will differ from different geography. So that is geographical. So these things you are finding in the history, chances are that you are dealing with an allergic patient. History, again, I will not go into much detail, but chief complaints, always हम पूछते हैं, रोज डांट पड़ती है पीजी लोगों की, क्या chief complaint है, duration बताओ. That is very important issue. Duration of illness, then details of chief complaints. Usually chief complaints will be somewhere around the disease, cough, breathlessness, rhinitis, rhinorrhea. So all those things, skin rashes. When symptom occur, that is also very important. It may be seasonal, pollen may be important, perennial. There are house dust mite, animal dander, mold, cockroaches may be important. Irregular, it may be perennial, we'll see. So everything you have to find in detail. Time and day of location where person gets a problem, that may also hint something to you. And then what are the precipitating, how these symptoms precipitate, that actually gives you the idea what are the underlying causes. That is very important. So you have to go into details. I always say the case sheet of allergic patients are quite different in every institute. So you have to, here also must be a different, it's not like a simple case sheet. So that's why we make it. And then asthma control, treatment issues, बहुत हम लोग हमारे एक YouTube में बड़ा कॉमन है कि क्या ट्रीटमेंट लिया, उसका क्या रिस्पांस आया, कोई एडवर्स ड्रग रिएक्शन तो नहीं हुआ. ये जानना बहुत जरूरी है. आदमी इलाज पूछ लेता, आगे कुछ नहीं पूछता. तो दैट विल गिव यू हिस्ट्री. अगर उसने एंटी एलर्जिक छींके या एंटी एलर्जिक लिया तो इसके माने ये चांस हो सकता है इसमें एलर्जी का रोल हो. असेसमेंट, सो thorough environmental history is also very important. Assessment of impact of illness, that is also very important. How it is affecting the life of an individual, that is the impact of illness. Past history, हमारे स्टूडेंट्स में एक आदत पड़ी है, हम अक्सर कहते हैं past history is not significant. ये एक तकिया कलाम बना हुआ है. तो मैं कभी कभी पूछता हूँ कि क्या तुमने पूछा जो कह रहे हो past history is not significant. So you have to be well versed. A particular situation, in a particular symptom, in a particular day, what past history could be very important. That is the meaning of a past history. So past history में जैसे आज अस्थमा वो बता रहा है और बचपन में बता रहा है मुझे साहब एक्जिमा हुआ था, स्किन की बीमारी हुई थी, तो आप कोरिलेट करेंगे ना उससे. Yes, this person may be a topic and today he is presenting as asthma and maybe in childhood he suffered from other allergic disease. So those things what I am, family history I said is not necessary that family history must be positive, but you see this study shows that 30% if one parent, a sibling is a topic, 50% chance if both parents are a topic, 13% maybe that none of them are a topic. So history में family पूछते जरूर हैं, लेकिन बहुत ज़्यादा अपनी जान देने की ज़रूरत नहीं है. कभी कभी नेगेटिव भी होता है, लेकिन मोस्ट ऑफ द टाइम पॉजिटिव होगा, ये मैं कहना चाहता हूँ. उसकी पर्सनल हिस्ट्री, क्या करता है, कैसे रहता है, क्या खाता है. So everything is important. That may lead to you. Then after a very exhaustive history, I usually say that you have to act what Dr. Rajkumar has already narrated, that you have to act like a CBI detective. आजकल CBI और AD का जमाना है? भगवान न करे किसी को हम में से कोई आवे, हैं? कुशवाहा साहब बैठे हैं, इनको सीबीआई के नाम पर मुझे याद आया, लेकिन मैं सुनाऊंगा, बहुत लंबी कहानी हो जाएगी। जब मैं शायद पटेल चेस फहीम थे, उन्होंने फ़ोन किया, सर वो सीबीआई वाले, हमने क्यों आए? बोले साहब वो दवाई आई थी उसके लिए आए हैं। हमने दवाई दिखा दो ना, तो सारा तो केसेस बनाए हो, सारा तो रिकॉर्ड रख। तो वो डॉक्टरों को एक मैसेज है, जो करो उसका रिकॉर्ड रखो, बहुत ज़रूरी है। सो फिजिकल एग्जामिनेशन विल डन ऑन, एक मैं हिंट यहाँ देना चाहता हूँ, अस्थमा का मरीज है, हिस्ट्री दे रहा है, आपने आला लगाया, नॉर्मल निकला, हो सकता है वो रेमिशन में हो भाई, उसको अर्टिकेरिया ना हो उस टाइम, हिस्ट्री तो दे रहा। सो दैट यू हैव टू ऑलवेज कीप इन योर माइंड। ये फिजिकल एग्जामिनेशन के बहुत लेक्चर, आजकल लोग करते नहीं, जानते भी नहीं। हमारे ख्याल से हमारा 1.5 घंटा का लेक्चर है एम्स पटना में, और इंडियन गाइडलाइन है डायग्नोसिस की एलर्जी के लिए, जिसमें हम सब, राजकुमार साहब, बहुत जितने लोग यहाँ बैठे हैं सभी पार्ट थे, that has been published. And so I have come to end of my presentation. Take home messages. There are 2-3 more slides I have. Value of good history is undebatable, I always say. बिना हिस्ट्री लिए कोई चारा नहीं है, चाहे एलर्जी हो चाहे और कोई बीमारी हो. Needs good amount of time for complete walk-up. ये भी बता दिया. Careful history discovers the underlying cause. हिस्ट्री तो ऐसे मरीज जब हमारे क्लिनिक में, आपकी क्लिनिक में इंटर करता है, पता लग जाता है अस्थमा का मरीज है, राइनाइटिस का है, स्किन का है, इसको एलर्जी. लेकिन वो जो हिस्ट्री हम जो स्पेंड करते हैं वो that discovers the underlying causes. So I say it is etiological history. You find why this is happening. So what is etiological, you have to spend time. ये बड़ा clear है. Clinical history also guides which allergen to be used for testing. अभी कल मेरे पास कोई आया, नाम नहीं लूंगा, 150 की लिस्ट लेके आया था. आलू, चावल, धनिया, क्या क्या, जीरा, सब. हमने कहा ये क्या लिस्ट लाए हो? हम लोग तो 10, 15, 20 से कराते हैं. And that is depend on the history. What do you suspect? So, this point is very important. Clinical history also guides the allergen to be tested. So you can prune down those testing. Clinical history also, and then clinical history also guides interpretation for skin and lab test. अभी राजकुमार साहब ने कहा, I like to repeat, सिर्फ टेस्ट से ही काम नहीं बनेगा, आपको उसको हिस्ट्री से कोरिलेट करना है, तब आपका सही आपको ज्ञान होगा. नॉलेज ऑफ एरोबायोलॉजी, एबी सिंह साहब अभी आएंगे, आए नहीं, आएंगे. तो एबी सिंह साहब का मैं दूसरा नाम उनके एब्सेंस में बता देता हूँ. उनका नाम ऐसे तो एबी सिंह है. हम लोग साथ केजी में ही पढ़े थे. यहाँ वो पीएचडी के लिए आए थे with our great teachers. So his another name I used to say is aerobiologist Singh. He's a master of aerobiology. अभी आएंगे, आपसे बात होगी, मुलाकात. So knowledge of aerobiology is very important and must correlate skin or lab test. जैसे लोग कहते हैं स्पेसिफिक आईजी करा लिया तो बस वो गोल्ड स्टैंडर्ड कुछ नहीं है. You have to everything put together and then you have to find out what is the culprit. So that's even if you see that clinical history is strength of recommendation, evidence based आज के हम बात करते हैं, is very strong. And although the certainty of evidence is little low, but it's a very strong. So my take home message finally is an adequate clinical history and physical examination is very important for diagnosis of allergic disorder, especially since we are pulmonologists, to respiratory allergic disorders. So I have even some of you are interested. I have even this lecture on this. We have a book on clinical allergy, जिसमें सभी लोग author हैं जो सामने बैठे हुए हैं. और सबसे बड़ी खुशी की बात है, इसका second volume, second edition अभी भी आया है, which will be released possibly in the evening. And then what made me YouTuber is this lecture on X-ray, which was simply taken in error, and that was put in YouTube, and probably more than 4 lakh people have already seen that YouTube. तब से मुझे लोग YouTuber कहने लगे. Although I'm not a YouTuber, I'm a teacher basically. So, and there's a book also. So I would like to end my 2-3 slides. क्योंकि अब हम कहते हैं अब हम लोग सिर्फ अब टीचर नहीं रहे, अब हम मेंटर हो गए हैं. हमारे मेंटर थे, अब हम भी मेंटरिंग करते हैं. तो ऐसे हृदय में पवित्रता हो, मन में स्पष्टता हो, क्लैरिटी हो, और कर्म में ईमानदारी हो, काम सही से करो, तो और संतोष खुशियों की. मैंने एक लेक्चर लिया, उसी से मैंने स्लाइड लिया, हैप्पीनेस पे मेरे को किसी ने कहा बोलने को, तो मैंने ये स्लाइड वहाँ यूज़ किया था. एंड आई ऑलवेज से एजुकेशन keeps you young and relevant. That's why anyone who keeps learning, I say, stays young. देखिए हमारे जैन साहब हैं, हमसे 3 साल सीनियर हैं. मेरे को थकान लग जाती कभी कभी, ये देखते हैं घूमते ही रहते. तो क्यों? बिकॉज ही इज़ ए गुड रीडर. बहुत पढ़ते हैं, मुझे पता है. हमको भी मार डांट के उन्होंने खूब पढ़ाया था जब हम पीजी थे, समझ गए. So anyone who keeps learning stays young. That's why I say in end of my presentation, in the thank you slide, I am still learning. So with this word, thank you very much.
Thank you, sir. Thank
for
you
very
so much.
patient listening.
If anybody wants to ask anything to Dr. Anand Prashad. If not, thank you so much, sir. Thank you very much for this. So the message is very, very clear that whenever you are taking the history, then you need to go in detail about the history, one. Second is for preparation, basically you have taken the history, you have decided that you are going to do the test. So now the test allergens has to be taken care basically. You cannot test with 200 allergens and everything. You have to decide it, which are the allergens to be tested. So during the history only, you need to prepare your mind that what are the allergen to which I am going to test. Suppose I am giving an example. A person has a rhinitis and the history is पूरे साल भर प्रॉब्लम रहती है. ओके अगर साल भर प्रॉब्लम रहती है और घर में जैसे जाता हूँ, whenever I go to the home, the problem increases. Means it's a perennial and indoor. तो इसमें चेंज ऑफ सीजन में कोई प्रॉब्लम नहीं होती, मार्च अप्रैल में कोई प्रॉब्लम नहीं होती. सो फॉर दैट पर्टिकुलर पेशेंट हु हैज़ ए इंडोर प्रॉब्लम, पेरिनियल प्रॉब्लम, सो द कल्प्रिट इज द पर्सन, द एलर्जन विच इज सिटिंग एट द होम. इंडोर एलर्जेंस. सो व्हाट आर द इंडोर एलर्जेंस? हाउस डस्ट माइट हो गया, इंसेक्ट्स हो गए. सो टेस्ट विथ दैट ओनली, नो पॉइंट टेस्टिंग द एलर्जेंस. So this is very, very important. So when you have gone through the history and everything, then you have decided now that I am going to do the allergy testing. So now I told you that in the beginning that there are 2 types of the testing has to be done. One in vivo and in vitro. So we have Dr. V.K. Jain who is going to tell us about the in vivo testing. It's a very, very important testing. And Dr. V.K. Jain, everybody knows he is product from this place only. And he had been the head of the department at Jaipur and then Udaipur and Jodhpur also. And everybody knows Bikaner. And everybody knows about him. He is the one of the stalwart, and the best part of his whatever career, academic career and education career and everything, he is a very simple, great human being. Down to earth person. You may not be knowing he travels by the bus also sometimes whenever there is needed. Nobody I have found out till my career that at his stage the person travels with the bus. So all the regards. Sir, मुझे पता है इसीलिए मैं बोल रहा हूँ सर. So sir, with that words I will
thank you Dr. Rajkumar for introducing me and appreciating me. I am also thankful Dr. Rajan Prasad, my house surgeon, for too much appreciating me. I am not an actor. I will just start my lecture not showing my photographs and showing all my achievements. but I'm very happy when he was the house surgeon. He was very simple person, very simple, not the actor. Now you can see how he is acting. He presented his lecture, so very thought-provoking. The clinical lecture. I don't know how many people knows the definition of clinic, clinician, clinical research. I think whatever you are doing, a doctor who is a very good opportunity to work directly to have a contact. Whatever he is doing in the clinic, he is a clinician. The first contact of the culprit or the patient is in the clinic and he report. जैसे कोई culprit होता है तो थाने में रिपोर्ट करता है, तो वो हॉस्पिटल और ओपीडी में रिपोर्ट करता है और वहाँ थानेदार होता है, वो सब उसको बताता है अपनी पीड़ा को. और उसके बाद so I'll be taking the investigation part, especially the allergy testing in vivo, where you do whatever in the with the patients. All investigation directly you put on the surface of the person or patient. That's a vivo testing. And vivo testing is very important because it is a mid part. After having a detailed, wonderful scene, we plan for investigations. Because this is the part where we can further manage the treatment or the management of the disease. So without investigations, it's not possible. Absolutely, we are not dependent on clinical part. So I'll be dealing. So diagnosis of allergy in vivo, mainly I will be emphasizing on the skin part. We all know the allergic diseases are most common clinical problem in day-to-day practice globally. The type 1 IgE mediated, and we know all the allergic rhinitis, asthma, rhinoconjunctivitis, dermatitis, food allergies, all are allergic diseases. So in day-to-day practice, so after taking a detailed clinical history, we further move to the investigation, routine investigation, blood and all these things. So clinical history, the vivo testing, the skin test. Basically, skin test is also a provocating or challenge test. When you provocate or challenge, the skin is a provocative. Other provocative is conjunctival, nasal, bronchial, oral. So either you put the allergen over the skin or in the mucosa. So these are basically the provocation tests. So, but separately we are mentioning the skin test, and skin test is also just call it as also a skin provocating test. Vitro test, the next speaker, Dr. Naveen Arora, will take these are the different references where I have taken my subject in different references, guidelines available. The recently Indian guidelines for diagnosis of respiratory clinical part and the investigating part and also treatment part. This came from the Patel Chest under the chairmanship of Dr. Rajkumar, and I was one of the experts on this clinical guideline. Coming directly to the skin test or the what we call also the hysterical, if you go in 1867, the Blackley was the first person who tried for placing the pollen grain extract on the own skin, abraded skin, and find and who was having allergic symptoms and having some reaction also. Later, the tuberculin cutaneous test, which is now the Montu test, these all are the important. Basically the skin tests are useful to rule out the immediate or type 1 Ig mediated type, and also we can detect the delayed Arthur's reaction type 3 as our Dr. Kathuria told, and delayed type of. These skin tests are rapid, very sensitive, specific, cost effective, reliable, reproducible and easy to perform. But it should be always performed by a trained person and should have a standard extract And we can divide the testing for the therapy, diagnostic purpose, the therapeutic purpose, or the prognostic. The diagnostic is just to detect the IgE-mediated allergy or type 1. And we can do it in the symptomatic patients who are suspecting allergy disease to find out the IgE-mediated cause of allergy. And we can also do the in a asymptomatic person where we can only find out if it is positive, it only indicate that the person is hypersensitive but not having active symptom. So both the purpose we can do it, we can do it, we can find out the culprit, whether it is a pollen or the dust or the insects, all we can detect specific allergen hypersensitivity. We can also do, we can also use as a epidemiological purpose, research purpose, and to also standardize the allergen extract. Therapeutic, after knowing the culprit, we can also use allergen avoidance, specific allergen avoidance, and also we can, after knowing the, we can also use the allergen immunotherapy, which is very important after knowing the skin prick test. The prognostic is also there. We can also need the outcome of the allergen immunotherapy, whether it is improved by retesting. We can also do it whether other, if patient not responding to immunotherapy, we can also know whether the new allergen is also allergic, and also retesting whether our patient is improving or not. These are the different type of skin tests, the skin prick or puncture test, and that, so they are basically epicutaneous and intracutaneous. Epicutaneous is the skin prick test or puncture test, or, and the intradermal is the intracutaneous test, scratch test, patch test, prick to prick test. There are certain factors which can increase or decrease the flare up or reaction of skin depending upon the mast cells where you are testing, depending upon the site. The more important is forearm and the upper back. The age, the sensitivity is very poor in the older and the younger infants, usually below 3 to 4 years, because that's why we usually do not recommend allergy test routinely in below 4 years, unless it is for very specific region. It also depends on the whether skin is having some disease, eczema, dermatitis, certain disease, chronic renal failure, spinal injury, diabetes. They also decrease the sensitivity, the concentration and standardization of allergen extracts. The person using anti-inflammatory, anti-histaminic, and antidepressant drugs, seasonal reactivity also. We need certain prerequisite before going for the skin testing. The history is very important. The history of medication before treatment, during, the treatment part is very important. And we should always ensure the emergency facility before going for the allergy test, written consent. And we should always do the allergy test on normal skin. And we should always observe the symptom before doing testing, during and after allergy test, and we should always know what is the concentration we are using. They are the common, the most important is the usual site is bowler suspect or forearm, and we will be showing this detailed procedure while during the workshop, but very important, the distance of the skin prick test, the test, we can do it on the bowler aspect, forearm, and we can also do back or even the lateral aspect of the upper arm. Physician should always be there, trained person must be there. We must use the good quality of a lancet or even tuberculin syringe and into the minimum amount. The first generation and second generation, first generation at least we need 1 week if we are using the second generation, and 3-4 days for the first generation. And then if your patient is on antidepressant, at least minimum 1 week, or if the patient is on tricyclic antidepressant, the 3 weeks may be. The bronchodilators, adrenaline and corticosteroid short term doesn't affect, only 12 hours stoppage is sufficient. And whenever there is a grow hair which should be saved, also we must always use the positive and negative controls. These are the emergency kit, we always do it. I think everybody knows while we are managing the emergency. So never do the allergy test unless we are having these all facets. These are mandatory and also ethical also. So all the minor, I mean, so that you can manage the immediate systemic reaction. The skin prick test, which I will be going first, the skin prick or puncture test. What is puncture? What is skin prick test? Is the epicutaneous test, and most commonly used in the clinical practice, which detect the IG mediated. This test can be performed in any age, but however we do not recommend is in below 4 years routinely unless we need specifically. We usually avoid in the infants and the person who are very old or having diabetes, mellitus, neuropathy, malignancy, all these. As I said, the distance must be 2 to 3 centimeter, minimum 3 centimeter between two tests, and we should 5 centimeter away from the crease of the wrist and 3 centimeter below to the antecubital fossa, and we should use the histamine as a positive control and buffer cell as a negative control. Now there are two methods. One is the vertical, when we enter into the skin, that we call it the puncture test. It's a standard test where we put it in the drop and we put the needle at 90 degree. The other test is the horizontal or semi-horizontal, where we put the needle lancet at 45 to 60 degree, and the reading we usually do after 15 to 20 minutes. The cutoff point is the 3 millimeter. 3 millimeter and more is the cutoff point. We consider 3 meter. That should be more than of control. And these are the method. Initially you see the so you find this is the vertical method, directly puncturing the skin, and the other is we entering the horizontal or semi-horizontal. We just enter in the skin and slightly lift it, and then we do it. These are the all procedure. We will be showing all these things in the workshop. And these are the lancet. At least the good quality lancet should be less than 1 millimeter or 1 millimeter. And sometimes people are using the blood lancet, which is too much traumatic, usually causing more and more bleeding. So standard lancet should be used of good quality. And the diameter, usually we take it the vertical and horizontal. Mean diameter we consider. We should always consider the bleb, and we should also look the erythema of layer around the bleb. So these two things must be there. The more important, the diameter, which should be mean, and these are all diagrams which we are showing. But now, generally the Western people, they say if the diameter is 3 millimeter more than the control, understand, control is 0, and if it is 3 or more is considered to be positive. But suppose the control is 2 millimeter, so then 5 millimeter will be considered as a positive 2 plus. So these are grading. So in India we are also having grading, other countries also considering grading, but Western people, most of it, they say 3 points and more, 3 millimeter more is considered to be too positive. So this is the grading which will be telling the grading 1, 2 to 3 millimeter, less than 3 meter is grade 1 of that control, always 3 to 5 centimeter, grade 2, 6 to 8, grade 3, and then more than 8 millimeter grade 4. And we should also look for the pseudopodia. If the pseudopodia are there, we always increase the grading, more grade. It is highly sensitive and specific. So 80-90% specific sensitivity is more, and specificity is also ranging from 7 to 90%. The intradermal test I am nowadays also emphasizing, because the intradermal test is very important, because in routine practice residents are writing whenever they are doing the allergy, are doing and giving antibiotics or anesthesia, other thing. They write after sensitivity test. I think 99% resident and doctors are not knowing. Nursing staff, they instruct, they don't know. When the doctor is not knowing how to do the drug testing. So intradermal test, which I am nowadays more emphasizing, because this is more in clinical practice rather than doing only SPT for the allergy test. Was the allergy for drugs? So this test is, initially it was too much famous because the standard quality of skin prick test allergen X-ray were not available and they were very costly. In India also we were initially practicing routinely for allergy test, intradermal ID test. It needs more experience and it needs a more labor intensive, require precise technique, and intradermal test is 10,000 more sensitive than the, but however it is less specific, and indication is we should do it in the drug testings, antibiotics, anesthetics, and we also use for insect venom allergy. Useful when the patient is having lower sensitivity or not having positivity with SPT, when and there is a definite history of symptoms, and then we can also go for the this is also do when we are doing the retesting to know the progress of your immunotherapy. So this is very important, and I'll show you detail. I'll give you the information. So we use the 70% alcohol. So I'll give you the detail about how we do proceed for the intradermal test and what amount is already received. 0.1 to 0.2 ml, maximum 0.5 ml we can inject by tuberculin syringe of 26 gauge. So these are the vial which is available. Usually it is 1:500 weight volume. But if we are having, the person is having high sensitivity of skin, we can use the 5,000 dilution also. And when we are doing the house test mighty, we can sometimes use the 1:5,000 also. So concentration, which I have already said, and in this case is more sensitive, but however the more false positive results are there, but the only thing, the systemic reactions are more in the intradermal as compared to skin prick test, is highly more sensitive, and we can also detect the delayed type of hypersensitivity, Arthur's reaction or type 3 reaction. So that's why this is also useful. So grading is, again I will tell you in the workshop. The grading cutoff point is a 6 millimeter. If it is, and if you give a positivity, it should be more than 6 millimeter of the control also. So if the one double of the control is say 1 plus, triple for 2 plus, 4 times is the 3 plus, and we should also look for the pseudophagia. So we should look for the wheel, and we should also measure the erythema also. And these are the comparison with the prick versus intradermal test. I think the prick test is routinely done, is less, I mean this is less expensive and easy. We can do it even in the young person, children below even less than 1 year also. While we never recommend the intradermal test, and the intradermal test is slightly it gives more false positive, and the speed of the skin prick test is higher. If we want to do more than 40 tests at a time, we can prefer the prick test. If the intradermal, we don't do it at one sitting more than 30 to 40. So these are all important things. The patch test, I think will be taken by this is another to find out the delay type. Generally we do it in the type 1 also, and the delayed type of reaction, and we use the different patches, and we read the reading after 24 to 48 hours, and we see the reaction over it after removing the patch. So this we usually for contact dermatitis, metal reactions, and latex or dyes we are using. And these are the different, the provocation test. I'll not go in detail, but the start from conjunctival, nasal, bronchial. Nasal test will be taken how we should. Now routinely we can use in clinical practice the nasal provocation, but routinely bronchial or conjunctival test we are not doing routinely in clinical practice. But however, oral food or drug challenge tests we can use in the clinical practice. These are the different international and in our Indian guideline. recommend definitely the skin test, if properly performed, are the most convenient, least expensive screening method for detecting IgE specific reaction in allergic patient and preferred over in vitro test for diagnosis and research. So this is the first gold standard. However, we don't say the vitro test is also coming and will be taken up by the other person. So last but not least, the in vivo remains a cornerstone to detect the allergy. And remember, the skin test never tell the specific disease, very important. It only tells that person is having IgE mediated allergy. If patient is symptomatic, probably the cause. If patient is asymptomatic, I think he is only having IgE mediated hypersensitivity, not having the active disease. So remember, that's a very, it doesn't mean that asthma, by doing SPT will never tell that person is having asthma. This you have to correlate with the clinical symptoms, make your clinical diagnosis, and after some PFT and all this. So I end my talk. I'll not take much time. So thank you very much for patiently hearing. Good luck.
Thank you, Dr.
So if
VK
there is
Jain sir.
any
Thank you so
questions,
much.
so it will be better
If there are
because
any
we are,
questions, anybody
however,
wants
we are
to?
going late, so we will give all answer while we are having
Okay,
the,
okay.
we should have these
Okay,
things
okay.
to the students, so they will definitely come in the workshop.
Okay.
Thank you very much.
Okay, thank you so much. And then, the first part in vivo test has been dealt with. Now, many times, you see the patients coming with the test report, right? The market test reports that I am allergic to this, I am allergic to this and everything. And they want that you should interpret. So what is the role of in vitro test? Dr. Naveen is going to tell us, and I have already introduced him. So directly, Dr. Naveen, over to you for the in vitro test. What is the role, how it can be compared with the in vivo test, and of course, concluding remark, which is the best for the patient.
Thank you, Dr. Rajkumar. I think Professor VK Jain has made my life easier. At least he has told you what is in vivo. And now what we are looking at is in vitro. So we are now, instead of, having the patient in front of you, they'll give you the report, or somebody will take a report. Only basis of that they are either using the blood to get that report. So what is in vitro test which comes out to be? Okay. As I think allergy is an exaggerated immune response, and it's a type 1 hypersensitivity, as Dr. P.C. Kathuria has mentioned it at the same time, and it is caused by allergens. And by different allergens, what is happening in these allergens? There's a IgE which is high. So IgE is the one which is the hallmark for the allergic diseases. And IgE is the one which is, I think, discovered by two independent groups. It's Bennett and Johnson, and also in Ishizaka in 60s. It was named as, a new IgE antibody immunoglobulin in 1968, and it is, synthesized by a specific plasma cells, which Dr. P.C. Kathuria has also mentioned the same thing about it. When you look at IgE, which is there, it's a Y-shaped molecule. It has got two heavy chain and light chains. It is produced by the B cells, and it is under the control of the T cells, the producing of the IgE with different cytokines, and the biologic response is through the receptor, which is Fc epsilon receptor, which is present on the mast cells of the basophils. And this is a very important thing, which is the half-life of the IgE. When you look at the half-life of the IgE, it's the serum IgE or the cell-bound IgE. The IgE which is serum IgE, that is what we are looking in the in vitro test, and the IgE which is the cell-bound IgE, that is what we are looking at in the in vivo test. And Half-life of the Ig is 2 to 3 days in the serum, and it can go up to 12 weeks in the in vivo test when it is the cell-bound Ig. So up to 12 weeks, so this can be detected by SPT, the intradermal test, as Dr. V.K. Jain has mentioned, which is a cell-bound Ig which you're looking at. The serum Ig which you're looking at, it is detected in the blood, either by ELISA or looking at some of the mediators by other tests which we'll be talking about a little bit. When you look at the allergy diagnosis, it can be in vivo methods and in vitro methods. I think some of the methods have been just mentioned by Dr. V.K. Jain about the in vivo methods. But I'll be talking about the in vitro methods here. It can be serological testing, or it can be looking at the mediators. As Dr. V.K. Jain said, when you challenge the things, there's something different comes out to be there. So these are the different methods which we'll talk about it in slowly, and some of the we'll talk about the mediator results. When we are looking at in vivo and then in vitro looks only will tell you that the Ig is present. It is clinically relevant or not, I think in vivo will tell more about it. This is the first, I think the IgE in vitro methods by allergy diagnosis is, when you're looking at, it is looking at the specific IgE or total IgE or looking at the mediators. It is the option in the absence of the standardized extract. So if you don't have a standardized extract, which is there for the testing, like food allergy, you can do the in vitro test in that manner. One alternative method for without, the patient cannot discontinue some of the drugs. So this is how you can use the in vitro method, and the sensitivity range from, from 50 to 90% depending on what methods you are using it. So this is the principle of this. Whenever you're looking at IgE, you should take patient serum. You look at allergen which has been coated with the solid phase. You come up with a second antibody which is either labeled with the, with some color, the luminescence or some thing. So you put it at, and then you develop the color and look at the signal, and it can be read by different machines depending on what type of color you are looking at. This is mostly the principle is to look at the IgE which is bound to the specific allergen. This is the oldest method of the way that it has been detected. It is, as you can say, it's a very old one, 67 it started with. This is the same person, Bennett Johnson, who is one of the person who discovered IgE, but they named it in a different manner. It's a radioimmunoassay, and it looks only looking at the specific IgE. What does it do? It has a solid phase which is activated with cyanogen bromide. It is a chemical which goes and binds to allergen and then comes to the patient sera, the same principle which have been mentioned here. And the sensitivity is very high because I think the radioactivity is usually requires lots of issues. So that is why this method is usually people are not using it in current situation. 2 decades before people were using it. The other method is using by ELISA. Again, the principle here it is immunoabsorption. Solid phase allergens coated on it's a microtetra plate. Ig comes in the patient sera, binds to this allergen, come with the anti-Ig, look at put the substrate in there, you look at the color, and that's the advantage here is require a very small amount of the allergen, because when you're doing it in a plate, which is again 100 micro, means each test can be done in 100 microliter, and some of the tests even can be done in 20 microliter reactions. It can also show you some of the cross-reactivity. If this allergen is cross-reactive to some other allergens or not, it can also indicate that way. The limitations of this one, it gives you false positive results when it's a total Ig is very high. Total Ig can be higher with some of the helminth infections, as it has been mentioned earlier. And at the same time, if a patient have a high IgG antibody, what you will get is the lower results. So you have to be looked at these two important parameters. The other method is a immunocap. This is the one which is commercially available, which is there, which is Fadiatop and some of the other methods which you might have looked at, you might have been knowing about it. Here the solid phase is cellulose derivative, that's it. And it is something like a three-dimensional structure. That is why, because it's a material which is cellular instead of plate, which is bound to at one place, which is there. It's a semi-quantitative method. Allergen extract can be detected, or a component can also be detected at the same time. And this is how, CRD, which is a technique which is known as component resolved diagnosis, which have been developed by, I think, by this method itself, which is there, or by, you can also do by ELISA. Advantages, again, is requires a very small amount of the sera, is a high sensitivity, specificity, allergen panel and components are range up to 650. And usually this is because it has been developed by Europe and US. So what allergens which you get is not the Indian allergens. So some of the allergens which are common, which is there, like some fungal allergens or dust mite allergens which are there. But when you look at the pollen allergens, which are very unique to this country, you will not find some of those panels there. And the other limitation is very high cost. When you look at the skin test which is there, you can do it in actually 1,500 rupees, and this you will get around the 15,000 rupees. So you have to be looking at the patient which is there, and also how much money to be spent on that one which you are looking at. Mostly this second test is done more of a confirmatory method as compared to the, I think, looking at the initial test. What do you do in here? This is the, I think, material which is a cellulose material. Because it's a three-dimensional material, this allergen component can bind in a different manner in all the methods. Which is a CNBR activated cellulose, you put the allergen component, which is I think bind to the allergen, the cellulose. You come with the patient sera, which has got an IgE. This allergen component will bind to different epitopes on the same protein which is there. It can be same or it can be different, which is present in the patient sera. Then you come with the second antibody, which is either labeled, or it can be fluorescence, or it can be color, and then you comes out to be develop the color or read it in a machine to get how, if the sensitivity is high, if the color is high, it means the person is positive. If it is less, then it may or may not be positive. The method which we talked about is a CRD, is the component resolved doctrine, which is also one of the in vitro methods. And you will find many people, as Professor Rajkumar has said, they'll come with the, some report. And once you see the report, it's very difficult to interpret the things. So here again, you can use allergen extracts, a single or multiple allergen components, which are used for the, when you're looking at the allergens, some of the purified allergens can be native, or it can be a recombinant method which have been made by the used for the preparation. This gives you a quantitative diagnosis, and also it is mostly the standardized allergens. CID also distinguishes within co-sensitization to an allergen in that manner. When you look at components which are available for these extract which are there, so these are some of the allergen components for the diagnosis, and you will find most of the components which are available, the purified or proteins which are available for this one, they're all again coming from the Western countries. So these are some of the grasses, animal origin, weeds, trees. You will not find trees which are common in India, which you will not find the grasses which are common in India. You will find only the grasses which are, I think, the allergens which are available in the Western countries. Some of the occupational allergens, molds, some of the mites, venoms, food allergens. Again, food allergens are very important. I think Dr. Rajkumar will be taking a talk on this one. And because the food habits depends from country to country, also from region to region. So if we are not eating that food, the chances of to have allergy is very less. And then again, it is the purified allergen, a single allergen which is there. To be looking at the whole food is a questionable. So you have to have a allergen extracts completely as compared to a single allergens when you're looking at a food allergy which is there. Then some of the other animal proteins which are there. These are mostly, again, I'll say pollen, weeds are mostly from the Western country. Is it good for testing in India? That's the question which I think people have to discuss about it. Where is scenario when the CID is good? Usually during the anaphylaxis, if a person is having anaphylaxis a lot. Polysensitization, that is pollen and food reactivity. So a person is, having a pollen reactivity, but whenever it's eating the food, here you will find the lips of the person is using swell. So person is having a food, it is the pollen, maybe the culprit in that way. Also give you the culprit. In some of the food allergy, where people are going to anaphylaxis a lot, and this is now becoming very important because people are, there are lots of imported food which have been coming into in India, and that can have an anaphylaxis. Which is it. Latex allergy is again one of the scenarios where people have used to prefer CRD. The other method is microarray for allergy diagnosis. What do you do here is you take a glass slide, you put a chips, and you can put some of the purified proteins, as has been mentioned here. And then you come up with the patient sera, and you look at the reactivity. And after reacting to the lactate, you can see this type of things which comes out to be after reading the machine. Wherever it is a highly positive, you will find in a red color, and it will tell you some, different color. And wherever it is less reactivity, you can look at the chip and you can say, okay, the person is positive to this, or it is just not. So here it is the fluorescence where it has to be, the slide has to be gone and scanned as you do it in a different scanner, which is there. So these are some of the I think if you look at companies which are providing different ways of some of the methods or different kits they have it. One is Immunolite, it's from the Siemens. Immunocap, Isaac, which I have showed you just now. It is from Thermo Fisher. Immunocap from the Thermo Fisher. Alex and Alex2, these are the some of the again companies which are giving you reagents. When you look at the Alex, it comes out in 2017. It has got 156 extracts and 126 purified allergens. They have come with the new one approach, Alex2, in 2019. It gives you 117 extract and 178 purified allergens. Which is, so you have to look at this one, and it will give you the report in that manner. So what do you require mostly? Actually, it's the amount of sera which is required is very less. So it can be done in a setting which is there, and there are different extracts which are there. Some gives you 160 extracts, some give you 120 extracts which is there, and the Euroline which gives you different panels also at the same time. And reading methods are different, detection range is different, volume required is different at the same time, but usually it is a very less volume which is required. Again, once you are looking at IG antibody, the other thing you should look at what IG antibody is releasing it from the mast cells, the basophils. That is what we say as the mediators. So it is IgE which is there when it is cross-linked with the allergen which is cross-linked with the IgE boundaries. It gives you some of the mediators which are there. Histamine is the major mediator, and histamine can be determined by chemical method or by immunoassay, and can be detected again in the blood itself. It requires, the advantage is it can go up to nanogram quantity of required allergens. Nanogram, when I say it is 10 to the power 9 from a gram. It's minimal interference with the serum IgE, and at the same time, when you look at the limitation, it requires large amount of the blood. It has a chemical method is complicated and laborious, and 10 to 15% of patients, give a histamine one way or the other by just like normal way, it gives you the histamine content. So you have to be careful whenever you are looking at this histamine release method. The other is a basophil activation test, which is what we say is a BAT in short, which is there. What you are looking at is, in basophils, you're looking at the receptors, like CD63 or CD26, which is inside or on the surface of the basophils. Once they are activated, they come on the surface. Once they are coming on the surface, then they can be detected by some of the facts which is there, what we say is analysis by some of the machines. And then once they are upregulated, the quantity goes up in the surface, and that is what you detected. It can be done with the whole blood or PBMC. It has a high sensitivity and specificity. Yes, there are chances that it will come into the market, but I think it is going to be expensive in that manner. The other method is looking at the mast cell activation. Again, here you look at the tryptase value, and the normal tryptase value is usually 5 nanogram or in allergic conditions 10 nanogram to 1 microgram. There are also advantages and the limitations also at the same time. So what are the advantages test for the in vitro testing is preferred over the in vivo method which is there. So here patients which can stop the histamine, you can do the in vitro test. Where patient cannot stop, I think the in vitro tests are possible. I think there is inherent risk of anaphylaxis when it is there. When you know that the patient can go into the anaphylaxis, the in vitro tests are preferred. You can do it in pregnant women. We don't want to, expose to the new allergens to that. You can use the demographic where their skin is usually reactive. I think children which are afraid to have a prick, I think where it is preferred in that manner. And in food allergy, actually most of the food allergens are not standardized. So that is the preferred way of doing it in the in vitro method. So in summary, IgE can be tested by various in vitro methods. In vitro methods can identify the offending allergens here. What you are looking at, by in vivo method is the extract completely. Here you are looking at, which protein is identified or which allergen is giving you the reaction. You can identify at the micro level. It can also be, look at the cross-reactivity, study the cross-reactivity in vitro methods. And in vitro methods are useful in, some of the pregnant women, demographic drugs cannot be, and food allergy and children allergy. With this, I'll close up this talk. Thank you very much.
Thank you, Dr. Naveen. And I think the questions we can discuss afternoon. So now you have been given in vitro and in vivo testing. So in vivo is preferred basically, but there are circumstances where you need to go for the in vitro test. That is, if the patient is on antihistaminics, you are not able to stop the antihistaminics. If the patient has a dermographism, the patient is pregnant, and so on. So these are the 3-4 conditions where basically in vitro can be done, and of course it need to be correlated. So after you have done the test and everything, so again I am just emphasizing that when you do the test is merely a test. These tests need to be interpreted in conjunction with the history. So it need to be correlated with the history, and if the history is correlating with your test, then only you think about the management, because that patient becomes allergic to that particular allergen. So avoidance can be done, or avoidance should be done, or immunotherapy can be given. So now we are going ahead with the immunotherapy. The immunotherapy, different types of the immunotherapy is there. SCIT, subcutaneous immunotherapy, and sublingual immunotherapy. And again, subcutaneous immunotherapy is going to be dealt by Dr. V.K. Jain, and I think I will request him to tell about the newer modalities of the immunotherapies also somewhere, because there are many new modalities of the immunotherapy are also coming into the picture. Over to Dr. V.K. Jain.
इसको डिस्प्ले करो भाई. So thank you, Rajkumar, for inviting me for the next lecture. After confirmation of the IgE-mediated allergy for the clinically suspected allergic diseases, the next step, how to manage. No doubt the pharmacotherapy is the main part, but however certain things are very important, can be long-term prevent the disease, their symptoms, medications, and so I'll taking about allergen immunotherapy in general, and my emphasis will be on subcutaneous immunotherapy and some recent advances, because 20 minutes are not sufficient to give full knowledge about the subject. So these are the different indications, contraindication, failure, and all these things. We all know the allergic disease, as already said, very common, already said, the very important thing, the immunity include the active and passive immunization. This is very important to our research. What is active and passive immunization? To increase the host defense against the microorganism or the allergen. Allergen immunotherapy basically is a active immunization. All the vaccines, whenever we use, it is being used for the active immunization. And whenever we are giving the ready-made antibodies, we use for the passive immunization. So basically, AIT is active immunization, which basically altering the host hyperactive immune response. So what you find generally in the allergic Ig mediated, there is a hyperimmune response to various culprits. So whenever we use the allergen extract, we can use for diagnostic purpose. When we use it for the vaccine, for the immunotherapy, we call it the vaccine, very important. And this comes under the medicine as an immune modulator. And AIT is a disease modifying treatment option of IgE mediated allergic disease. The objective is properly use the AIT safely, effectively in clinical practice to be used by trained physician using the standard. These are basically the management of the overall holistic approach, patient education always there, pharmacotherapy is very gold standard to treat the symptom immediately, and long term also the allergen avoidance after knowing the culprit, and last but not least the most important, the allergen immunotherapy, which is effective just to change the natural course of the disease for long term. The vaccine, we know the history, Jenner 1793 actually prevent smallpox with cowpox. So I'll not go. This is the history of the vaccine, which is already there in last three, four century. For regarding immunotherapy, Noon and Freeman was the father of allergen immunotherapy, who himself used the injections of pollen extract in patients of grass allergy. We are using the different term, desensitization, hyposensitization. So desensitization, basically we cannot completely desensitize anybody by any means, whether use the vaccine or immunomodulator. So desensitization is basically a term, but however in the clinical practice we cannot completely protect it. Yes, hyposensitization proposed by Cook, where protection offered than the less or complete. Allergen specific immunity is an ideal name term where allergen vaccine is used for the treatment of allergic disease as defined by the WHO. Recently, we are using the term allergen immunotherapy, which is universally accepted to increase or induce the immune tolerance in the allergen. And what is allergen immunotherapy? Simply defined as a slowly and gradually administration of vaccine to allergen specific vaccine to a allergic patient who is having disease Ig mediated to a maximum dose for tolerance, which is effective for relieving the symptoms and reduce the medication. Recently, the AIT vaccine are classified, as I already said, it's a medical product, and in most of the country require marketing authorization. Before this 1997, there were a lot of controversy about the using of allergen. The other physician and chest physician not considering that the immunotherapy is effective. Lot of debate, lot of confusion. But this first paper, which came in 19, definitely said, which are endorsed by multiple international associations, said this, and the having multiple trials, more than 500 trials now, they are confirming that immunotherapy is one of the most important approach to what happened? Yes. थोड़ा सा बड़ा कीजिएगा. So these are the references where I have taken my topic, and already it has said that this is the picture which I have already said. The in the TS2 is in a allergic disease, TS2 is hyper reacted, most dominant part which is causing the disease here. Now, what is the mechanism of immunotherapy? Basically, it causes initially the rapid desensitization, early tolerance and sustained tolerance. So basically it's the immune tolerance which is hyperactive with the allergens, and starting with the rapid desensitization, early tolerance. So initially what happens when you give the vaccine, there is a increased IgE level initially. Mast cells and basophils, they decrease. Mediators, they increase initially when you give it in early, say 1 month or. But gradually there is early tolerance and sustained tolerance develop. And so there is an increased T regulator cells, and there is an increased ratio of TH1, TH2. So when the shift to be towards TH1, there is an increased IgE globulin, especially the G4, and there is a later decrease in IgE antibodies, decrease tissue inflammation, mast cells, eosinophils, and the mediators also reduce in the tissue. So these are the different changes where you find the which I have already said. IgE level will decrease, the IgG, especially IgG4 will increase, and the the TH one shift from TS to TS1. So these are all immunological changes you find, which you find more during the sensitization and active development of disease, from sensitization to symptom hyper responsiveness, and then disease development. So these are the all things which you find during and after immunotherapy. So this is the AIT is a, so nothing is the immune modifier, which I have already said. It prevents air modeling also, it repairs impaired also epithelial junctions, and these are all. So what is the rationale of prescribing immunotherapy? Is the patient having specific IgE mediated, which has to be confirmed clinically and by investigation, RAST or vitro or vivo test. So when complete allergen is not possible, symptoms not absolutely controlled by pharmacotherapy, patient refuse for long-term pharmacotherapy. Pharmacotherapy sometimes produces the side effects, and non-compliance of the patient for long-term treatment of pharmacotherapy. Now these are the disease indication. I think the rhinitis, conjunctivitis, asthma, all dermatitis, atopic is also now coming paper, that even the allergic or atopic dermatitis, the immunotherapy is also effective, very effective in insect allergy also. The age is very important. There is a questions where generally we prefer the age, which can be age can be there, but ideally the 10 to 65 years, most ideal age is 15 to 40. We do not recommend the immunotherapy below 5 years, and the between 5 to 10 years, yes, we can think of starting. Recommendation, we can use it if the patient is allergic to pollens, dust, insects, molds, food, we can do it. And even with the fungal, especially the Claudosporium alternaria, results are very encouraging. Animal danders, cat and domestic cat and dog, we can do it. Insects, cockroach and other are also showing encouraging results. Food allergy, especially peanuts, cow milk, egg, etc. Yes, very important for the information. Bacterial vaccine, we never use the AIT for bacterial vaccine. There is no role also. So with this, there are different types of allergen. Usually now we are clinical practice, we are using the allergen extract, which are usually aqueous vaccine, which are unmodified. Now depot and modified vaccines, which can be modified by physical, chemical or in combination. Newer vaccines are also, but in presently we are using the actual aqueous vaccine in our practice. And this is globally most commonly used heterogeneous mixture of allergens, and it is also having non-allergic material. That's why sometimes creating reaction also and not very effective. The aqueous vaccine rapidly absorbed and less stable, more allergenic, less immunogenic. Remember, more allergenic because it contains also non-allergenic part, also causing the more systemic reaction. Modified depots and allergoid are much better than the aqueous. They are better and they can be modified by physical, chemical or in combination, and they are very good and they produce the less reaction, systemic also, and they are most effective as compared to axle vaccine. The advantage which I have already slowly absorbed, needs fewer injection, they are less allergenic or systemic reactions, more immunogenic, and they also causes sometimes they causes more local reaction. Depot preparations are causing more reactions also. Preparation of therapeutic vaccine, selection of allergen action and their quality is based on very good quality of clinical history, grading of skin reactivity, knowledge of local aerobiology is very important, botanical knowledge of your area, that what are the plants, what are the culprits around you, they are important. Patient's exposure both of indoor as well as outdoor environment is important. Ideally, we should not mix more than 3 or select the 3 or 4 allergens, but up to 5 we can consider. Total quantity of subcutaneous immunotherapy is 5 or 5.5 ml. I will tell you detail. Most expected with mono. If mono allergy, I think it is good. But if it is a polyallergy, we can take 3 to 4 allergens separately. Especially, we should not mix the pollen to the dust mites or the other. We should have a. But in the practice, I think the people are giving the mix pattern also, pollens and other things. But practically, these are the contraindication, absolute and relative. Absolute if the asthma is uncontrolled, when FEV1 is there less than 7, predicted malignant neoplasm. Yes, pregnancy very important, never start new initiation of AIT, but however those who are already on AIT and if there is a pregnancy, we can continue. Children below 2 years, AIDS, severe psychiatric disorder, relative beta blockers, CBC, cardiovascular disease, chronic infection, immune deficiency, using immunosuppressant, autoimmune disorder, children between 2 to 5, their relative indication, if the HIV CD4 count is more than 200, and psychiatric and mental disorder of moderate grade. These are other miscellaneous contraindication, repeated severe reaction during immunotherapy, poor compliance, pregnancy, I have already said, and IT can be temporarily deferred during severe asthma attack. If there is a severe attack, we should not give the immunotherapy, intercurrent infection, or even high risk pregnancy and very high fever. So in these cases, we can temporarily deferred. The route of immunotherapy, the most ideal is a subcutaneous, which is routinely practiced in India in most of the places, which is more effective as compared, or maybe much better than SILIT. However, SILIT is not bad, but the more systemic reaction in the ISKIT rather than the sublingual, I think another important and I think very good in the children and will be taken by my colleague, my friend, Dr. Nagendra. I will not go. The other, we never use the routinely the nasal and bronchial immunotherapy. That is, sometimes we can use it in a research purpose. Never use the immunotherapy intravenously or intramuscularly. See, the subcutaneous immunotherapy, more systemic reaction, and there is also local reaction, wheal, erythema, diffuse swelling, late reaction. Sometimes we can have a nodule, which is more common in depot preparation. The systemic fatal reactions are reported, and because of that, paper which came from US and France create the havoc that immunotherapy should not be because of system, but it was not so much significant. Very few deaths because of not only by the immunotherapy, because of the wrong practice, wrong injection, and the quantification. That's the main reason. And whenever you use the immunotherapy, you have to ask the patient to sit at least 30 minutes, minimum 30. The international recommendation, even people are also asking for 45 minutes. Dose schedule of subcutaneous, we start with minimum dosage and concentration. We start whatever the dose is starting from 1 is to 5,000 and 1 is to 500 concentration, then 1 is to 50. There is a the calendar is there, there is a way, but basically we start with minimum dose 0.1 ml with the tuberculin syringe, reaching up to 0.9 or maximum 1 ml, because I prefer 0.9, because if you fill up in the 1 ml syringe, it will come out, so that but up to 0.9 routinely. So we start beginning 1 is to 5,000 bi-weekly, 1 is to 500 bi-weekly, and then weekly. And there is this is a schedule, and I'll show you the I think in workshop you'll find all these how we different vials, starting from first vial from higher concentration, higher dilution to, and this is the cluster immunotherapy, is a accelerated build-up schedule with several injection at increasing doses of 2 to 3 per visit in a single day of treatment at a single day on non-conjunctive days, and in this build-up dose achieved within 4 to 6. So build-up dose you can get within a 1 or 1.5 months, while in the routine subcutaneous practice we took about 3 months for build-up. So this is rush immunotherapy is also just to achieve the early build-up phase, and this is also being, but routinely it is not practiced in our country. The failure, or why there is a failure of immunotherapy, or improper selection of patient in terms of diagnosis, selection of allergen doses, inadequate duration of immunotherapy, poor compliance and address, poor education, less duration, premature stop of immunotherapy, developing new allergy to previous negative allergen, that is also cause of failure, developing allergy to new allergen in the environment also. So these are the slide where the proper history has to be taken. Number, as already said, not to be more than 3 to 4. So this is the monocytized patient. We select the allergen out, and we suppose a patient who is having 4 grading. So we with the single allergen we will take the 5.5 ml in one vial, and we will, so of different concentration starting from 5,000 to 500 and 550 for monoallergen. For the prescribing for a polysensitized or multiple allergen, we can select it 3, 4 ideally, and we calculate accordingly the positivity first of different allergen A, B, C, D suppose, and we calculate the plus point, and then we divide it by into the 5.5, and whatever minimum each allergen dose comes, so that we will be having a practice, because again there is a demonstration for the how to prepare the vaccine and what are the precautions, and that basically is the immunotherapy is a art in a scientific manner. I saw many problems you come when to stop. Sometimes patient having very severe reaction, sometimes having very severe infection, fever and other disease or pregnancy, that you will have a experience. So basically this 2-day workshop is just to create the sensitization, more awareness and your interest in the practice of allergy. Remember, in the future the allergen immunotherapy will be a very highly, because you see the COVID vaccination, immunotherapy, whatever in the form, or immunomodulators. This will be the future of treating not only the infectious diseases, not only the allergic diseases, and also even the autoimmune diseases. You will find the role of these various type of allergen vaccine. So this is all schedule. As I said, the 5,000, 500, 550, there is a fixed schedule. And this you will learn after seeing all these charts available there. I'll show you if you are interested. My colleagues will show you all these charts, and so these are all things which I have said. I'll not go in detail, but one thing is very important. It should be practiced only when you are trained, and it should be only practiced when you are having emergency management in your clinic. Then you see, and always ask patient to sit minimum 30 minutes in the clinic. So these are all these things which I have already said. Thank you very
Thank
much.
you.
All the things. The duration is very important. The minimum duration is 3 years, but maximum we can give it to 5 years. And the results are is very more effective in pure rhinitis. It's 70 to 80% efficacy in patients of rhinitis, reduction of medications and the symptom score. And when there is a asthma, I think 50 to 60% patients are, and my
Thank you.
patients are improving like anything. And so if you really practice judiciously, properly, and in a proper manner, really this immunotherapy is very,
Thank you,
last
sir.
but not future of immunotherapy is very promising, bright, which I already said, to be more than 500 trials, not the more than this. So this is a preventive, this is a tertiary prevention of the therapy, which can be reduce the symptom eradication. Thank you very much for
Thank you,
patiently hearing.
Dr. V.K. Jain, sir. Thank you so much for giving the overview about the skit. So, skit we have learned. Just for your knowledge sake, I'll just put some of the points, like you can prevent developing asthma. Basically, if you start the immunotherapy in a properly diagnosed case of the rhinitis, their studies has been there, and you can prevent the development of the bronchial asthma. One. Second is, if you give the immunotherapy in any form, hyperreactivity decreases, symptom score decreases, medicine score decreases. So I think these are the benefits of the immunotherapy, either way, whether skit or the slit. So skit has been told. In this also, the basic concept is slowly you need to increase the concentration of the antigen, slowly increase the amount of the antigen, and slowly increase the duration between two antigens. So that is the basic terms, and you can give for the 3 to 5 years. Sir, thank you so much. I think we'll discuss later on. And with that, we go to the slit, and this is the very important modalities. I think Dr. Nagendra Prasad, everybody knows, he is one of the leading allergologist of our country, and he has a center that is called the Bengaluru Allergy Center, which is really doing the excellent work, and he has developed the diploma course in association with the university, and hands-on also goes for, I think, couple of days, months there. I have visited his place. It's a really very good academic orientation is there at his place. With that, Dr. Nagendra Prasad about the slit.
At the onset, I thank Dr. Ved Prakash and I thank Dr. Rajkumar giving me opportunity to address this workshop. The basic idea of this workshop is to make to understand the basic utility of these therapies. And before we start the therapy, the morning all our friends have said about the importance of the history, the diagnosis, the futures of diagnosis. And these are all basic information which has been given. And immunotherapy has to be given only to a selective patients. It cannot work in all the patients, and you should be very careful in selecting the patients. You'll be understanding in the afternoon. Can you make it the screen bigger? हो गया. Thank you. This is my center where I am working, and I should be thankful to my mentor, and because of his motivations, which I could able to commit the practice of allergy, which it was not very established as we have a good knowledge and a technology which has improved in allergy now, and it was very crude at that time. And the principles we will be discussing, and also we will be discussing about the slit dosage and efficacy and the safety, and what are the importance of allergens which is found in India or more in the pollens and the house dust mite. And just giving you a small gist of about the history of how the immunotherapy has initiated. Way back in 1911, which has been started without having any clinical trials. Just they took the allergens, they started giving, and they responded with a hay fever, and they continued. The mechanism of action was not known, and only in 1964, only when the IG was invented, then only we could able to know how the mechanism of action is happening. And because of the gap of so many years, the medical fraternity could not able to recognize the importance of allergen immunotherapy. Even now, there's lot of resistance about the immunotherapy. Even this morning, I met one of the orthopedic surgeon, and he is conducting some workshops in our hotel clerks. And he was asking, what is allergy? Any specialty or any branch? What it is? So that means we are not communicating to our own colleagues about the allergy disorders and the management. So that is the level where we are. And 1980s, we have a slit sublingual immunotherapy studies was published with a double-blind placebo control study. And 98, WHO and IAACI endorsed the slit. And 2010, tablet approved for house dust mite and a grass and a ragweed. And we have combination of probiotics in the slit, and which is going for a molecular approach. So it is growing. So as Dr. Navin Arora said about the IgE molecule, which has been make a different outlook how the allergen immunotherapy works. And it is based on the mucosal allergy, which is the diagnosis which has to be done as per the protocol given in the morning by Dr. Rajendra Prasad and Dr. V.K. Jain. And first is allergen avoidance. Pharmacological treatment is very, very much important, and it cannot be avoided till the symptoms are under control by using the immunotherapy. What is the primary objective of immunotherapy is, that is, the immune tolerance has to be developed. So anybody who comes to you, you should say that allergy is not a disease like other diseases to cure. We had to increase the tolerance. Once you increase the tolerance, the reactivity of the allergens comes down, the intensity comes down, and he will be free from the symptoms and also free from the pharmacotherapy drugs. So that you have to understand first, so that you can communicate to the patients. What are the principles? It is a continuous stimulation of the immune system with a particular allergen which is sensitive, and to reach a tolerance dose, whether it is a skit or a slit, to treat the airway and skin and food allergies. So indications and pro-conditions which is already discussed. It mainly decreases the symptoms which I told you and reduces the pharmacotherapy drugs, and it is a long-term efficacious, effective completion of the total treatment period. Once it is compliant, then you will get a sustained effect. And it works on immunological basic mechanisms, and it is an anti-inflammatory treatment, and it's a very causal and a preventive treatment, and it is the only treatment that influences the basic course of allergic disease by immunomodulation or a disease-modifying effect, which already discussed about the mode of action is on cellular and molecular. And the main focus or the main action of immunotherapy is to suppress the mast cells and basophils, and also the suppression of effector T cells and suppression of the tissue inflammation, and the mucus production, and the inflammatory dendritic cells is reduced, and it enhances the tolerogenic dendritic cells, and also the suppression of IgE and the induction of IgG4. This is the basic mechanism of immunotherapy. And you see, there are two factors. When the IgE increases, the inflammation happens in the particular tissues. It may be in the lung, or it may be in the nose, or it may be in the eyes, or in any other organs. So most of the people who are treating with allergic asthma, they bring down the inflammation by using the inhalers, ICS inhalers. And this will bring down the inflammation, but they can't withdraw the inhalers, because the factor is IgE molecule is continuously producing because of allergy exposure. But once you bring down the IgE molecule, the inflammation also comes down, and the inhalers can be stopped. So people who are using the inhalers and they say that lifelong you have to take it, the reason behind is IgE production. So once you bring down the IgE production by using the immunotherapy, and naturally they can free from the inhalers. Another factor is the skit continuously taking for 3 to 5 years is really horrible, and a patient can't able to tolerate, and because of trypanophobia, which they reluctant to use the, especially the children and also the female group, which they don't like to have injections continuously. So actually, Dr. V.K. Jain has said about the limitations of the subcutaneous immunotherapy, and because of the induction of the fatalities in early part of the 80s, and they said that the immunotherapy has been withdrawn from practice in European countries, and they are restricted only as specialists. At that time, the regression started on immunotherapy. Then the alternative routes initiated, and 86, the double-blind placebo control started in this late. What are the alternative routes which they have tried? And they have tried with local nasal immunotherapy, that is spraying into the nose, and the sublingual also they have tried, epicutaneous over the dermal patches which they have tried, oral immunotherapy, and that is by putting the drops into the mouth and swallow, and intralymphatic immunotherapy, which is still in the process of R&D, clinical trials. Intradermal immunotherapy was also tried, and a subcutaneous, which is already there in the, and the intrabronchial immunotherapy, which has been restricted only for R&D work, which now not continued, and oral mucosal immunotherapy, which is coming up in the recent time. The current option, which is we got it, is only subcutaneous and a sublingual, and a future options is the intralymphatic, and epicutaneous is also is slowly is coming down, and oral mucosal immunotherapy is coming up. Why only the target for a submucosal area? The reason is that the mucous membrane in the submucous and as well as the vestibule, the mucous membrane is very, very thin, which is approximately about 100 to 200 microns and not keratinized. So it can penetrate into the system very easily. So this is how this usually, so this is a vestibular area between the gums and the cheek, and a sublingual area. These are only two areas in the buccal oral mucous membrane, which is a suitable area where these allergens can be absorbed, and you have to keep it for 2 minutes. Usually we advise for 5 minutes. The reason is if you advise to the patient for 5 minutes, at least it can be justified for 2 minutes. So usually it is a transcellular and a paracellular. These are the two mechanisms how these allergens can enter, and transcellular may be in a different path, and which happens only in these two areas. So this I am giving you just how this, the Waldeyr's ring, which is found in the throat, that is adenoids, and a palatine tonsils, and a tubal tonsils, and a lingual tonsils, where it is adhered to the epithelial layer, and then slowly it absorbs into the systemic circulation. And you see that buccal and a gut is more or similar to the same anatomical features, and histology is also similar. The only reaching to the gut, it has to pass through the passages with a different pH media, and as it gets destroyed and degraded before it reaches to the gut, therefore it has to be kept in the sublingual area. And this is one of the experiment which has been done, and when we started this sublingual area, and they have put the pollen, which is a radio labeled, and kept in the below the tongue, and shown that 1 hour and after 2 hours how these allergens can be absorbed, and you can see in the tissue which has been distributed. So as I said that SLIT is an allergen-oriented immunomodulation, affects the immune response to allergens. And it is a self-administered, requires careful instruction to be followed. That means your communication to the patient is very, very important. And a clinical efficacy of SLIT in asthma and rhinitis is supported by large control trials and meta-analysis, which you will be seeing shortly. So this is how the allergen has to be kept below the tongue, and it has to be used. And mechanisms in the early part, like in 1996-88, they said decreasing the migration of eosinophils, and also number of mast cells, and also a number of activity of the eosinophils, and this decrease in eosinophil numbers in bronchial hyperreactivity. The importance of the SLIT efficacy depends upon the type of allergen what you use. This morning, Dr. Naveen informed you about the standardization of allergens. The quality of allergens is very important because these are all biological materials. And a dosage, which is very important, which has to be standardized according to the need of the patient, and a duration. And which I have already told you about this. And this is one of the study which has been shown that you can see the first visits, you can see how much the symptoms can be controlled in asthma. Similarly with the eyes, and in general, and the nose and the skin. So these are all how the immunotherapy could able to give a total relief to the patients. So we have a strong evidence on meta-analysis, and Cochrane has been reviewed in 2020. More than 60 randomized control trials have been shown that a significant reduction of the symptom and a medication score, and it is very effective in children, adults, and elderly people. And it is a progression from rhinitis to asthma which can be retarded, so that the symptoms can be brought under control in the beginning with the allergic rhinitis. A PAT study that is studied in 2002, and another study which has been studied in 2007, a 3-year SLIT reduces new asthma incidence in children. And you get a long-term benefit persisting after stopping. The people who have been done the work, one with Dr. Durham from Imperial College, and they have given a long-lasting effect. Once you give a total therapy for 3 to 5 years, and you can stop it, and the recurrence may happen after 15 years or 20 years. But again, you have to give another short-term duration of therapy for 2 to 3 months or 2 to 3 years, so that the sustained effect can be continued. And the systemic reactions are very, very less in compared to the SLIT, and only the local symptoms may appear. But whereas in the SLIT, the anaphylactic reactions may happen, one should be very careful when you are giving the maintenance dose. But in the slit, which can happen in the lesser dilutions or more tolerance to the higher concentration than the dilutions. So the people who are using this slit as a build-up phase may be getting more reactions locally, like a pruritus or a swelling in the tongue, a swelling in the lips, but there's no anaphylactic reactions to happen with a slit. So we have a number of studies which I am not able to go in detail because of the short of time, and which is already published, and you will be getting a lot of informations on the internet. And the main results is to reduce the medication and improve the quality of life. This is very, very important. So we have international guidelines on the slit, which has been published by AREA, that is allergic rhinitis in asthma, and also IAACI, European Allergy, and World Allergy Organization, American Allergy Organizations, and Indian College of Allergy and Immunology. So what AREA 2020 says, slit for allergic rhinitis has been recommended with asthma or without asthma, moderate to severe. Evidence supports grass, birch pollen, ragweed, house dust mite tablets and drops. So here one should be very careful that selection of allergens may be showing positive with other allergens, maybe food or maybe other like feathers and other things. So it is not recommended because the clinical trials was not showing very promising, but you can apply as a individually to the patient to see the observation, but you had to inform the patient, it may not. Similarly, IAACI in 2018 guidelines, it is the first line of treatment in allergic rhinitis, especially in children and adults, is a slit and a strong evidence with a grass and a ragweed and a birch, house dust mites. Early intervention in children prevents asthma, and WA position paper, slit effective and safe versus skit, and encourage where skit structure limited. Emphasis on standardization of extracts and adherence is very, very important. Similarly, American College of Allergy and Immunology and Allergen Academic Institute, which has been shown that FDA approves slit tablets for a grass, ragweed, house dust mite. Drops are off-label in US and India also is used. One should be very careful because the placebo effect and the real effect of the slit is very, very narrow. So he may be using the slit drops, which may be a potent allergen or may not be there because they are using in the liquid form. Stability will not be there. As Dr. Naveen Arora has shown, the slit of different contents, major content may be there, may not be there. So, Indian College of Allergy and Immunology in 2018 consensus statement has given, slit is very safe, accessible, widely used in India as a off-label, which is not approved by the drug controller, and it drops more common than the tablets, and relevant allergens, house dust mite and pollens. So the comparative summary table, which is already covered and which is showing the duration of treatment may be 3 to 5 years. And area guidelines which has given the information that allergic rhinitis, it can be used and from moderate to severe to the mild persistent and moderate severe persistent. Another good news is the slit is the only drug which has been recognized by GINA, and GINA has given a clear picture that it can be add-on therapy. It cannot be exclusive treatment. It can be given as an add-on therapy in the step 2, step 3, step 4, but not in the step 5. So these are all statements which has been given why it is effective in GINA. And when compared to the skit and the slit, the efficacy is almost remains same, but safety-wise, very safe in the slit compared to the skit, which is having a risk of systemic reactions. And convenience, the home dosage provided, you counsel the patient repeatedly, recurrently, because you had to take it for a long time. So you have to give a personalized counseling, and repeated counseling is very, very important. And a clinic dosing, as a doctor will be addressing, or a doctor's assistant will be addressing to the patient, by giving the injections, they are motivating for every dose. So even there also the dropout will be very fast after, when the symptoms are under control after 6 months to 1 year, and they say that number of injections I have taken, I am not able to continue. So now the combination of skit and slit has been started. So in the beginning you can start with the skit, and till the symptoms are under control. Then once the symptoms are under control, then you can start with the slit immunotherapy. And adherence is very high in the kids, provided you motivate the mother of the child. And skit, very low adherence, they drop out very easily and fast. And we have the slit. The allergens was not listed in the pharmacopoeia, and this pharmacopoeia, which has been published in 2017, which they have included, and earlier it was not included. And now we have a slit tablets and a strip which has been formed at the Bangalore Health Center, and which is very, very convenient. And a solid forms are more stable when compared to the liquid form. Liquid forms degrades very fast when compared to the solid forms, because the stability of the proteins will be more in the solid forms. And we have introduced this pollen parthenium in the 2003 in the form of a drops. Then we have introduced the pollens strip as well as the house dust mite tablets in 2014, and subsequently we could able to get a dispensing license from the drug controller. And also we have got a Indian patent and a strip and house dust mite pollen and insects. And we got it patented for house dust mite tablets. So these are all globally, which is available in a different forms in a different countries. So not only in India, even other countries also having the same. And one of the international MNC tablets have been introduced even in India, and which is really very expensive, but it is working well. Thank you very much. Yes, sir.
Thank you, Dr. Nagendra Prasad.
Yes, sir.
Thank you so much. I think question answer they will discuss later
Okay,
on.
that's fine.
So after this, we are going to take the lecture on the food allergy. ये इसको बड़ा कर सकते हैं यहाँ पे?
बड़ा करा दो भाई.
We are already
Welcome,
running short of time, so
Very well.
we'll try to finish as soon as possible.
Professor Rajkumar sir, for gracing and managing this whole show very efficiently. And this could be, I think, possible because of your continuous and continuous guidance and support. So thank you for being with us always, sir.
So I will request the other faculty members to try to finish as soon as possible, because already 4 lectures are there. So what food allergy, because whenever you come across the patients, especially bronchial asthma and everything, so the patient always asks you what to eat, what not to eat, every time. And especially in the case of the bronchial asthma, when I started my career, I was just a lecturer, and the residents took the history. They came with the history of the patient. History was presented, 12-year-old child, and history was presented. History was like a typical bronchial asthma since childhood. And the child was emaciated, basically. So I asked the mother, सेम क्वेश्चन आई आस्क्ड द मदर कि इस बच्ची को इतना दुबला पतला क्यों रखा हुआ है, इसको खाना तुम नहीं देती हो क्या? दैट वाज द क्वेश्चन आस्क्ड बाय मी. द रिप्लाई वाज, द मदर टेल्स कि इसको बचपन से ही सांस फूलती है और पसलियाँ चलती हैं, सांस फूलती है. तो लोगों ने मेरे पास जो आए उन्होंने बताया कि इसको चावल मत देना, इसको दही मत देना, इसको ऑरेंज मत देना, इसको बनाना मत देना, इसको अंडा मत देना. ये सब चीज़ें मैं शुरू से ही नहीं दे रही हूँ. आई वॉज शॉक्ड. Then I thought, let us do a study on the food allergy in bronchial asthma. And I still remember at that time I was just 2 or 3 years old lecturer. I did not knew how to write the project. The project was virtually everything was written by late Dr. VP Singh, and the collaborators were Dr. Naveen Arora, and one of the student PhD also did, 2 students did the PhD also. We got the fund, we approached to the ICMR, got the fund, still remember 21 lakhs to know the food allergy in bronchial asthma. So my whole lecture's aim is today to tell you what is the food allergy and is there any food allergy to the extent we understand. Means what is the prevalence of the perceived food allergy and what is the actual food allergy. Food allergy is there, but not to the extent that we understand that the patient is having the food allergy. So unnecessarily you ask the patient to stop particular food. You do not know whether the patient is having the food allergy or not. So please, now onwards after this lecture, you should ask the patient to stop any particular food if you are 200% sure that the patient is having the food allergy. Otherwise, don't ask them to stop any food. Whenever the patient comes to me, क्या खाना है, I start with this, केला खाओ, दही खाओ, दूध खाओ, चावल खाओ, and the people say कि ये तो बाहर वाले लोग मना करते हैं. मैं बोला नहीं, मैं बोल रहा हूँ खाओ तुम, कोई प्रॉब्लम नहीं होगी. So food allergy is there, but not to the extent we understand or the patient understand basically. So I will just introduce the food allergy, then epidemiology of the food allergy. I will try to go hurriedly. Clinical feature, diagnosis, then what is the relevance of a specific IG, total IG. Component level already has been discussed by Dr. Nabeen Arora. Natural history of the food, rice and the legumes that we generally eat much more, and the guidelines of the diagnosis of the food allergy, management, role of immunotherapy. So food allergy is an adverse health effect arising from the specific immune response that occurs and reproducible on the exposure to a given food. So whenever the history of the food allergy will be there will be reproducibility will be there. So whenever the person eats that particular food, the person will have the food allergy, person will have the symptoms. We will come to the later the symptoms and everything, but whenever the person takes that particular food, the person has a reaction or have a symptoms. So that is very, very important. Reproducible, that is very, very important. And of course, the food reactions may be non-toxic, toxics, then hypersensitivity. The toxins can also give a reaction, food reaction and everything. So that is not actually food allergy. So it can be allergic hypersensitivity, it can be non-allergic hypersensitivity, it can be food intolerance, it can be drug reaction to any particular drug, and it can be IG mediated or the non-IG mediated. The clinical features or the differential diagnosis can be so many differential diagnoses can be there. So food allergy is not a very simple subject. Okay, the patient has come with some reaction and you label the patient as a food allergy. Differential diagnosis of the food allergy is so much. So you need to know about these clinical entities in the different basically mechanism, metabolic, pharmacological toxins and the others. Food allergy and the food intolerance, very important, you need to understand. So on an average, very important, in the food allergy, most food allergies are IG mediated reaction which occurs within 2 hours of the exposure. And food intolerance, it will be variable, complaints will be variable, and not a severe reactions will be not there in case of the food allergy. But food allergy, severe, and it will be consistently after the consumption of the particular food and so on. Of course, first exposure, second exposure, release of the mediators and the symptoms occurs. Epidemiology varies because it depends upon how you have diagnosed the food allergy. Have you diagnosed food allergy on the basis of the history only? Percentage will be different. On the basis of the skin prick test, percentage will be different. On the basis of the oral food challenge test, different. So how the people have diagnosed, have taken into account, what are the parameters has been taken into account. So you can see in the country it depends upon 0.5% to maybe around 15 or 20% and so on. In the different area basically, again I told you the methodology, what are the methodology which has been taken. It can vary from around 1% to maybe 15, 16 or maybe 30% or so on. Food allergy prevalence of the specific food allergen, that depends upon like the egg, milk, peanut. So in United States, it's for the egg 0.6 to 0.8%, and worldwide 1%, and then the milk 2% in the children, and then the peanut basically in the US 1.2%, tree nut and so on. So percentage will vary from the place to place and so on. Like we had done in the rice allergy, our percentage was 0.8%. So they were basically IG mediated rice allergy was there. In the black gram, it is 1.7% has a food allergy and so on. So these are the major food allergens, which are basically milk, egg, peanut, tree nut, fish, shellfish, wheat, soya, and the sesame. So these are the nine major food allergens across the world and so on. In our country, not much work has been done, but some places the work has been done, and the percentage varies from different place to place. And one of the study where Dr. P. Mahesh has done it, the cow milk allergy was 0.5%, and with the apple it was 5%. In case of the Calcutta, the people have done, and they have found out the overall prevalence was estimated to be 17%. With the equal sensitizer to the cereals and the legumes. Mind it was a food sensitization, not actually the food allergy basically. Is it a really food allergy? There is a great discrepancy between the reported and the medically diagnosed food allergy. That's why basically I told perceived food allergy is the different percentage and the actual food allergy is the different. So what we did, we took around 2,000 patients of the bronchial asthma and or rhinitis basically. We go for the history of the patient. Around 60% people have the food allergy, so-called food allergy, perceived food allergy. Then we did the skin prick test, that was 30% percentage was there, and of course we went ahead with a specific IgE, and then we did the oral food challenge test. That was an open food challenge test and the double blind placebo food challenge test, which is the golden standard for the diagnosis of the food allergy, and it came out to be 4.47% basically in case of the asthma, rhinitis or the both. So mind it, the perceived food allergy was 60% and the actual food allergy was only 4% basically, and that was maximum with the rice, black gram, citrus fruits and the banana. So that we should always take into account whenever we are dealing with the food allergy, particularly in the patient of the bronchial asthma and rhinitis. Typical symptoms of the IgE mediated reactions can be depending on the organ which is involved basically. If it is skin, urticaria, angioedema, intestinal problems, abdominal cramps, diarrhea, then oropharyngeal swelling, then ocular conjunctivitis, respiratory rhinitis, rhinorrhea, cardiovascular, pallor, sweating, and even the death can also occur basically. And neurological anxiety, feeling of the impending doom, change of the behavior. So these are the symptoms. So which organ has been involved, accordingly the symptoms are going to be there. diagnosis of food allergy is not very easy, very, very difficult to diagnose food allergy. It needs time to diagnose food allergy basically. So diagnosis of the food allergy depends upon the history. You need to take the history in the detail. That also I told you that it should be reproducible. Every time the person takes that particular food, the person has the symptoms. So reproducible. And then of course skin testing you need to do, specific IgE. Nowadays basically because it's very difficult to do the oral food challenge test, that also the double blind placebo food challenge test. So that's why there are many studies which are coming that specific IgE especially, if it is more than this particular international unit, then the patient can be labeled as having the food allergy, because it's very, very difficult to do. Sometimes anaphylaxis also occurs during the doing of the food challenge test. So that's why I'll come to that data. The data has come for the specific IgE also. Of course, the recommendation about the diagnosis of IgE mediated food allergy, that was published in 2023, clinical history, diagnostic test, oral food challenge test. These are the important component basically. Diagnosis of the food allergy, I told you the history is very, very important. Skin prick test can be done, and of course this data I have already shown. Then one of the component is the prick to prick test also. This is also very important. Prick to prick test means with the juicy material you can prick that juicy fruits or something like that, and you prick the skin. So it is prick to prick test, and it has been seen basically, and the recommendation are also there. Wherever needed, the prick to prick test can be done, and prick to prick test has been shown it is better than the skin prick test, especially for the juicy material and especially for the fruit. I was telling that if there are positive predictive value with the common food allergen of the specific IgE. So recommendation is that if it is if the positive predicted value is 100% basically, and reproducibility of the food is there, then specific IgE, if it is more than is around 15.5 or 7.2, and then so you can see the positive predictive value, then you need not go for the food challenge test. You can stop here and you can label that patient as having the food allergy with that particular food. We also did the relevance of the specific IgE in case of the food allergy, and we found out that the specific that serum IgE 260 international unit per ml or more with the marked positive skin test can serve as a marker and a topi of the food sensitization basically. And we saw that if the specific IgE is 3 times the normal control, correlates well with the positive double-blind placebo-controlled food challenge test and the other evidence of the case of the food allergy. So if the specific IgE is 3 times then the normal control, and if there is a history of the food allergy, then you need not go for the double-blind placebo food challenge test. In case of the rice also, we went ahead and we did the skin test positive, and of course the specific IgE to the rice, if it is more than 6.9, that shows correlation with the food challenge test and so on. And of course for the black gram also we did, and we found out if it is 4 times or more of the normal control specific IgE, that was well correlating with the double blind placebo food challenge test. And of course this I have already shown you that if the specific IgE is this much or more, then you need not go for the double blind food challenge. Diagnosis of the food allergy is basically different test has been also told by Dr. Naveen, epitope mapping, basophil activation test, mast cell activation test, that can be also done. I will not go into detail about that. Then coming to the oral food challenge test. So oral food challenge test is also very, very important, that can be done. And then double blind placebo food challenge test, that can be done, where you need to mask the taste, smell and the sight and the texture of that particular food. So for that you need to make the recipe in such a way that you mask the smell, taste and the texture of that particular food. I will not go into detail about that, it will time consuming, and then only you do the test basically. And if it is positive, then confirmed the person is having the food allergy and so on. This this patient I discussed with you about, yeah, this is another patient where it was a like highly positive to the pulses, and you can see in this particular we did the food challenge test, and you can see FVC decreased to minus 48%, FEV1 to minus 64%. So this was done for the research purpose, and at that time basically this was in 2000, and we started with the immunotherapy in this particular patient, and we succeeded also. I'll not go natural history of the food allergy. Of course, if the person is allergic to the milk, then rate of resolution more than 50% resolution is there in 5 to 10 years. Egg 50% 2 to 9 years, wheat 50% by 7 years, soya it is 45% by 6 years, peanuts about 20%, and so on. So there is a natural history of the food allergy resolution is there with the food allergy and so on. Management of the food allergy, avoidance. So basically the avoidance is the best modalities when you can do, and that the guidelines has come out. So dietary management, psychosocial support, and treatment plan and immunomodulator treatments are there. So dietary management is very, this is recently published in 2024. In case of the dietary management, so what you do, allergen avoidance. So whatever the food you are allergic to, please avoid that, and you consume the safer food. Individualized dietary advice need to be given, and now they have recommended that ideally this should be done with the consultation of the dietitian. Psychological support is very important, because what to eat, what not to eat is a very stressful for the patient who is having the food allergy. So coping strategies need to be there, cognitive behavior therapy, and ideally the clinical psychologists need to be there to help for the psychological support and so on. Treatment plan, emergency medication can be given, adrenaline, auto-injector, and salbutamol, antihistaminics can be there. And of course, emergency treatment management has to be known to the people. And training support, auto-injectors you are going to give, EpiPen you are going to give. So how to give that EpiPen, that's also is very important. Of course, immunomodulator treatment, allergen specific immunotherapy can be done with the for the peanut, oral immunotherapy, slit, and epicutaneous immunotherapy. For the egg, oral immunotherapy, milk, oral immunotherapy. And biologicals, omalizumab has been tried and has been found successful, and it has been recommended in the guidelines to give for the food allergy and so on. And I told you for the peanuts can be given, for the egg, for the cow, and biologicals can be given for the immunotherapy. And so to conclude, there is a great difference between the public perception and reaction or allergy to the food, and confirmed reaction or allergy to the food. The patients of the asthma or rhinitis are advised to undergo appropriate in vivo as well as in vitro test before preparing advising diet elimination. Food allergy estimated to be 4.47% in the adolescents. And rice, legumes, and the citrus fruits are the major food allergens in our study. Avoidance of the particular food is the best treatment. Immunotherapy to the food is recommended for the few foods. So whenever you advise any patient to stop basically particular food, please 100% be sure that the person is having the food allergy to that particular allergen. My acknowledgements to Dr. B.P. Singh, Sushila Sridhar, Dr. Naveen Arora, S.N. God, A.B. Singh, Dolly Kumar, PhD student, Prakriti Srivastava, Vishal Khare, and so on. And I am thankful to the ICMR, DBT, and WHO, Ministry of Environment, and the BPCI for allowing me and funding me for these food allergy projects. So thank you so much.
Thank you, sir, for very nicely covering your topic within time, especially. And so I think
so
our
we'll move
student
to yeah.
may have any questions. अभी तो काफ़ी भीड़ लग रही है यहाँ पे, काफ़ी लोग आ गए हैं. बाद में भी डिस्कस कर सकते हैं. सर तो अवेलेबल हैं हमारे साथ में, पूरे टाइम रहेंगे. So thank you, sir.
Yeah, thank you so much.
Thank you very much.
So we'll move to the next talk, and that is about the drug allergy, because you know drug allergy is also a subject which is not understood by the people as large. So I will request Dr. P.C. Kathuria to deliver on the drug allergy, and I request to be finish in time so that we finish everything. Thank you.
Thank you, sir.
Thank you. My greetings again. Thanks, Dr. Ved Prakash, Dr. Rajkumar, for giving opportunity to share my thoughts on drug allergy. Again, I discuss with the old gel and comb classification. It was incomplete because at that time we were not knowing the specific cells which are innate immune cells and the acquired immune cells. And these 23 classification, out of which 5 belongs to the drug allergy. So each drug has its own immunological reaction, but one single drug can produce combination of 2 or 3 reactions, like penicillin, beta-lactam, monoclonal antibodies. So with this, if you look at this, 7% of the general population who have got an adverse reaction, among which 2 types of there, the type A reaction and the second is a type B reaction. Type A reaction are dose dependent and predictable. Say for example, if you give warfarin, if you increase the dose of the warfarin, there will be bleeding disorders. So they are type A reaction. But the type B reaction, they are dose independent and they are dependent on the pharmacology molecule of the drug. So they can have a variable, so now defined as DHR, again 5 classification of the gel of 2023. Like if you focus on IgE, it will produce urticaria, angioedema, anaphylaxis. And if you focus on a T cell, it will produce 2 types of that. Maculopapular eruptions, or it will be a generalized systemic cutaneous reaction. Now we use that the term SCAR. And if you have IgG, then it will be a type 2 and type 3 reaction. Now what is PI? PI is a pharmacologically interactions. Type 4A means here the HLA, which becomes a strong antigenic, drug mixed with the HLA, then activate the T cells. So most of the strong reactions like Stevens-Johnson syndrome, 10, toxic epidermal necrolysis, AGEP, or DRESS syndromes, they come under this domain. And then I told that this is a classification which was not under any of the gel and comb. Now this classification has been put under type 6 of DID, the drug-induced reaction. Now for the sake of brevity, we find it that it is a type 2, and it is a non-allergic and allergic. Allergic means it is a IgE or it is a IgG or T cells. So IgE has been further classified that most of the drugs which are IgE are beta-lactam, anesthetic agents, as monoclonal antibodies and the platins. These are IgE. What does it mean? IgE means you can do skin test. But if it is a IgG, you can't do any skin test. Because like quinolone, anticonvulsants, no skin test is required. And the another phenomena of is there that all mast cells degranulation is not due to the IgE cross-linking. It could be due to other mechanism. Whenever there is a IgE induced mast cell degranulations, it passes through the 2 phases. Either the person is sensitized on the first dose and a subsequent intake of the drugs will produce degranulations like this. Now, if you have got a non-Ig mediated, then there are certain receptors sitting on the membrane of the mast cells. This is like MRGP or COX-1 membrane derivative. If you give aspirin and NSAID, the arachnoidic metabolisms disturb and there is increased level of the leukotrienes and the reactions occurs. So friends, think it that cross-linking or mast cell degranulation occur not only due to the IgE, but either due to the complement activations or due to the other receptors like MRGPCR. So these drugs can be, we can differentiate on the basis of it, whether my reaction is immediate or whether my reaction is delayed. If the reaction is immediate, then it could be either due to three things. Either it is the cross-linking of the Ig receptors by the drug, either it is due to the COX-1 inhibitor, either it is due to MRCPGR. So this is, three mechanisms are there. So Ig mediated, non-Ig mediated, or aspirin exacerbations due to the NSAID. If it is a delayed, then we further define into two groups. Whether the reaction is MPE, means single organ involvement, maculopapular eruptions, no any systemic involvement. Then either it could be the systemic involvement. So two groups are there. If it is a systemic involvement, then we take it as a scar. So let us say, define in that way, is it a IgE or it is a non-IgE or it is a T cell mediated on the base of the reaction. Sometimes during the reactions of the anaphylaxis, T cell also comes. During COVID epidemic, we have seen that some reactions, they occur immediately. Within 24 to 48 hours, patients has a macrophage activation syndrome or mast cells degranulations, T cells cytokines like ILC increases suddenly. So this was due to the activations of the T cells. These T cells were not including our initially the classification. Now it has been classified under that anaphylactic reactions is not due to the mast cells, but anaphylactic reactions could be also due to the T cell cytokines, IL-6, IL-8. So sometimes the reaction can occur. You see, the difference between Ig mediated will be the urticaria, angioedema, anaphylaxis, but the T cells will have got a high fever, chill, back pain. That is the differentiation clinically you do it. So friends, we define where the patient belongs to the type A, 80% of the patients are immediate reactions within 1 to 6 hours. Is it a Ig mediated or is it non-Ig mediated, or it is a type 2 reactions, type 3 reactions, or it is a T cell mediated when it is a single organ involvement, or it is a multi-organ involvement when we say it is a scar. And recently the another class which added is due to the cytokine release reactions involvement of the T cells. Now coming to the history. History depends on the timings. History detects that which type of the test you do. Say for example, if you have got a history, the past history of the anaphylaxis, what you will do? You will do all the tests, clinical, skin test, intradermal test, patch test, past history of the anaphylaxis. Or even you can do for the OPT for a specific drug. But if the recent anaphylaxis, the only test we do is only the vitro test. And the vitro test is the serum tryptase, which we'll see. Well, if the patient has got only single allergen involvement, then the guideline says that go directly for the OPT, the oral provocation test. And if the patient has a history of the scar, the systemic cutaneous adverse reactions, then no test is required. Only you have to look for the another alternative drug with a selected OPT. So friends, history is important, timing is important, and the type of the reaction is important. Is it a immediate or a late? There are many guidelines are there, but more than 6 hours, just take it that it is a T cell mediated, and once it is a less than, then it is a Ig mediated or non-Ig mediated. In between, some certain like MPE are the fixed drug eruptions, we define it. So this is the timing which is most important. Why the T cells are very significant for us? Because Steenman-Johnson syndrome, 10, AGEP, or DRESS syndromes, they may take days and days. Today you give the drugs anti-epileptic, the reaction may take 2 weeks, 3 weeks even. So what we want to diagnose is the Ig mediated. Now look at how we make the diagnosis. This is a Ig mediated. Either you do for the bed, either you go for the skin test. BAT is not available, so we depend on the skin test. Then it is a T-cell mediated, either we go for the skin test. It is a late reading intradermal test. There is a difference between this. Here the reading is done after 48 to 72 hours. And again the cellular test, the patch test. But patch tests are not standardized, so we depend on the late reading intradermal test. So in both the way diagnosis is made, either you do skin test, diagnose IG immediate reactions, and also the late readings skin test in case of the T-cell mediated. So serum tryptate is the only test. If you have a patient of a perioperative anaphylaxis, do serum test. There are certain baseline level of the serum tryptase. If it is more than 11.5, then consider that this patient is likely to develop anaphylaxis, and then you can take all the precautions measure in this. Specific IgE by the Thermo Fisher is only done in a few cases, but still not available in India. We are requesting them to bring as soon as possible. So serum tryptase is the only test during perioperative anaphylaxis. Next is the BAT, already discussed. Here we look at the CD203, CD23. They are sitting at the cell membrane. They become activated when you interact with the drugs. Specificity is very good, sensitivity is poor. If you compare all the vitro tests, so we have got a immunocap, we have got a BAT test. If you compare this, sensitivity and specificity is mostly the equal. So ultimately, where we are left with only with the skin test. Now, skin test, you have to know the dose. Skin test, you look at it, this is the wheel size, and reading is done day 1, day 2, and day 3. Day 1 is for immediate reactions, and late reading is done day 2 and day 3 for the late reading intradermal test. Now, question is there, how will you do skin test? You take the pediatric solutions of each drug and look at what is the non-irritating intradermal test dose, and that dose is very important. Like if you want to rule out beta-lactam, you take 20 milligram per ml of the ampicillin or amoxicillin and do the IDST test, and if it is negative, then you can delabel that this patient is not allergic to the beta-lactam. So there are certain specific dose irritating. If you don't know the dose irritating, what is the dose is irritating, or it is due to the preservatives of the drug, then we do the end dilutions test. We make it a dilutions, and if you make the dilution still the drug is positive, then it is due to the drug molecule, not due to the preservatives. So these are the tests which you have to do. You have to prepare yourself. Your pharmacy should be there. Now coming to the patch test, or T-cell mediated, or delayed reading intradermal test. These you have to make your own pharmacy. You make the 30% dilutions with the petroleum jelly and put on the back, and then look for the reactions. Most of these tests are done in a scar, means systemic cutaneous adverse reactions. So these tests, they are not standardized, but still they are done for the sake of that whether they should be given alternative drug or not. So these are the, DRESS syndromes, systemic diseases, and keratoconus 10, that this involvement of the mucosal DRESS syndrome, eosinophils is there, neutrophil, AGEP, and this is eczema. So patch test and intradermal test are directly indicate that this patients can be due to this drug molecule. Now another test is their LTT. LTT directly can indicate the T cells, but it is not available. It is still in the pipeline. So we have to depend only on the patch test. Penicillin is the most important. You have to delabel the penicillin. I told you the dose. Where you will do the skin test, 3 types of the reactions will be there, beta-lactam. Either the patients will have got only the MPE, the maculopapular eruptions, either there will be anaphylaxis, either the patients will have got a scar. So 3 clinical presentations you will get with the beta-lactam. So what will you do? In MPE, there is no need of doing any skin test. Guidelines says directly go for the oral provocation test. But in case of the anaphylaxis, you have to delabel whether the patient is sensitive or not with a specific non-irritating dose. While in case of the scar with the beta-lactam, then you have to think for the alternative. Some of the reagents are available and directly one can do, which is a non-irritating dose. Now, another is their take-home message is the neuromuscular blocking agent. Now, you see most of the cases we see in the practice, during a perioperative, patients get adverse events, even the death occurs. Cases, one can sue even. So, why one should know? It should be the mandatory for the anesthesiologist and even for the allergist to do these 4 drugs, Fenta, Propofol, Atracurium, and Midazolam. Because these 4 drugs are the only most drugs which are being used, and they should do the skin test because their sensitivity and specificity is the tune of more than 90%. If the patient has a history of a recurrent anaphylaxis, and this we have seen during the COVID pandemic also. MP is there, I told you, direct the OPT can be done. Now, some of the quinolone groups depend on the OPT also. There is a cross-reactivity between them. Ofloxacin and levofloxacin has got a cross-reactivity. So, patient who is sensitive to the ofloxacin, one should avoid levofloxacin. But Cipro and the other gemifloxacins can be given as a separate OPT. NSAID is another story. NSAID, I told you there is a aragonide acid metabolism do occur. And this you have to depend only on the OPT. You give aspirin to the patients and you look for whether the patient is cross-reactive or it is a cross-selective. If the patient is a cross-reactive, means he has got a NERD, NECD, NIUE, these patients, none of the NSAID can be advised. But if the patient is a cross-selective, then either one of the 5 groups of the NSAID can be advised. So NSAID is to be diagnosed only by the aspirin provocation test. So there are certain criteria by which you can say, I just show you that this case, 41-year-old male, no underlying disease, acute angioedema, 1 hour after ibuprofen. So what is the diagnosis in this case? Will be that this case has got a NEOI because this is immediate reactions occurs and it is a cross-selective. So some of these cases are there which we differentiate on the base of the OPT. You can differentiate that this patient is a cross-reactive or cross-selective. Second is the RCM. RCM is a very common. Most of these patients, they say, doctor, I have got a history of the anaphylaxis. So we must have a parameter which is safe. If the patient non-ionic is there and safest drug is there, initially the patients were giving perioperative prophylaxis drug. Now it is debatable, but now skin test will tell you whether this patient's which type of the safest can be given. The list is there. You can go through the literature of my book. Then you will find out that this is the safe. Another is the type 2 reactions, erythroderm, or type 3 reactions, as I told you, serum sickness-like syndrome. So these are certain in vitro tests. Most important vitro test, if you have got a history of the anaphylaxis, serum tryptase and IL-6. Nobody does this. IL-6 is more important. People, they think that initially we were not knowing it, but IL-6 will also indicate if the patient has got a history of the fever, chill, rigor, during you do any of the drug or basically of the molecular antibodies. So friends, immediate reactions are there, Ig mediated, non-Ig mediated, cytotoxic T cell mediated, delayed reactions, T cell mediated, single organ involvement, and HLA associated drug T cells, what we call is a SCAR. So these patients have got a specific classification, and one has to know that these need delabel or if desensitization. Desensitization is a special procedure by which you can induce the tolerance, but it is a temporary process. Like most of the cases, they are referred to us, doctor, I have got aspirin, which I get MPE, what to do, I am getting stent or other thing going on. So we used to desensitize with the aspirin. We start from 1 milligram and reach up to 75 milligram, and then one has to maintain. It is a temporary process, so one has to continue. With this, thank you very much for your kind attention.
Thank you, Dr. Kathuria. So without wasting time, we go to the next topic. And I told you earlier that whenever you are going to do the test or starting the immunotherapy, your center should have the emergency tray, how to manage if there are any anaphylaxis. So that is very, very important. Thank you, Dr. Kathuria. Thank you so much. So for that, I will invite Dr. Sonam, and who is associate professor in Vallabhbhai Patel Chase Institute, and he has been doing the allergy testing and immunotherapy, I think, for last 7-8 years, and his publications are in the field of allergy immunotherapy. Recently, he has gone to present his paper in Yaqui and Apache also. So over to Dr. Sonam.
Thank you for the nice introduction, sir. And thank you for the organizing committee for the inviting me for talk on this important topic of the allergy workshop, that is anaphylaxis. So whenever we conduct the workshop or any lecture on the allergy and immunotherapy, the attendant or the delegate always asks, what is the chance of anaphylaxis, sir? Is there a risk? Did you see the anaphylaxis? The people are eager that if I start the allergy and immunotherapy, if I start the skin prick test, what happens if the patient got the anaphylaxis? Which is, yes, a common it is not common, but it is reported with the both of those things. So in the next 20 minutes, I just go through the basics of the anaphylaxis, what are it and how it can happen, and then how to treat then anaphylaxis, which is an important. So what's the anaphylaxis? It is defined as an acute life-threatening systemic reaction that have a wide range of clinical manifestation. It can be fatal without evidences of cutaneous involvement. Usually it is associated with cutaneous involvements. That's why till recently we have no any universal agreement on the definition of the anaphylaxis. There are no any universal agreement till recently for the diagnosis, clinical diagnosis of anaphylaxis. And if we look in the literature, in the last 20 years, the definition of anaphylaxis, every second year or every alternate year, there are the anaphylaxis definition was changed by some of the societies or some of the guidelines from 2001 to the 2022, including the 2006 NICAAICON, which is commonly quoted in the WHO and ICAAICON guideline in 2019 and 20. So the overall, there is the confusion over the clinical definition. So recently published in the 2025, the Gallen 2 study report on the consensus report in 2025 about the anaphylaxis definition. And this consensus report is done by Delphi consensus from the 46 experts from 14 countries, including 7 specialties. And they drafted this with these 46 experts, and they try to define the anaphylaxis. And according to this, the anaphylaxis is defined as a serious allergic or hypersensitivity reaction that progresses rapidly and may cause death. That is the including in this definition. And it may involve the skin and mucosa, including the lips, tongue, respiratory, lung, and the breathing, cardiovascular system, heart and blood pressure, and gastrointestinal, stomach, and gut system. In life-threatening anaphylaxis is characteristic by respiratory and cardiovascular involvement, may occur without skin involvement. And this anaphylaxis definition, the expert agreement was 43 out of 46, that is nearly 94% was agree on this definition of anaphylaxis. So we have now the better definition for the anaphylaxis recently published. So the global incidences is 50 to 112 episode per 1 lakh per person year, and lifetime prevalence is 0.3 to 5%. Recurrence of reaction, one after the recurrence can be possible in 26 to 54%. Despite this much of the anaphylaxis, however, mortality still remain low. The mortality is 0.05 to 5% for drugs, 0.03 to 0.3 for food, and 0.09% to 1.3 for the venom. So these are the various triggers. The most common trigger is food, drugs, and the stings, and the allergen immunotherapy less than 1%. Food is the common, 35 to 55%, and it can accidental, and it is usually during the first 5 years of the life in the children below the 3 years, and incidences of peanut allergy is double in this age group compared to the adults. Food, these are the 8 food routes which account for 90% of the food allergy anaphylaxis trigger, and sir already shown that the 9 sesame was added in 2021. About the medication, again 5,50,000 allergic reaction to drug years in US per year in US. The most common, Kathuria sir already told that penicillin group are the commonest trigger, then beta-lactamase and non-steroid anti-inflammatory drugs. Intravenous have more than the oral drugs. Then, despite that, many of remaining are idiopathic, nearly 50% by the most of the study, and one of the study even found that 70% of the drug these reactions remain idiopathic, despite extensive testing, extensive history, and all possible testing, including mastocytosis. So what are the symptoms if you suspect with the anaphylaxis? The most common symptoms is cutaneous, including urticaria and angioedema seen in nearly 90%, flushing in more than 55%, then sometimes pruritus without rash also. The second most common involvement system is the respiratory, that is dyspnea and wheeze in 50%, again upper respiratory angioedema in 50 to 60, rhinitis in nearly 20%. Then cardiovascular, including hypotension, giddiness, syncope, diaphoresis seen in 30 to 35%. Abdominal symptoms, including nausea, vomiting, diarrhea, abdominal cramps, again in 25 to 30%. Then the miscellaneous like headache, substernal pain, seizure occurs in less than 5% of the cases. So these events are rapidly progressive. Within 5 minutes, if it is atogenic reaction, venom usually 15 minutes, food more or less late, sometimes up to the 30 minutes. Differential diagnosis, all the reaction which is occurring within a minute, including vasovagal, myocardial infarction, insulin resistant, hysterical reaction, laryngospasm, medical toxicity, carcinoid, hereditary angioedema, and systemic mastocytosis. So the important is how to differentiate between the vasovagal and anaphylaxis. The vasovagal are usually immediately, while the anaphylaxis usually occurring within the 15 minutes. In the respiratory system, here the breathing is normal and may shallow, but not laborious. Where in the anaphylaxis, all system coming together like cough, wheeze, stutter, hoarseness of voice, distress, tachypnea, everything comes together. In the cardiovascular, the vasovagal bradycardia, anaphylaxis tachycardia, here strong carotid pulse, where weak or absence of the pulse. Consciousness usually remains in the loss in the vasovagal, and it is not lost in the anaphylaxis. Skin in the vasovagal usually cool, chlamydia skin, where again in the anaphylaxis every symptoms coming together: pruritus, journalase, erythema, urticaria, angioedema. Gastrointestinal, here nausea and vomiting, where the cramps and the diarrhea are more common in the anaphylaxis. In neurological, feeling of pain and light headache, where there is a sense of severe anxiety and distress. So treatment, be prepared. Whenever you're doing a skin prick test, we should have an emergency test. If somebody has happened with the anaphylaxis with anything or not during skin prick test or anything, we have to have an emergency protocol, remove the allergen if there is continuously, then do the ABC, airway breathing and the circulation, and then call for the help from others, and just give the injection, that is epinephrine or adrenaline, 0.01 milligram per kg on the anterolateral aspect of thigh intramuscularly. This is the life-saving drug and the drug of choice for treating anaphylaxis. Then we go for the keep the patient on the back, then oxygen, then IV fluid. What we people are doing, we first try to give the oxygen, inhalation, and then IV fluid. If you are suspecting an anaphylaxis, first you give the epinephrine, that is the life-saving. Then this is again the remove the source, keep the patient flat, give the intramuscular adrenaline on the mid-thigh of the with an intramuscular injection. The dose is 0.3 to 0.5 ml. Ratio, concentration is 1:1000, which is commonly available in India in the same concentration. Then other drug what we can use with this after epinephrine is the antihistaminics and then steroids and the H2 antagonists. This is the dose of the epinephrine in according to the age and the weight of the patient. Then failure to administer epinephrine promptly is the most important factor contributing to death in a patient of anaphylaxis, and vasopressor effect of epinephrine along with its effect in the preventing and relieving the laryngeal edema and bronchoconstriction may be the lifesaver with this adrenaline. The recent guideline says that intramuscular epinephrine should be given immediately even for suspected anaphylaxis. If we are suspecting it, the intramuscular epinephrine is not harm, we can give and can be given for a patient who do not fulfill the criteria based upon the clinical diagnosis. You are suspecting the patient may have an anaphylaxis, you can give it, and the dose already I say, and we can repeat after 5 to 15 minutes also. Why it is has this many effect? Because it's effectively on diastolic, systolic heart rate together within the 10 minutes of onset. Why not antihistaminics and the other corticosteroid for first that antagonist that receptor only and slow action than the epinephrine, and guideline support to give this should not support to replace with the epinephrine and never to treat alone with the antihistaminic and corticosteroids. Other we can ranitidine, cimetidine, nebulize, methylprednisolone, dopamine if hypotension is there, and glucagon we can also use. Then sometimes we require 2 doses of epinephrine. Different studies from different part of the world shows that nearly 15 to 35% of the anaphylaxis require more than 2 doses of epinephrine. And the second dose may be administered within the 5 minutes if it is not responding, but there is no way to predict who will require the 2 doses. It's depend upon the severity of the reaction. Then long term after the first anaphylaxis, to identify the trigger by history, testing, immunological consultation, and written action plan, and then availability of the epinephrine auto injection, which is not available in our country, and try to find the risk factor for and the fatality of these things, and recommendation to carry the mobiles or the exercise-induced anaphylaxis in the pockets, and to avoid allergen immunotherapy or desensitization if severe reaction is occur, medication, identification alert like wearing of bracelet with those who are having the anaphylaxis, or this wallet card in the pocket, and register if there is registered in particular country. Then education and training, public health, these are the important part long-term management. The long-term management consists of this discharge and try to find out the testing, what are the triggering factor, and then try to avoid or to treat those treatable things. Coming to the auto-injection epinephrine, it is a medication that quickly reverses the anaphylaxis, open airway, raise blood pressure, and reduce swelling with a pre-filled auto-injection in the thigh. Best work when given early. So the people used to carry their own auto-injection, just put here the safe injector. It is an auto-injection, but unfortunately it is not available in India. So about the availability of this auto-injection epinephrine, that epinephrine is recommended as an essential medication for anaphylaxis by WHO. Despite its pivotal role, this is not readily available in most of the countries, not only in India. It is limited to only 32% of 195 countries, that's mostly in the high-income countries. In the sum, there are distribution special licenses in the name of the suitcase state. However, this is unofficial source, is unreliable and undesirable. So does epinephrine use in the anaphylaxis? This study was a multicentric study done in the Europe among the children, and they found that among those patients who had food-related acute illness, only 3% receiving the epinephrine, and among those food-related anaphylaxis, 6% receiving, and 2 doses are receiving in only 12%. As per their study, they found that only 20% of the patient with a food-related anaphylaxis receive the epinephrine. Rather, they receive 60% antihistaminic, corticosteroid, IV fluid, and beta agonist. Those 20% who receiving the epinephrine, the dose of the route was subcutaneous in 75. So it is wrongly. So most of the people did not know how to treat the anaphylaxis. It is the epinephrine intramuscular is the route to give. Then again, this paper again published this year only. It is a European anaphylaxis registry, and they found that allergen immunotherapy account for 1.1% of whole Europe anaphylaxis. So much less with the allergen immunotherapy, and they out of that 96% received the treatment. However, 80% were treated again with antihistaminics and corticosteroid rather than the epinephrine. Only 30% of grade 2 and 50% of grade 3 received the adrenaline, remaining usually treated with the steroids and antihistaminics. Other option, we have the by pre-medication with antihistaminic steroids, solo infusion in the biologics and others. Small studies found that omalizumab and some methylene blue in some case report are also true. Prevention, avoid the trigger, carry the epinephrine injection if available, wear the ID like bracelet and call, in inform school and the workplace, in anaphylaxis action plan. Little bit about the anaphylaxis and skin prick testing, as we are doing the workshop on the skin prick testing or allergen immunotherapy. It is very rarely seen with skin prick testing, seen in less than 0.02%. Again, if it is more with the food, latex and drugs, intradermal slightly more risk than the skin prick test. This study with 55,000 patients showing only one anaphylaxis reaction. Again, another study of 25-year study of systemic review found that 17 cases of skin prick test related anaphylaxis. Out of them, only 5 were with the yellow allergen. Then little bit about the allergen immunotherapy in anaphylaxis. Does allergen immunotherapy is a risk factor for anaphylaxis? This registry of 16 years from 54 centers from Europe found that only 173 anaphylaxis out of nearly 16,000 is accounted by the allergen immunotherapy, accounting for 1% of the total. Respiratory symptoms are more in adult pediatrics, while gastrointestinal and cardiac are more in the children. Sublingual allergen immunotherapy among 8 only, remaining 153 with the subcutaneous, and only 1 fatality out of this registry. Skin and symptoms are both in pediatrics and adult are similar. Respiratory more in the children, other are more in the pediatrics age group, adult age group. Allergen extract more commonly with pollen, then venom, and among these 3, house dust mite has less. Immediate reaction, I already shown this slide that only 30% of grade 2 and 50% of grade 3 receive the adrenaline, remaining majority are treated with corticosteroid. Little bit about our experience, we doing the skin prick test and the allergen immunotherapy from years in Patel chest. Data from last 2018, 6 years, we did more than 4,200 with more than 12,000 testing with various skin prick tests. No single anaphylaxis was seen during this 6.5 years. In this paper, what sir says, I present it. This is a prospective study planned for last 3 years with try to find out any allergic anaphylactic reaction or any complication with skin prick test 1,264 patients undergoing skin prick test for 58 allergen and 68 food allergen. None single anaphylaxis is recorded. Only 7 cases had mild reaction like pruritus, itching, headache, something like that in the 7 cases. So recommendation, special attention to young children with a history of previous systemic reaction and high reactivity. Pregnant lady, just try to postpone. If there is immediate reaction, need do an serological testing. So I am summarizing with the anaphylaxis. It can be caused with food, venom, latex, drugs, exercise, and many remaining idiopathic. Prevalence underestimated up to 12 million are risk of anaphylaxis. Several symptoms coming together at the same within a minute that's with the contact of this allergen. Epinephrine intramuscular 1:1000 is drug of choice on mid anterolateral thigh. Very rarely seen with skin prick test and allergen immunotherapy. Thank you very much.
Thank you, Dr. Sonam, giving a very nice perspective of the anaphylaxis, doing allergy testing and immunotherapy. Thank you so much. So we have now the last lecture, and that is, basically it's very important to see that how you set up the allergy testing clinic. So for that, we have Dr. Gautam Modi, who is practicing for several years in Patna, and he has got a beautiful center. I have visited his center, and lot of patients he sees daily. So he is going to give us about the how to set up allergy testing clinic. Over to Gautam Modi.
Thank you so much. The patient audience, my father figures sitting in the audience today, Dr. Rajkumar sir, Dr. P.C. Kathuria, Dr. V.K. Jain, Dr. Nagendra Prasad, Anil Jain ji, Naveen Arora ji. I come today in the last as an exterior specialist. You have been listening to wonderful scientific deliberations of how to proceed ahead.
Yeah, I will put my perspective here. It's not the last, very important, because you know everything now, you're starting from history and everything. So if you want to set up a clinic, it's a very, very important.
Yes. In Bihar, late Dr. R.K. Modi. And for you all, it's a transition. You see me coming from an audience on the stage, and that is the process of learning. So, Allergy Clinic is basically a center of excellence in allergy testing and treatment of allergy. When you start an allergy clinic, you must have 3 P's. You must be prepared. You must be prepared to start an allergy clinic, and you must feel proud that you are going to start an allergy clinic, and then you must promote yourself and your allergy clinic, because you are going to deal one of the most rapidly growing menace in our society, in our country, and globally. So it's an effective asthma and allergy treatment center. This is the jumbled up picture which you face when you start an allergy clinic. These are the various forms in which diseases, disorders, manifestations will represent in front of you. You have to take care of it, and you see on your left corner, Pratyurjita is written. That is the Hindi version of allergy, what we know in our country as. So why is allergy a growing disease? We have got multiple reasons for it. One of them, environmental factors, increased exposure to chemicals, increased antibiotic usages, and lifestyle differences, which is going on degrading day by day. And thus the allergy prevalence in our country rises markedly, and so does commercially the therapeutic market rises, which is about 68.38 crores by 2030, what we are anticipating. So allergic rhinitis, bronchial allergy, nasobronchial allergy, dermal, drug allergy cases, all these combined, you are always listening that one or other member of your family, of your surroundings, of your known, has got a reference to this term ALLERGY, allergy, and which in turn solicits and endorses that you will be approached to or sought after as an expert for as an expert advice. So these are the allergy factions what your clinic must have. You must be able to very successfully deal in drug allergy, food allergy, which sir has so beautifully explained, Dr. Rajkumar sir and Dr. PC Kathuria sir. And these are the rhinitis, inhalations, asthmatics, ocular allergies is very common nowadays. And of course, Dr. Sonam has highlighted the anaphylaxis chapter so very well. And this is the SPT methodology which has also been described. So these are the combined setups. These are the cases you might be seeing, and these are the setups you must have in your allergy clinic. If I go back, it was exactly in 1951 that officially the first allergy clinic in the world was set up by Dr. Harry Alexander in Midwest US. Of course, we have a very clear demarcation of Charak Samhita, 4th century BC in our ancient texts. And historically, allergy treatments involve from basic remedies to learning more advanced diagnostic treatment approaches. And thus, the emergence of you as a specialized allergist has to significantly contribute to the growth effectiveness of allergy clinics in addressing complex allergic conditions. I must say that, and I am a witness personally, that over the time allergy clinics have evolved to incorporate innovative technologies, personalized medicine, and evidence-based practice for better patient outcomes. What are the basics of allergy clinic? You plan to start a clinic. What are the basic things you must have in your mind? You must understand and accept that you are going to run a specialized care center. If you run a specialized care center, you may give help as a normal person in a normal conditions, but you must accept yourself to be a specialist for specialized conditions. So it is a state-of-the-art healthcare facility that will focus exclusively on diagnosing and treating various kinds of allergies and managing them associated other conditions. Please keep it in mind that pharmacotherapy is something which is very rampant nowadays by authorized or unauthorized persons. So when the ball jumps into our court as an allergy specialist, you must take it as a state-of-the-art healthcare facility where you will be addressing the cause of the suffering, and subsequently it will be expected from you that treatment appropriate and judicious is given. These clinics offer total diagnostic tests both in vivo and vitro, dealt very nicely with our learned teachers, to identify the specific allergens. Further, for treatment, specific immunotherapy is prescribed, either SCIT or SLIT. Both have been dealt very clearly. And allergy clinics, they will involve allergists, specialists from various other departments, nursing, paramedical staff, and healthcare personnel working together to provide comprehensive care. This section involves the scenario of a patient walking right step one into your clinic. He must get an impression that yes, he has come to a place where his suffering is going to be minimized and a proper treatment approach is to be given. So this is the pictorial depiction that what is you are going to face when you are dealing with an allergy clinic. So what are the fundamentals of allergy clinic? Immunotherapy, allergy shots or sublingual tablets, skit or slit, is primarily the most sought out thing for which a patient walks up to you. So the difference between pharmacotherapy short-term goal and immunotherapy long-term goal for the allergy treatment starts at this very allergy clinic. So it is mandatory that you gear up yourself that you are going to have the treatment modality in the form of skit or slit at your clinic. Understanding common allergy triggers like pollen, fungus, dust mites, dander, insects, and food allergens is essential for acute diagnosis, not just for you, but for your patients also. Dr. Rajkumar sir just now said he had visited to my center, and it was a very good advice which he had given, that small pamphlets be there for the patients to know regarding their suffering and prepare themselves while sitting there in the waiting room itself that yes, they have to take this treatment. These are the few charts, types of allergies. This can be put out on your waiting area. These are the triggers what the patient will feel. When he will see these, he will might feel that yes, अरे ये चार चीज़ें तो हम करते हैं. जब ये चार चीज़ें करते हैं तो इनसे हमको better feel होता है. And then what are the common agents by which the patient gets allergic reaction? What are the essentials of allergy clinic? You must have in vivo vitro testing methodologies, and they must include medications because immediate relief has to be given, anaphylaxis management has to be there, immunotherapy, and then certain lessons for lifestyle modifications. You could incorporate a good lifestyle instructor once in a week or once in 15 days. It's a practice at my center also that yoga teacher is coming and he will teach you the elements of a better adoption of lifestyle. And patient education for comprehensive care, which is very important. Conversation with patient, listening to them and giving them a proper understanding advice is very important. Regular follow-up, essential to address treatment effectiveness for adjusting therapies and managing new concerns. Regular follow-up to address treatment effectiveness, if it is dealt very properly, I can assure you that the fallout ratio will minimize. It will come down. But the fallout for immunotherapy is more because once the patient is on immunotherapy, we are not giving him adequate time to settle down and understand that yes, he is improving or his quality of life score has improved. These are the prick testing, intradermal testing, modified quantitative testing, RAST and patch, which already sirs have already shown you, and how it is to be done. Sessions have been taken. Importance of allergy practice, one of the most important slides in my talk. You must understand why it is important to take up allergy as a specialty, why it is important that you can start an allergy clinic, because you will confirm allergies through better diagnostic, develop a better treatment plan, patient will go less on drugs, have more specific treatment, and the 3 steps that you will understand allergy testing, why it is important, and make the patients also understand what are the types of allergy tests. This will be also made it clear to the patients, and when to get allergy test done. It is not essential that a person is walking in your clinic and you tell him that yes, you have to get an allergy test done. It is you and only you who has to assess and rationally decide when to get a test done. These are the few allergy clinic models which I am showing. and it's a globe models. We have got few in our country also. And the three, you can see that architecture wise, you will see that one is a building, one is a ground floor only, and this looks more of a rural setup in US where they have. This was Dr. Sonam was talking very clearly. This they practice in Japan very clearly. India में हम लोग इसे भाईजान का bracelet कहते हैं, Salman Khan, but this is a very common practice in Japan where they give, allergy clinics give a bracelet for people having hypersensitive reactions to fishes and food items and also history of anaphylaxis. Some extra label or something extra could be given to patients suffering from anaphylaxis, and regulatory requirements, licensing certificates and insurance regulations is very, very needed. Unfortunately, in our country so far, when we talk about medical regulations and when we talk about health policies, allergy is one aspect which has not been very widely addressed and accepted. So you may have some problems initially, but I hope by in the next 2, 3, 4, 5 years down the practice, when you start picking up, things will improve to a better standard. Challenges, you can have resource allocation, cost has gone up. You must have a very good patient education programs. You must have a good data management and form partnerships with laboratories, hospitals, pharmacies, and patient advocacy group for enhancing. I always have found that old patients are the best referrals. Patients who have improved, patients who have had a marked quality improvement of life, they are the one people who will say that you must go and consult an allergist. Legal aspect, very important. These are the 4 picks. One is the problem, one is the working staff, one is the doctor, and this is how the people, this picture has got an inclusion of all the other faculties also not dressed in the medical attire, and they are your legal partners. Legal partners who will keep you safe, and in spite of your best of efforts, when the questions are raised, they will say that no, this person working on this patient has been judicious and as per the copybook under the rule guidelines. So what are the future trends? The future trends lies in personalized care, genetic profiling, targeted therapies. Newer vaccine research is going on. And this is one of the pictures which I took last year in Denmark on 23rd of August 1960. The first vaccine was given to a patient by ALK Laboratories Copenhagen. India is also somewhat 1 or 2 years up and down. So we are keeping up with the pace globally. A successful allergy clinic will involve many specialities. We must recognize who are the potential people who are in favor of continuing with the science of allergy, chest medicine, GP referrals, occupational, ENTs, patient information, clinical inflammatory, even GIT specialists. So patient information is very important, that time to time reminders should be there that yes, there is a treatment available. I remember that when my father passed away in 2016, there was a question raised whether that allergy treatment will be still available or not. So to this extent, the people are more inquisitive. So you have to reassure them that yes, this treatment is there now and they can avail it. These are the pics of some clinics which you can see globally, different setups. You see on this pic, even weed and grasses are grown here. One of the patients walking in through here may have an allergic reaction to them. But because it's in a place called Nashville probably, so they have kept it at a very local standard so that when the patient walks in to such kind of a setup, he will not feel out of the place. These are the lounges which people keep in the allergy clinics, and it should be well lit, decorated, and overall the patient, when he walks into an allergy clinic, he should feel specialized, he should feel that he has come at a good place. These are the various methodologies by which they do SPTs. So this is one-to-one, one-to-one. And here you can see that an extra attention is being given by this lady to the person, that he is sitting there and nothing wrong is going to go on with him. And these are the various types of immunotherapy. You can see the doctor here giving here, here, and here. Any of these things you can adopt and keep incorporate in your practice. Emergency room is a mandatory setup for any allergy clinic. Dr. Sonam has very well emphasized on managing anaphylaxis efficiently. And these are the various logos. And out of the global survey, this logo was picked up as the best because this was the most simplest form of communicating. When you walk into such kind of a setup, you are having a jumbled view. So have a clear-cut message, clear pic of your clinic. I dedicate this talk to my late father, Dr. R.K. Modi, who started the clinic. And lastly, the best pick where I learned the masters of allergy treatment. So be prepared to treat everyone unless and until you find someone who's allergic to everything and everyone. Thank you so much, sir. Thank you.
Thank you, Dr. Gautam. It was a really excellent lecture, I must say. And last but excellent. And I think we have learned how to take the history, then after taking the history, how to go ahead with the investigation, in vitro, in vivo method, and when the test come positive, how to correlate with the history of the patient, and when the history is correlated with the your test and everything, that becomes allergen. And then you can do the avoidance. Sorry, we have not taken the avoidance because we said everything becomes too lengthy to convert. And then after that, you should give the immunotherapy. The best modality is the single is the allergen. The best is the result basically. And you can either practice skit or the slit. It has been shown in the literature and the publications that skit is better than slit, but slit safety wise is better than the skit. So either of them can be chosen and that can be used. Both are effective. If you see with the placebo or the pharmacotherapy, both are effective. And of course, when you start any clinic, you need to have the emergency tray with you, and you should be able to know the management, anaphylaxis management, and so on. And of course, you should know about the food allergy, you should know about the drug allergy, and at the end, if you know everything, you should be able to open a good clinic, just like Dr. Modi had shown his clinic, and so on. Again, I am trying to tell you that this is just a sensitization. Please, after getting the certificate, you should not think yourself that you have become the allergologist. Still, we are learning. So I will conclude and I will here only, and we will break up for the lunch. And after the lunch, we divide ourselves into 5 groups, and the 5 groups already stations has been made, and stations are history taking. Dr. Ayendra Prasad and his team will be there. If Dr. Ayendra Prasad is not there, Dr. Kushwaha, you should be there with another faculty member. Then skin testing, Dr. Kulwal, I think, going to join and with his team. Then intradermal test, Dr. V.K. Jain and the team. And slit, Dr. Nagendra Prasad and his team. And skit, I will request Dr. Sonam to be there so that that can be explained. Outside this room, there are 5 stations has been already made. Tables are there, chairs are there. And I think if you make a group of the 10, so that will serve our purpose. With that, I conclude, and I think organizers, if it is okay, then we'll break for the lunch. अभी और 5 मिनट लगाओगे? हाँ, बुला दें? बताइए जल्द. Okay, instead of Dr. Kulwal, Dr. Jain will be there. There is no problem. So, stage based. So all faculty members are requested to come on the stage. We'll have a group photograph, and organizers wants to present a memento to us.
हाँ जी कुशवाहा साहब स्टार्ट कराओ. हाँ मेरे एक एक करके दे, सबको इकट्ठे दे दो ना भाई. वेद प्रकाश जी सारे हम लोग खड़े हैं, आप एक एक करके सबको दे दो आप मोमेंटो. हाँ आइए सर खड़े हो जाइए.
Thank you, Ved sir, for felicitating Dr. Rajkumar sir.
A token of appreciation to our national coordinator of this workshop, Rajkumar sir. I request sir to felicitate Professor PC Kathuria sir. PC Kathuria sir. Yes sir. Yeah. ये PC Kathuria sir का दे दो. नवीन अरोड़ा sir. सीक्वेंस में दो यार. हाँ, ठीक है. हाँ. अब किसका दे रहे हो मुझे तो बता.
PC Kathuria sir.
वो तो गया ना राजेंद्र सर. प्रोफेसर राजेंद्र प्रसाद सर. अब किसको सीक्वेंस ठीक. मोदी में क्यों दे रहे हैं? गलत सीक्वेंस है क्या? गौतम मोदी सर. लेटेस्ट से दो भैया. नवीन सर. प्रोफेसर वीके जैन सर. ये नहीं है, अभी नहीं है. और ले आओ. वो है नहीं है. केवी नागेंद्र सर. डॉक्टर सोनम सर. हो गया. और लास्ट बट नॉट द लीस्ट, our coordinator of the workshop, Kushwaha sir. किसको दे रहे हो?
Thank you all for very patient listening. The inaugural ceremony will be held in this hall at 5 p.m. today, sharp at 5 p.m. and you have to come here before 5, 10 minutes before 5. So all are requested to move for lunch. Thank you for patient listening and being with us. And thank you all. और जो भी जितने डेलीगेट्स और फैकल्टी के स्पाउस जो आए हैं, उन सबको भी हम लोग इनवाइट कर रहे हैं कि हमारी जो इनॉग्रल सेरेमनी है उसका हिस्सा बने सभी लोग। मैं बहुत बहुत धन्यवाद देता हूं हमारे राजेंद्र प्रसाद सर जो कि ऑर्गेनाइजिंग चेयर हैं, और हमारे लिए जो पैट्रोनेज है उनका, वीके जैन सर और राजकुमार सर जो नेशनल कोऑर्डिनेटर इसको सफल बनाने के लिए, जो आप इतनी देर से, इतनी भीड़, मुझे लगता है कि सर इतनी भीड़ कई बार कॉन्फ्रेंस में दिखती है जितनी आपके वर्कशॉप में है। तो बहुत ही ओवरवेलमिंग रेस्पॉन्स जो रहा है डेलीगेट्स का, और मुझे लगता है कि पैन यूपी से डेलीगेट्स हैं, बाहर से भी हैं। मैं सबका स्वागत करता हूं, और ऑन बिहाफ ऑफ इकाईकॉन एंड ऑन बिहाफ ऑफ द ऑर्गेनाइजिंग कमेटी, यू ऑल आर मोस्ट वेलकम एंड मूव फॉर लंच। बट बिफोर हैंड राजेंद्र प्रसाद सर से मैं अनुरोध करूंगा कि 2 शब्द कह दें सर।
I think it has been very good workshop here on allergy, and I went down also on the second floor. There is a workshop on advanced PFT. That workshop is still, I think, is going to finish there. I think now you are all invited for the lunch. And as Dr. Ved said very rightly, the inauguration is at sharp 5. So probably we have to assemble. As you know, the Deputy CM of this state is the chief guest. So you have to assemble about 10-15 minutes earlier. And as told by the Ved, since this inauguration is preponed because of the chief guest availability. So whose faculty has spouse, has come with the spouse, they are all requested to come with the spouse. Thank you.
respected dignitaries, esteemed faculty, distinguished delegates, and dear friends, Namaste, Adab, and welcome. It's a wonderful evening here in Lucknow, a rainy one for sure, the city of culture and heritage. We are delighted to have you all with us as we come together to celebrate learning and the spirit of medical excellence. On behalf of the Department of Pulmonary and Critical Care Medicine, King George's Medical University, it gives me immense pleasure to extend a warm and heartfelt welcome to all of you to the inaugural ceremony of ICAAICON 2025, the 59th annual conference of the Indian College of Allergy, Asthma and Applied Immunology. I am Dr. Harshita, and it's my absolute honor to be your host for this evening. We are truly honored to have among us a constellation of distinguished dignitaries whose presence lends immense grace and significance to this inaugural ceremony. It's our proud privilege to welcome our chief guest, Honorable Shri Brajesh Pathak Ji, Deputy Chief Minister and Minister of Health, Family Welfare, Medical Education, and Maternity and Child Health, Government of Uttar Pradesh. Sir, your visionary leadership and steadfast dedication to strengthening the healthcare system in our state continues to inspire us all. So kindly take your seat on the dais. We welcome you, sir. We extend a warm welcome to our Chief Patron, Padma Shri Professor Dr. Sonia Nityanand Ma'am, Honorable Vice Chancellor, King George's Medical University, whose dynamic leadership continues to guide and inspire us. A very special welcome to Padma Shri Professor Dr. Digambar Behra Sir, Emeritus Professor and former Head, Department of Pulmonary Medicine, PGI Chandigarh, and Director, Pulmonary Medicine, Fortis Healthcare, Mohali, a stalwart in respiratory medicine. Welcome, sir. We are honored to welcome our respected guest of honor, Professor Dr. Rajkumar Sir, Director, Vallabhbhai Patel Chest Institute, Delhi, a visionary academic leader whose contributions to pulmonary medicine are exemplary. Welcome, sir. We warmly welcome Professor Dr. Suresh Kulwal Sir, President ICAI and Professor and Head, Department of Pulmonary Medicine, Mahatma Gandhi Medical College, Jaipur, a respected leader and a passionate advocate for advancing allergy and respiratory medicine in India. We also warmly welcome Professor Dr. A.B. Singh Sir, Secretary ICAI and Emeritus Scientist, Ex-Emeritus Scientist, CSIR Institute of Genomics and Integrative Biology, Delhi University, a pioneer in allergy research and creator of India's national pollen calendar. Welcome, sir. Next, we take immense pride in welcoming Professor Dr. Rajendra Prasad Sir, Chairman ICAI, Director Medical Education and Professor Respiratory Medicine, Eras Lucknow Medical College and Hospital, Eras University Lucknow, Vice Chair National Task Force NTEP India, recipient of the prestigious BC Roy Award and a guiding force for pulmonologists nationwide. We warmly welcome Professor Dr. Suryakant Sir, Editor-in-Chief ICAI, Organizing Co-Chairman, Scientific Chair ICAI, and Professor and Head, Department of Respiratory Medicine, KGMU, an inspiring teacher and an eminent clinician whose guidance continues to shape many young pulmonologists. Lastly, we extend a warm welcome to Professor Dr. Ved Prakash Sir, Professor and Head, Department of Pulmonary and Critical Care Medicine, KGMU, Lucknow, and Organizing Secretary, ICAAICON 2025. His vision, his dedication, and meticulous leadership have been the driving spirit behind this remarkable academic celebration. And a warm welcome to all the respected faculty members, delegates, residents, students, and friends joining us from across the nation. With our esteemed dignitaries now amongst us, we move on to a moment of heartfelt appreciation and tradition. As a gesture of respect and gratitude, we shall now felicitate our distinguished guest with saplings, a symbol of growth, knowledge, and enduring legacy. May I request Professor Dr. Ved Prakash Sir, Organizing Secretary, ICAAICON, to kindly do the honors and felicitate our esteemed dignitaries. Our chief guest, Honorable Shri Brajesh Pathak Ji. May I request, sir, to felicitate our chief patron, Padma Shri Professor Dr. Sonia Nityanand Ma'am. Padma Shri Professor Dr. Digambar Behra Sir. May I request, sir, to welcome our respected guest of honor, Professor Dr. Rajkumar, sir. Professor Dr. Suresh Kulwal, sir, President ICAAI. May I request, sir, to welcome Professor Dr. A.B. Singh, sir, Secretary ICAAI. May I request, sir, to please welcome Professor Dr. Rajendra Prasad, sir, Chairman ICAAI. May I request, sir, to welcome Professor Dr. Suryakant, sir, Editor-in-Chief ICAAI, Organizing Co-Chairman, Scientific Chair ICAAI. We now move to the next auspicious part of this evening, the lighting of the lamp. In our tradition, light is the eternal symbol of knowledge, purity, and wisdom. Tamasoma Jyotirgamaya. May we all be led from darkness to light, from ignorance to understanding, and from knowledge to enlightenment. We now invite our esteemed dignitaries to kindly come forward for the lighting of the lamp ceremony, marking the formal inauguration of this academic celebration.
शुभं कुरु त्वं कल्याणं आरोग्यं धनसम्पदा शुभं कुरु त्वं कल्याणं आरोग्यं धनसम्पदा शत्रुबुद्धिविनाशाय दीपं ज्योति नमस्तुते दीपं ज्योति नमस्तुते शुभं कुरु त्वं कल्याणं आरोग्यं धनसम्पदा शुभं कुरु त्वं कल्याणं आरोग्यं धनसम्पदा दीपं ज्योति परं ब्रह्म दीपं ज्योति जनार्दन दीपं ज्योति परं ब्रह्म दीपं ज्योति जनार्दन दीपो हरतु मे पापं सन्ध्यादीपो नमस्तुते शुभं कुरु त्वं कल्याणं आरोग्यं धनसम्पदा शुभं कुरु त्वं कल्याणं आरोग्यं धनसम्पदा बोधि ब्रह्मारूपस्सवं ज्योतिषा प्रभुराव्यः बोधि ब्रह्मारूपस्सवं ज्योतिषा प्रभुराव्यः आरोग्यं देहि पुत्राशं मति स्वच्छा हि मे सदा आरोग्यं देहि पुत्राशं मति स्वच्छा हि मे सदा शुभं कुरु त्वं कल्याणं आरोग्यं धनसम्पदा शुभं कुरु त्वं कल्याणं आरोग्यं धनसम्पदा शत्रुबुद्धिविनाशाय दीपं ज्योति नमस्तुते दीपं ज्योति नमस्तुते शुभं कुरु त्वं कल्याणं आरोग्यं धनसम्पदा शुभं कुरु त्वं कल्याणं आरोग्यं धनसम्पदा थैंक यू
Thank you for that divine invocation. May Goddess Saraswati bless us all with wisdom, humility, and clarity in our pursuit of science. And now, to officially welcome all our esteemed guests and delegates, may I invite Professor Dr. Rajendra Prasad, sir, Organizing Chairman, ICAAICON 2025, to deliver the welcome address. Welcome, sir.
Namaskar. गुड इवनिंग। आज के इस समारोह के मुख्य अतिथि हम लोगों में बहुत ही पॉपुलर श्री ब्रजेश पाठक जी। मैं कई बार कह चुका हूं, एक बार इनकी अनुमति से मैं फिर कहना चाहूँगा। इन माय लास्ट 50 years of career of medical education, I have not seen any dynamic and proactive health minister of state of Uttar Pradesh. He is also Deputy CM of this very great state. Then in the dais, many people are sitting who are my own. Let me name first Sonia. I always call him Sonia because he has been my student. And majority of sitting in the dais have been my student. So I'll not name everyone. And then in the front rows, stalwarts in the field of allergy and pulmonary medicine are sitting. Many ladies, including my wife, is also sitting. All the students, all the delegates, ladies and gentlemen, persons from press and media. It gives me immense pleasure to welcome you all for this 59th annual conference of Indian College of Allergy, Asthma and Applied Immunology. To my memory, if I collect, पाठक जी को बताना चाहूँगा कि ये लखनऊ शहर में ये पांचवा यही नेशनल कॉन्फ्रेंस 5वीं बार होस्ट की जा रही है। 2 बार मुझे याद है मेरे गुरु प्रोफेसर MS अग्नोत्री, हम लोगों के सबके गुरु, जब मैं पढ़ता था यहाँ KGMC जब मैं पढ़ता था तब वो 2 बार ये नेशनल कॉन्फ्रेंस हमारे सामने करा चुके थे। जी सर, आपने बिल्कुल कलेक्ट किया। अशोक नगर में था जी। 2 बार उन्होंने कराया, 2000 में, उसके बाद मैंने स्वयं कराया जब मैं विभाग का प्रमुख था, TVHS डिपार्टमेंट का उस वक्त। उसके बाद एक बार डॉक्टर सूर्यकांत जी ने कराया 2016 में हमारे ख्याल से, मैं अगर सही याद कर पा रहा हूँ। और इस बार 2025 में मैं ये कहूँ मेरे परम शिष्य मैं कह लूँ तो कोई बुराई नहीं है, वेद साहब बुरा नहीं मानेंगे, अब तो ये प्रोफेसर अनहेड हैं, तो ये करा रहे हैं। और जब ये कॉन्फ्रेंस लेने की बात आई, एसोसिएशन में देने की इनके लिए बात आई, तो मैं भी बैठा था, तो मैंने कहा भाई ही इज़ अ वेरी कैपेबल मैन, he will keep his words and he will do it. That's why this conference was given to him, although he made me organizing chairman. मैं ज़्यादा समय नहीं लूँगा। एलर्जी एक ऐसा सब्जेक्ट है सर, बहुत कॉमन बीमारी है। आप भी जानते हैं कि ऐसा कोई घर नहीं जहाँ पर एलर्जी से कोई ना कोई ग्रसित ना हो। ऐसा वर्क किया गया है कि कम से कम 100, मतलब हर तीसरे से चौथा आदमी एलर्जी के किसी न किसी बीमारी से ग्रसित है। लेकिन थोड़ा दुर्भाग्य ये है कि एलर्जी की एजुकेशन अभी भी बहुत अच्छी नहीं है कंट्री के अंदर। Although we are trying hard, डॉक्टर राजकुमार साहब बैठे हैं, इनके पहले मैं भी सर इसी इंस्टीट्यूट का डायरेक्टर था जहाँ ये आजकल मेरी कुर्सी पर मतलब विराजमान है। तो हम लोगों ने ये ट्राई कर रहे हैं, होपफुली समथिंग विल फ्रूटफुल हैपन सो दैट द एलर्जी एजुकेशन माइट इंक्रीज। मैं एक बात यहाँ और कहना चाहूँगा, सालवी साहब बैठे हैं या चले गए मैं देख नहीं रहा हूँ। यस, ही इज़ देयर। ही इज़ अ गाय हु डिड रिसर्च इन इंडिया। इन्होंने रिसर्च किया कि ओपीडी में किस तरह के मरीज रूटीनली आते हैं, ओपीडी अटेंडेंस। तो ये मल्टी सेंटर वो स्टडी थी, तो उसमें पाया गया कि जो कोई भी ओपीडी हो, जनरल ओपीडी हो, पीएससी की ओपीडी हो, जिले अस्पताल की हो, मेडिकल कॉलेज की हो, तो 50% लगभग रोगियों को कोई ना कोई रेस्पिरेटरी सिम्टम होता है। ये सच है, हम भी देख रहे हैं। अब हमें भी 55 साल हो गए यहाँ पर इस KGMC में। तो लेकिन बड़ा एक और हम आपके सामने हमने तथ्य पहले भी रखा था, फिर मैं रखूँगा कि जो एजुकेशन इन रिस्पिरेटरी, जिसमें ये सिम्टम्स आते हैं, सारे एलर्जी के भी सिम्टम काफ़ी हद तक उसी में आते हैं, तो उसके एजुकेशन अभी भी बहुत, जितना अच्छा होना चाहिए उतना अच्छा नहीं है। और मैंने पिछली बार भी आपसे अर्ज किया था सर कि अभी तो गवर्नमेंट ऑफ इंडिया ने क्या किया है कि जो रेस्पिरेटरी डिपार्टमेंट से जहाँ पर सिर्फ एमबीबीएस की ट्रेनिंग होती है, वहाँ से वो डिपार्टमेंट हटा दिए गए हैं। तो मैं कभी कभी मैं मानता हूँ, क्योंकि मैं शायद यहाँ जितने लोग बैठे हैं, मैं अपने से सीनियर, मैं किसी एक साहब वीके जैन साहब बैठे हुए हैं जो मेरे सर गुरु हैं, इनको भी लाइफ टाइम इस साल अभी आप देंगे। ये मेरे भी टीचर रहे हैं, यही टीचर क्या, यही केजीएमसी से हम लोग साथ साथ थे, पढ़े थे, हमारे 3 साल हमसे सीनियर हैं। तो मतलब जब हम कहते हैं कि जब टीबी चेस्ट की या चेस्ट की पढ़ाई होती थी, तब तो ये हालत है कि टीबी रोग का कैंसर, और कैंसर को टीबी हम लोग रोज देखते हैं, अपने पर्चों में ओपीडी में मरीज देखते हैं। और ये सब कमियां इसलिए हैं कि कमी सर हमारे एजुकेशन में है। तो हमें कहीं ना कहीं, चूँकि आप बैठे हैं, हम आपके सामने रोग आ सकते हैं, तो हमारे आपसे यही कहना है कि जहाँ कहीं आपको मौका लगे, ये बहुत ही ज़रूरी सिस्टम है। इस सिस्टम का एजुकेशन हाईएस्ट एंड का होना चाहिए, और जब हाईएस्ट एंड का एजुकेशन होगा तो हमारी जो जनता, अल्टीमेटली बेनिफिट किसको जाएगा? बेनिफिट हमारी जनता को जाएगी, पुअर, स्पेशली द पुअर नीडी पीपल। जहाँ मैं आज भी देखता हूँ, पर्चे में देखता हूँ डायग्नोसिस गलत, ट्रीटमेंट गलत। मैं हमेशा, मेरा मानना है, मैं कहता हूँ अपने मरीजों से, कोई डॉक्टर गलत इलाज लिखना नहीं चाहता है, बस भाई उसका ज्ञान कितना है, अपने हिसाब से लिखता है। सो व्हाट आई एम ट्राइंग टू रिक्वेस्ट यू सर, जब कभी मौका आपको, आप बहुत सक्षम है मैं जानता हूँ, और जब मौका लगे तो इस चीज़ को, हम लोगों की आवाज़ को आप उठाएं, और जिससे कम से कम मैं अपने लाइफ टाइम में ये देखूं। मैं भी सर बड़ा हो गया हूँ, काफ़ी उम्र हो गई है, लेकिन हम लोग काम कर रहे हैं, करते रहते हैं, भगवान की मेहरबानी है कि अच्छा एजुकेशन हो। और अच्छा एजुकेशन इसलिए हो कि हम अपने गरीब जनता की सेवा कर सकें। इन शब्दों के संग मैं वेद प्रकाश जी को बहुत बहुत धन्यवाद देना चाहता हूं कि इन्होंने ये कॉन्फ्रेंस इतने अच्छे से, अभी आज पहला दिन है, मैं इनकी कैपेबिलिटी को जानता भी हूं, मेरे ही पढ़ाए हुए, मैंने देखा इनको बहुत सालों से। और माई बेस्ट विशेस to the conference. And with these words, I welcome you all for this conference. Thank you very much.
Thank you, sir, for your inspiring words that beautifully set the tone for this academic celebration. Next, I would like to invite Professor Dr. Suryakant sir, Editor-in-Chief ICAAI, Organizing Co-Chairman, Scientific Chair ICAAI, to grace the podium. Welcome, sir.
अब अगर राजेंद्र प्रसाद साहब ने कह दिया है कि हमारे उत्तर प्रदेश के अब तक के मोस्ट डायनेमिक हेल्थ मिनिस्टर एंड मेडिकल एजुकेशन मिनिस्टर एंड डिप्टी चीफ मिनिस्टर हैं, तो कम से कम वो जो राजभवन कॉलोनी में घर है आपका, वहां तक तो ताली की आवाज जानी चाहिए। कमाल करते हो यार। हमारे मुख्य अतिथि, और 30 वर्षों से मैं इन्हें देख रहा हूं सक्रिय राजनीति में, पहले छात्र राजनीति में, विश्वविद्यालय में 1990 में ये लखनऊ विश्वविद्यालय छात्र संघ के अध्यक्ष बने, तब मैं जूनियर डॉक्टर था, एमडी का फर्स्ट ईयर स्टूडेंट था, और तब से मैं इनको ऑब्जर्व कर रहा हूँ। राजनीति के क्षेत्र में बहुत ही उद्दीप्यमान, दैवीयमान ऐसे सितारे हैं। हमारे घर पधारे हैं, हमारे उत्तर प्रदेश के मुखिया हैं, हम सभी के 25 करोड़ के मुखिया हैं। सिर्फ ये मत सोचिएगा, हमारी संस्थान की मुखिया अभी इसी वर्ष पद्मश्री से सम्मानित, और हम सबको ऐसा कोई भी एकेडमिक कार्य हो, चाहे आउटरीच सोशल हो, जैसे मैं कैंप बहुत लगाता हूं, तो चाहे आउटरीच का प्रोग्राम हो, चाहे दूसरे प्रोग्राम में, हर काम में हमारा सहयोग देने वाली प्रोफेसर सोनिया नित्यानंद जी। तो कम से कम वाइस चांसलर रेजिडेंस तक तो आवाज़ जानी चाहिए। तो हमेशा ख्याल रखती हैं कहीं भी। अभी बाय द वे फ्लाइट में हम आए, मैडम को एक एक्सीलेंस फिक्की का अवार्ड मिला था, और हम लोग एक ही उसमें थे साथ यात्रा में। और हमारे इसमें दो हमारे, मैंने कहा कि मेरे उत्तर प्रदेश के मुखिया मंच पर हैं, संस्थान की मुखिया मंच पर हैं, और तीसरे हमारे विभाग के मुखिया हैं। मैं विभाग के मुखिया ऐसे इसलिए कह सकता हूं कि विभाग तो बना 1946 में, मैं बेसिक डिपार्टमेंट की बात कर रहा हूं जिससे ये डिपार्टमेंट निकला 2016 में। उसकी स्थापना तो 1946 में हुई थी, और उसके मुखिया मैं इसलिए कहता हूं क्योंकि डॉक्टर राजेंद्र प्रसाद ने जो विस्तार दिया है विभाग को और इस स्पेशलिटी को, वो अनुकरणीय है, अतुलनीय है। और हम सबके विभाग के मुखिया मैं कहता हूं, हम सभी के, हमारे फैकल्टी मेंबर भी बैठे हैं, कुशवाहा साहब, राजीव गर्ग और बहुत से लोग, दर्शन बजाज, तो हमारे विभाग के मुखिया। तो उत्तर प्रदेश के मुखिया हमारे पास हैं इस मंच पर, संस्थान की मुखिया है मैडम हमारी, हमारे विभाग के मुखिया हैं, और दो हमारे नेशनल मेंटर हैं। इनके बिना तो हमारा कोई काम ही नहीं चलता। हमारे पद्मश्री अवार्डी डॉक्टर दिगंबर बेहरा साहब हैं, एक बार जोड़ के वहाँ तक तो पहुँचा ही सकते हो। हमारे दूसरे मुखिया डॉक्टर AB सिंह साहब, हमारे इस एसोसिएशन के प्रमुख कर्ता धर्ता हैं, सेक्रेटरी जनरल हैं, और यहीं उत्तर प्रदेश के निवासी हैं, जौनपुर के। इसके अतिरिक्त दो बड़े भाई भी मेरे मंच पर बैठे हैं। एक हैं पटेल चेस इंस्टीट्यूट के डायरेक्टर डॉक्टर राजकुमार, लेकिन इन्हें बड़े भाई कह दो तो बुरा मान जाते हैं, दोस्त ज़्यादा हैं ये, और यारी दोस्ती में ही रहते हैं, लेकिन वैसे हमसे बड़े हैं तो बड़े भाई हैं। दूसरे बड़े भाई बहुत ही हम्बल हैं, सुरेश कुलवाल जी, जयपुर से, इस समय हमारी संस्था के राष्ट्रीय अध्यक्ष हैं, और पूरा मार्गदर्शन हम सभी को मिलता है, इस कॉन्फ्रेंस का भी मिल रहा है। और अब हम आखिरी में बात करेंगे, लेकिन सबसे इम्पोर्टेंट बात करेंगे कि हमारे छोटे भाई भी इसमें हैं। दो बड़े भाई के बाद एक छोटे भाई भी हैं, डॉक्टर वेद प्रकाश जी, और इनको हम दोनों गुरुओं का संबल प्राप्त है। डॉक्टर राजेंद्र प्रसाद का तो सबको प्राप्त है, लेकिन ये ऐसे अनोखे हैं कि ये हमारा भी इनको पूरा गार्जियनशिप, मेंटरशिप मिली है, और डॉक्टर राजेंद्र प्रसाद साहब की भी मिली है। मैं अभी जिक्र किया डॉक्टर राम प्रसाद साहब ने कि 5वीं कॉन्फ्रेंस है, दो हमारे मरहूम प्रोफेसर मधुसूदन अग्नोत्री साहब ने की, जिनको फादर ऑफ एलर्जी हम कहते हैं। मैम, किंग जॉर्ज मेडिकल कॉलेज और यूनिवर्सिटी की खास बात यह है कि फादर ऑफ एलर्जी DN शिवपुरी साहब, वो भी हमारे KGMU के एलमनाई हैं, और फादर ऑफ एलर्जी इन उत्तर प्रदेश डॉक्टर MS अग्नोत्री साहब, वो भी हमारे एलमनाई हैं। तो इस एलर्जी को देश में फैलाने में हमारे इंस्टीट्यूट ने बहुत बड़ा योगदान दिया है। और जैसा अभी बता रहे थे सर कि 5 में से एक कॉन्फ्रेंस मैंने भी की है, और एक बात तय है, ऑर्गेनाइजिंग सेक्रेटरी उस कॉन्फ्रेंस में मैं था, इस कॉन्फ्रेंस में डॉक्टर वेद प्रकाश हैं, लेकिन ऑर्गेनाइजिंग चेयरमैन हम लोग नहीं बदलते हैं, वो डॉक्टर राजेंद्र प्रसाद ही रहते हैं। तो इसलिए मैं ज़्यादा वक्त ना लेके मैं सभी अतिथियों का स्वागत करता हूं। हमारे बहुत फैकल्टी मेंबर बाहर दूर देश के कोने कोने से आए लोग बैठे हैं, इन सभी का स्वागत है। और सभी को मालूम है कि एलर्जी और सांस की रोगियों की ये बड़ी संस्था है, और एलर्जी और सांस की रोगियों पर रोकथाम हो, इसके लिए हम लोग 3 दिन चर्चा करने वाले हैं कल से। और सबको मालूम है कि वायु प्रदूषण सबसे बड़ा कारण है, और इसीलिए एक अभियान हम लोगों ने शुरू किया है, वायु मित्र अभियान। यानी हम लोगों को सेंसिटाइज करते हैं, ट्रेन करते हैं, और उनको एक सर्टिफिकेट देते हैं कि वायु मित्र हैं, आज से आप ये करिए और ये ना करिए, ये डूज एंड डूज। हमारे कारण कोई वायु प्रदूषण ना हो, और हम कितनी अपनी योगदान दे सकते हैं कि वायु प्रदूषण कम से कम हो। उत्तर प्रदेश सरकार बहुत उल्लेखनीय कार्य कर रही है, हर साल वो लाखों की संख्या में पेड़ लगाती है, और इसकी तारीफ भी हो रही है। हमारा जो ग्रीन जोन है वो बढ़ रहा है। और दूसरा मैं कहता हूं कि ये जो हमारी डाइट है आज की, तो ये बहुत ख़राब हो रही है। मेरी तो एक कहावत ही है कि जब तक आंटी के चिप्स थे तब तक समस्या नहीं थी, जब से अंकल चिप्स हो गए तब से समस्या ही समस्या हो गई। तो इसलिए ऐसी बहुत सी छोटी छोटी चीज़ें हैं, वो तो मैं बाद में कल अपना जब ओरेशन दूंगा तब बताऊंगा। धन्यवाद सर, AB सिंह साहब और कुलवाल साहब, आपने मुझे डॉक्टर RK मोदी मेमोरियल ओरेशन अवार्ड से सम्मानित किया है। कल मैं डिलीवर करूंगा, उसमें ये विस्तार पूर्वक चीज़ें बताऊंगा। बहुत बहुत धन्यवाद।
Thank you, sir, for those insightful words. May I now request Professor Dr. AB Singh, sir, Secretary ICAAI, Scientific Chair ICAAI, to share his words of wisdom.
Good evening, friends. It is indeed a great pleasure and honor for me to welcome today's chief guest, who is none other than Vijay Pathak ji, the Deputy Chief Minister as well as the Health Minister of Uttar Pradesh government. I also welcome Dr. Sonia, the Padma Shri awardee, and Dr. D. Behra is also a Padma awardee and is also past president of the Indian College of Allergy and Applied Immunology. Dr. Rajendra Prasad, Chairman Organizing Committee. Dr. Raj Kumar is also guest of honor and currently the director of Vallabhbhai Patel Chest Institute. Dr. Suryakant, editor-in-chief of ICAAI, he belongs to the same college, this is KGMU. Dr. Kulwal, currently the president of Indian College of Allergy and Applied Immunology. So it is my great pleasure to welcome all this, including those, the past presidents who are off the dais, and I especially welcome Dr. Achal Gulati Sahab, who made it possible to come here, and he will be awarded Lifetime Achievement Award, Lifetime Fellow of the college. In fact, it is, I also welcome some of the foreign delegates who is here from different countries. Sir, the ICAAI is a pioneer organization of the physicians as well as the life science personnel engaged in patient care, research, and health aspects dealing with allergy, asthma, and immunology. As it is evident that we are organizing 59th ICON 2025, so the college is more than 59 years old, established in December 1967 with its headquarters at Vallabhbhai Patel Chess Institute, Delhi. The 59th conference will review the progress made during the last few years, particularly after the last conference held at VP Chess Institute in 2024, and will deliberate on the roadmap of taking the college for further scientific heights. The college has been closely working with many international and national organizations, such as World Allergy Organization, Asia Pacific Allergy Immunology, European Academy, American College of Allergy, South Asian Allergy, which is affiliated as an organization. Sir, today allergy and asthma is a global health problem, and India is not lagging behind. More than 300 million Indians suffer from one or the other major or minor allergic diseases, as explained by Dr. Rajendra Prasad. This is called as an epidemic of 21st century, and the rapid increase in the incidence is attributed to the changing lifestyle, food habits, greater exposure to ever-changing environmental allergens, climate change, besides advanced diagnostic techniques. The pollution and smog in metro cities like Delhi lead to the increased respiratory problems either directly or indirectly by synergistic effect of the pollutants, altering the allergenic properties of the allergens. The development of molecular ergology takes diagnostic to one step further. It can enable us to get better perspective on risk connected with the sensitization. Allergic sensitization to molecular components are measured individually, which helps exactly to pinpoint what molecule has been responsible for allergic diseases. These new developments will help clinicians obtain detailed information on sensitization pattern of the patients and accurate interpretation of allergic symptoms and correlating with the component resolved diagnosis. These will further revolutionize the allergy diagnosis in India. In spite of great advancement in the knowledge of allergy diagnosis and treatment, the field of allergy is still not considered a specialty so far in India. Now it is the time that regulatory agencies should recognize the field and include it in the curriculum of graduate and postgraduate courses. The recent efforts by VP Chess Institute and ICAAI has raised some positive steps for the regulatory agencies in this direction. In spite of advancement in the knowledge of allergy diagnosis and immunotherapy, it is still underdiagnosed, sometimes misdiagnosed, sometimes overused and misused in certain quarters. Therefore, a judicious use of diagnostic and therapeutic modalities should be considered by the allergy practitioners. I am glad that ICAAI, in collaboration with Vallabhbhai Patel Chess Institute, has published the Indian guidelines on diagnosis and allergen immunotherapy for clinical practitioners in India, and I am sure it will help standardization of allergy practice in the country. Dear friends, now I would like to very briefly put certain points actually which the college has been doing. To encourage young researchers in the basic and clinical aspects of allergy, Charles Rickey Prize and Franz Rickey Prize is given to outstanding workers every year during the conference. I am extremely happy to announce that this year DN Superior Oration 2025 will be delivered by Dr. Suresh Kulwal. Thank you. From Jaipur and currently the president of ICAAI. The ICAAI Foundation lecture will also be delivered by Dr. A.K. Janmeja from Chandigarh. Dr. R.K. Modi Memorial Lecture will be delivered by Dr. Suryakant from KGMU, Lucknow. The Lifetime Achievement Award will go to Dr. V.K. Jain from Jaipur, a past president of the college. I am further pleased to inform you that the college recognizes the academic and clinical contributions in the field of allergy to outstanding workers by honoring them with fellowship of ICAAI. On the recommendation of the council, this year the honor goes to Dr. Gautam Modi from Patna, Dr. Jagdeep Bayer from Palakkad, Kerala, Dr. Rohit Kumar from Delhi, Dr. Atul Luhadia from Jaipur, Dr. G.V. Singh from Agra, Dr. H.J. Singh from Jalandhar, and Dr. Ashish Prakash from Gurgaon, Haryana. I am further pleased to announce that this year's honorary fellowship has gone to the honorary fellowship has been awarded to Dr. Achal Gulati, Honorable Vice Chancellor, MGM University, Jaipur. Give him a big hand, actually. He is here, sir. Congratulations, sir. This year, a total of 12 live memberships were included in the college list. Finally, I would like to take this opportunity to thank the organizers of the ICON 25, Dr. Ved Prakash, organizing chairman Dr. Rajendra Prasad, and his team of dedicated workers. I'm glad that they have organized given a very good scientific as well as the cultural program during the next 3 days. It will not be out of place to mention that today we had 2 workshops, one on allergy testing and diagnosis, and another one on pulmonary function test. Both were successful. I once again welcome all the guests, invitees, delegates, students, friends from the media to the 59th ICON 2025. Thank you.
Thank you so much, sir, for those kind words. Next, I invite Professor Dr. Suresh Kulwal, sir, President ICAAI, to address the gathering. Welcome, sir.
Honorable Chief Guest, Shri Brajesh Pathak ji, Deputy CM, Uttar Pradesh, distinguished guest on the dais, respected seniors and dear friends. It's both an honor and privilege to stand before you as today as the President of Indian College of Allergy, Asthma and Applied Immunology at this esteemed annual conference. I extend a warm welcome to each one of you, clinicians, researchers, academicians, and allied health professionals who have gathered here with the shared commitment to advancing the science and practice of allergy, asthma, and immunology in India. Over the past decades, our field has witnessed remarkable progress. The burden of allergic disease and asthma continues to rise, not only in the urban centers, but also in the rural communities. Environmental changes, urbanization, and evolving lifestyle has contributed to this growing challenge. As practitioners and scientists, we are at forefront of addressing these issues, striving to translate research into meaningful clinical outcome to our patients. This conference reflects our collective aspiration
to integrate cutting-edge research and with day-to-day clinical care. We are privileged to have among us international and national experts who will share their insights on the latest advances in immunotherapy, biologics, precision medicine, and environmental interventions. These sessions will not only enhance our knowledge, but also inspire us to adopt evidence-based approaches tailored to unique needs of our population. Improving allergy diagnostic in semi-urban and rural India requires a multifaceted approach like training primary care providers, enhancing diagnostic infrastructures, standardized allergen extract availability, telemedicine, artificial intelligence, and decision support, integration with existing health programs, community and patient education, research and data collection, and recognition of allergy as a separate specialty. Schools play a critical role in the management of allergy anaphylaxis given the significant amount of the time children spend in the school. Effective management in the school require coordinated multidisciplinary approach involving the school personnel, healthcare providers, students and families. Policy gaps in allergy management in India are multifactorial and contribute significantly to the high burden of uncontrolled allergic disease, delayed diagnosis, and suboptimal patient outcomes. Existing protocols are often adopted from international guidelines, which may not account for India's unique epidemiological and environmental and socio-economical context. There are very few dedicated postgraduate training programs, resulting in a shortage of trained allergists and immunologists in India. Most allergic diseases are managed by general practitioners, pediatricians, or organ-based specific with variable expertise in allergic management. As we celebrate scientific achievements, we must also acknowledge the challenges that persist. Access to diagnostic facility, affordability of advanced therapies, and need for widespread awareness remain sufficient hurdles. The Indian College of Allergy, Asthma and Applied Immunology is committed to addressing these gaps through education, advocacy, and collaborations. Our ongoing initiative in physician training, patient education, and public health outreach are steps in this direction. I urge all members to actively participate in these scientific deliberations, share their expertise, experiences, and foster collaborations that transcend institutional and regional boundaries. Let us also remember our responsibility to mentor the next generation of allergists and immunologists, nurturing curiosity, compassion, and a spirit of inquiry. In closing, I express my deepest gratitude to the organizing committee for their tireless efforts in making this conference a reality, to our sponsors and partners for their support, and to each and every delegate of for your dedication to our field. Together, let us reaffirm our commitment to excellence in patient care, research, and education. Thank you, and I wish you all a stimulating and productive conference. Jai Hind.
Thank you so much, sir, for that motivating message. We now request Professor Dr. Rajkumar, sir, our guest of honor, to grace us with his message.
Respected our Chief Guest, Deputy Chief Minister and Health Minister, Government of Uttar Pradesh, respected Honorable Vice Chancellor, and other dignitaries on the dais. At the outset, I bring greetings from Vallabhbhai Patel Chess Institute, which is one of the premier institutes of our country. It's a mandir of the chess diseases in our country. सर, जो हमारे देश में जो एलर्जिक डिजीजेज है, अराउंड 30 to 40% पीपल सफर्स फ्रॉम सम काइंड ऑफ द एलर्जिक डिजीजेस, और इसके लिए एज सच कोई प्रॉपर करिकुलम नहीं बनाया गया है, और हम लोग बहुत कोशिश कर रहे हैं वल्लभ भाई पटेल चेस इंस्टीट्यूट इसके ऊपर एनएमसी से मिल करके कोशिश कर रहे हैं कि कोई डिप्लोमा कोर्स या तो एमडी कोर्स स्टार्ट हो, और मैं रिक्वेस्ट करूंगा सर से भी कि जैसे भी जब भी मौका मिले इस चीज़ के बारे में ज़रूर बात करें, ताकि एक हमारे देश में एलर्जिक डिजीजेज के ऊपर कोई ना कोई कोर्स शुरू हो. Coming to the allergy, this conference has been made possible because the hard work of the people like वेद प्रकाश जी, इन्होंने बहुत मेहनत करके इस कॉन्फ्रेंस को एक मुकाम पे पहुंचाया है. और आज के वर्कशॉप में मैं था दिन भर. दोनों वर्कशॉप जो थे फुल्ली पैक्ड चल रहे थे और एक अच्छा प्रोग्राम बना है जिसमें कि लोग विभिन्न देशों से, विभिन्न राज्यों से आकर के एलर्जी के बारे में बात करेंगे और एक दूसरे को हम समझ पाएंगे कि एलर्जिक डिजीजेज क्या होती हैं और इसके बारे में व्याख्यान होंगे. और जो अभी हमें ज़रूरत है कि जो एयर पोल्यूशन और एलर्जी के बारे में ज़्यादा बात कर पाएँ और इसमें जो हमारे प्रोग्राम में एयर पोल्यूशन के बारे में भी बताया गया है, बताया जाएगा और यह एक सराहनीय कदम उठाया गया है. और इसमें मैं जो ऑर्गेनाइज सेक्रेटरी हैं उनको मैं कॉन्ग्रेचुलेट करूंगा कि इन्होंने बहुत बेहतरीन तरीके से काम करने की कोशिश की है. इसके साथ ही सभी को धन्यवाद और सभी को मैं वेलकम करता हूं. थैंक यू सो मच.
Thank you so much, sir. It's an honor to hear from Padma Shri Professor Dr. Digambar Behra, sir, an academician par excellence and a teacher to generations. Welcome, sir.
Honorable Chief Guest, the Deputy Chief Minister of Uttar Pradesh and the Health Minister of Government of Uttar Pradesh, Madam Sonia Nityanand, Professor Rajendra Prasad, the President and Secretary of ICAAI, Professor Suryakant, Dr. Rajkumar, Director of VP Chest Institute, Professor Ved Prakash, the stalwarts of allergy and immunology in this country, and pulmonary physicians, ladies and gentlemen. It is a pleasure to stand before you and take part in this conference. And before I tell something about this conference and this disease, I welcome you all also on behalf of the National Academy of Medical Sciences, which incidentally I am leading now. And we are having the conference next week. So as has already been told by Professor Rajendra Prasad, the President and the Rajkumar, etc., we all know that allergic diseases is a very common problem for this country. About 30 to 40% of our population is having one or other form of the allergic disease. And then the most important thing is they are increasing actually over time, over the years, over the decades. It is because of obviously apart from the genetics, we have got the pollution, we have got the climate change, the change in the dietetic habits, infections, so on and so forth. There are many causes, and then they have also told some of the solutions. But as I could see 2 or 3 important points which are important to tackle this problem. I think one is the unfortunate part is while the pulmonary medicine has has spread in it different ways. We have got now development of in the critical care, the interventional pulmonology, so on and so forth, sleep medicine. But unfortunately, the allergic diseases, which is I think is by and large neglected by the pulmonary medicine specialist. Let me tell you very clearly, even I am part of this as a pulmonary physician, even I have neglected this, let me admit that, and that is many of us done that, but only few stalwarts who are bringing it forward and then highlighting it. And obviously there is lack of specialization, and my previous speakers have already spoken about the need for a specialization, and they are fighting for it. I think BP Chest Institute and ICAI itself is fighting for it over the years, but they are not yet successful. But I only recently came to know that the National Board has now sanctioned it, because I am part of their governing body. I saw one agenda that it is already passed it was about last month was the meeting, and it is already agreed. I hope there will be some change. Then number two, sir, again my humble request to you to impress upon the Honorable Health Minister of India to see that the speciality of pulmonary medicine is not taken away with or not done away with, as Professor Rajendra Prasad has told you. So, sir, you have got the capacity, and I know that you have the capability of speaking to the Health Minister of India, Sri Nadaji, and bring that and help us. So next week, the NMC chairman is coming to for this NAMSCON, for this National Academy of Medical Sciences conference, and we have got a panel discussion on medical education in India. So I'll try to, highlight this issue with him also. And Professor Rajendra Prasad is chairing that panel discussion. So I am sure he will utilize his chairmanship for impressing upon that. And then the number two issue is the, as I told you about the allergic diseases. Still there are a lot of issues with the bronchial asthma, which is another important allergic disease. That still there are a lot of myths, a lot of misconceptions about the public. The availability of the drugs is another issue, sir. And I think the inhaler is one of the very important drugs for treating these patients. And unfortunately, what is happening in the many of the rural areas, these drugs are not available, neither they are affordable, although the cost is not very much. So as per the WHO or even the health policy, I think these drugs should be available, and they are part of the essential medicines. So, sir, what you are the health minister, and you are a very dynamic minister. So at least you see that in your state, every primary health care facility should have got availability of these inhalers. And number two, also the availability of lung function test machines, that is the spirometers. Not only it will be helpful for asthma, it will also be helpful for diseases like COPD. So the spirometers, etc., they are not very costly. And of course, there are other some essential drugs for asthma and COPD. I am sure your government should look into that. There is a recommended essential drug list, so they should all be available. So with some of these requests to you, sir, and to all my fellow colleagues, I again thank you. I thank Ved for giving me this opportunity. And as the chairman of this scientific committee of this particular conference, with the help of my other colleagues, we have tried to bring out a scientific program so that we will be discussing all aspects of allergy and immunology and bronchial asthma. The pity is that while we have got now the biologics available for bronchial asthma, which cost about few thousands or few lakhs of rupees, we have got issues of inhaler of a few hundred rupees or 200 rupees, and we don't have got as has already been highlighted, neither we give importance nor we have got availability of good allergens, good immunotherapy practice in this country, and also there are lack of specialists. So I think we need as chest physicians. Of course, allergy has got multiple diseases. I think it includes also the ENT, Dr. Gulati ji here, and then the skin specialist and the food and food specialist, nutritionist also. All are to be together so that the allergic diseases are given due importance in our country. So with these few words, I again obviously Ved will be welcoming you all, but on his behalf I also welcome you all. And I hope this conference to be a great success, and all of you have a good academic feast. Jai Hind.
Thank you so much, sir, for your enlightening message. We are truly privileged to have amongst us our respected Vice Chancellor, Padma Shri Professor Dr. Sonia Nityanand ma'am, whose visionary leadership continues to elevate KGMU to global heights. Ma'am, we humbly invite you to address the gathering.
थैंक यू। माननीय उप मुख्यमंत्री श्री ब्रजेश पाठक जी एवं मिनिस्टर फॉर मेडिकल एजुकेशन एंड हेल्थ, दी पद्मश्री प्रोफेसर डी बेहरा सर, डॉक्टर राजकुमार, डॉक्टर सुरेश कूलवाल, डॉक्टर ए.बी. सिंह, डॉक्टर राजेंद्र प्रसाद, Dr. Suryakant and Dr. Ved Prakash. On behalf of the King George's Medical University, all the faculty members in the audience, esteemed faculty members, all the invited guests, Mrs. Prasad, Rajendra Prasad, and all the other invited guests, and जितने भी participants हैं, आप लोग सबको KGMU की तरफ से बहुत हार्दिक स्वागत KGMU में। मुझे बहुत अच्छा लग रहा है कि डॉक्टर वेद प्रकाश ने ये कॉन्फ्रेंस ऑर्गेनाइज करी है, विच इज़ ऑन एलर्जी, एस्थमा एंड अप्लाइड इम्यूनोलॉजी, और वो भी नेशनल लेवल की। सो सबसे पहले डॉक्टर वेद प्रकाश, आपको बहुत बहुत कॉन्ग्रेचुलेशंस कि आपने ये नेशनल लेवल की कॉन्फ्रेंस ऑर्गेनाइज करी है। अभी हम बात कर रहे थे डॉक्टर राजकुमार से, बिकॉज जब से आप लोग बोल रहे हैं, जितने भी एक्सपर्ट्स हैं इस फील्ड में, मेरे दिमाग में ये आ रहा है कि ये एक काफ़ी डिफ़िकल्ट डिपार्टमेंट है। आप एक तरफ तो पल्मोनरी मेडिसिन है जिसमें एक बहुत इम्पॉर्टेंट आईसीयू कंपोनेंट है, बिकॉज हम लोग सब जानते हैं कि पल्मोनरी डिजीज़ेस जो लंग के प्रॉब्लम्स होते हैं वो अक्सर कैन बिकम क्रिटिकल, सांस नहीं आती है, आईसीयू सपोर्ट चाहिए होती है। और दूसरी तरफ ये स्पेक्ट्रम है एस्थमा का, एलर्जी का, इम्यूनोलॉजी का, जिसमें एक इन डेप्थ नॉलेज बेसिक साइंसेस की चाहिए है। इस साल का तो नोबेल प्राइज़ इम्यूनोलॉजी में मिला है, एंड उससे हाईलाइट होता है कि रेगुलेटरी टी सेल्स कितने इम्पोर्टेंट हैं। इम्यूनोलॉजी, इम्यून रिस्पॉन्स एकदम अगर कम होता है तब प्रॉब्लम होती है कि इम्यूनो डेफिशिएंसी डिसऑर्डर्स होते हैं, जिसमें अगेन रिकरेंट इन्फेक्शंस ऑफ द चेस्ट होते हैं, और अगर हाइपर इम्यून रिस्पॉन्स होता है तो एलर्जीज हैं, एस्थमा होती है। तो इसके लिए एक इन डेप्थ नॉलेज हमें बेसिक इम्यूनोलॉजी का चाहिए होता है, जो एक क्लिनिशियन जो दिन रात पेशेंट देखता है उसके लिए अक्सर मुश्किल होता है। बट मेरा ये एक सजेशन है कि गुड पार्ट ऑफ द करिकुलम, आप लोग सब बैठे हैं, शुड बी ऑन इन pulmonary medicine, respiratory medicine, should be on basic immunology and applied immunology. अगर हमको यही नहीं मालूम होगा टी लिम्फोसाइट्स के बारे में, तो हम नहीं, we will never be able to understand कि एस्थमा कैसे होता है। So वो बहुत इम्पोर्टेंट है। और क्लिनिकल टीचिंग के साथ साथ एक पार्ट ऑफ द करिकुलम should be on understanding the basic science of immunology. And maybe ये भी आप लोग सोच सकते हैं, because USA में there is a special speciality of allergy immunology. After doing your basic medicine, जैसे यहाँ DMs होते हैं वहाँ पे इसको fellowships कहते हैं। So maybe this, आप लोग suggest करेंगे NMC को, तो this will start going, is to start a program, dedicated program in immunology and allergy, because allergy is not only applied to pulmonary medicine, to lung diseases. It's many other aspects which are covered. So it might be worthwhile that in India the time has come, because मुझे याद है जब मैंने MD medicine पढ़ा है, when I have gone through MD medicine, बहुत limited knowledge थी इस field की. एस्थमा है, बट हम लोग डरते थे एस्थमा के पेशेंट्स को ट्रीट करने में, बिकॉज स्टीरॉइड्स के अलावा कुछ समझ भी नहीं आता. और आज भी आई थिंक बहुत ज़्यादा साइंस इन एस्थमा नहीं बढ़ी है. स्टिल द बैकबोन ऑफ ट्रीटमेंट इज स्टीरॉइड्स, So it might be that it's time for this country to start a specialty course, maybe a DM in allergy and applied immunology. Second thing जो मैं डॉक्टर राजकुमार से बात कर रही थी, because I was very intrigued जब मैंने यहाँ पे as a VC join करा है, कि there is a department of respiratory medicine and there is a department of pulmonary medicine. एक MD देता है और एक DM देता है. One is a basic medical MD course and the other is a super specialty. But कितना commonality है दोनों में between MD respiratory medicine and DM pulmonary medicine. So जैसे cardiology में होता है, you don't need to do an MD medicine. You can do a straight 5-year cardiology course. A DM in cardiology कई संस्थानों में है. You straight away do a specialty and a super specialty course which is joined together, and it's a 5-year course. So maybe respiratory medicine and pulmonary medicine in future can be one department, because दोनों लंग से डील कर रहे हैं और दोनों में लंग रिलेटेड प्रॉब्लम्स हैं. बेसिक्स तो दोनों को जानना ज़रूरी है, and it could become a 5-year MD DM program. है बहुत इम्पोर्टेंट स्पेशलिटी, बिकॉज घूम फिर के हर स्पेशलिटी में लंग प्रॉब्लम ज़रूर होती है. हम लोग फॉर अ पर्सन लाइक मी जो बोन मैरो ट्रांसप्लांट करते हैं, हर ही पेशेंट में ऑलमोस्ट एवरी पेशेंट विल लैंड अप विद अ कॉम्प्लिकेशन, विद एन इन्फेक्शन ऑफ द लंग्स. दैट इज़ आई एम सेइंग कि स्पेक्ट्रम इतना बड़ा है आप लोग का कि आपको लंग इन्फेक्शंस देखने हैं, बैक्टीरियल हों, चाहे वायरल हों, चाहे फंगल हों, एंड द अदर कोविड भी आपने देखा है. और उसके साथ साथ ऑन द अदर साइड ऑफ द स्पेक्ट्रम is the asthma, the immunological disorders. I am very happy with the progress of the department. It's a great pride of the university, जो department हमारा pulmonary medicine का है, and बहुत it gives a lot of critical, that's why it is called pulmonary and critical care medicine. ये ICU support, critical care medicine support sick patients को जिनमें पल्मोनरी प्रॉब्लम्स होती हैं, बहुत ही ब्यूटिफुली एक्सटेंड करता है. ऑल लेटेस्ट यहाँ पे टेक्नोलॉजीज़ हैं, स्लीप स्टडीज़ हैं एंड अदर टेक्नोलॉजीज़ हैं. एंड आई विश दिस डिपार्टमेंट grows further and further. Dr. Ved Prakash, give you all the best wishes to you. And again, congratulations कि आपने और आपकी टीम ने, डॉक्टर राजेंद्र प्रसाद चेयरमैन है इसके, कि आप लोग को ये कॉन्फ्रेंस ऑर्गेनाइज करने की एक अपॉर्चुनिटी मिली, which brings the department on a national scene. It also brings KGMU on a national scene. So बहुत बहुत धन्यवाद. और अंत में मैं अपने माननीय उप मुख्यमंत्री को बहुत बहुत धन्यवाद देना चाहूँगी कि बहुत बिजी हैं इस समय. वी नो कि सब लोग को मालूम है बिहार इलेक्शंस आर ऑन, सर की ड्यूटी लगी है, बट उसके बाद भी आपने टाइम निकाला और आप हर चीज़ में यूनिवर्सिटी को सपोर्ट करते हैं. द मोस्ट, जिसे कहते हैं द मोस्ट एक्सेसिबल पर्सन फॉर द यूनिवर्सिटी. हम लोग कोई भी प्रॉब्लम लेके किसी भी समय में आपके पास जाते हैं और आप उसका कुछ ना कुछ सल्यूशन निकालते हैं. सो उसके लिए आपको बहुत बहुत धन्यवाद सर. थैंक यू. जय हिंद.
Thank you, ma'am, for your inspiring leadership and kind words of encouragement. Science grows when knowledge is shared and documented. We now move to the much-awaited moment, the release of 2 prestigious publications. First, the release of the 2nd edition of the Clinical Allergy book, edited by Professor Dr. Rajendra Prasad sir, Professor Dr. V.K. Jain sir, and Professor Dr. Nikhil Gupta sir. May I request Dr. Rajendra Prasad sir and Dr. V.K. Jain sir to kindly unveil the book, joined by our esteemed dignitaries on the dais. I welcome Dr. Nikhil Gupta sir as well to unveil the book, joined by all our dignitaries. Next, we proceed to the release of the Indian Journal of Allergy and Immunology 2025, 39th volume, first issue, edited by Professor Dr. Suryakant sir. May I request sir to kindly unveil the journal along with our distinguished dignitaries. Moving on, it is our profound honor to celebrate a living legend, Professor Dr. V.K. Jain sir, a stalwart in pulmonary medicine, Chief Pulmonologist and CEO, Rohit Hospital, Jaipur, and former Professor Emeritus and Head, Department of Respiratory Medicine, Mahatma Gandhi Medical College, Jaipur, and SP Medical College, Bikaner. With over 4 decades of exemplary service, Sir has illuminated the field through 70 publications, 4 books, 50 book chapters, and more than 200 conference presentations while mentoring generations of physicians over 46 years of teaching. A recipient of 6 Lifetime Achievement Award, and this being the 7th one, 17 national and international honors, 7 fellowships including FAMS, FCCP, and WHO fellowships. Dr. Jain's leadership as President of ICAAI, NCCP, ICS, and IAB has profoundly shaped respiratory medicine in India. A huge round of applause for Sir for receiving the Lifetime Achievement Award here at ICAAICON. Today, we also take great pride in honoring Professor Dr. Achal Gulati sir, Vice Chancellor and Professor of Excellence, Mahatma Gandhi University of Medical Sciences and Technology, Jaipur, a distinguished academician, accomplished surgeon, and a visionary leader. A renowned otolaryngologist and head and neck surgeon trained at PGI Chandigarh, Dr. Gulati sir has over 40 years of outstanding service in teaching, research, and administration. Recipient of numerous national and international honors, including the Sarvapalli Radhakrishnan National Award, Gapio Surgical Excellence Award, Excellence in Medical Education Award. He also serves as the Vice President of the International Rhinologic Society and Fellow of the National Academy of Medical Sciences. Sir is being felicitated with the Fellowship of Indian College of Allergy, Asthma and Applied Immunology in recognition of his exemplary contributions. A huge round of applause for Sir. We now invite our dignitaries for the handover of mementos, a small token of respect and appreciation for their invaluable presence. I invite Professor Dr. Ved Prakash Sir, Secretary ICAI, to kindly felicitate our chief guest, Honorable Deputy Chief Minister of Uttar Pradesh, Shri Brajesh Pathak Ji, with a token of our deepest respect and gratitude. I now request, sir, sir, to graciously felicitate our chief patron, Honorable Vice Chancellor of King George Medical University, Padma Shri Professor Dr. Sonia Nityanand Ma'am, as a mark of our admiration and heartfelt welcome. I request, sir, to kindly felicitate Padma Shri Professor Dr. Digambar Behra, sir, with the token of our profound respect and warm welcome. I request, sir, to felicitate Professor Dr. Raj Kumar, sir, with the token of our respect and admiration. I request, sir, to kindly felicitate Professor Dr. Suresh Kulwal, sir, with the token of our deepest respect. I request, sir, to kindly felicitate Dr. A.B. Singh, sir, with our token of our profound respect. Now I request, sir, to kindly felicitate Professor Dr. Rajendra Prasad, sir, with a token of our immense respect and admiration. I request, sir, to kindly felicitate Professor Dr. Suryakant, sir, with a token of our respect and warm welcome. I now request Honorable Deputy Chief Minister of Uttar Pradesh, Shri Brajesh Pathak Ji, to kindly felicitate Professor Dr. Ved Prakash, sir, Secretary ICAAICON, with a token of appreciation and respect. And now the moment we all have been waiting for, May I request our chief guest, Honorable Shri Brajesh Pathak ji, Deputy Chief Minister, Uttar Pradesh, to kindly bless the gathering with his words of wisdom and encouragement. Welcome, sir.
किंग जॉर्ज मेडिकल यूनिवर्सिटी में पूरे देश से आए हुए तथा कई अन्य राष्ट्रों से आए हुए सभी हमारे विशेषज्ञगण, विशेष रूप से यहाँ उपस्थित KGMU की कुलपति प्रोफेसर सोनिया नित्यानंद जी, पद्मश्री प्रोफेसर D बेहरा जी, प्रोफेसर राजकुमार जी, प्रोफेसर सुरेश कुलवाल जी, प्रोफेसर AB सिंह जी, प्रोफेसर राजेंद्र प्रसाद जी, प्रोफेसर सूर्यकांत जी, प्रोफेसर अचल मुलाटी जी, प्रोफेसर VK जैन जी, प्रोफेसर वेद प्रकाश जी, प्रोफेसर डॉक्टर KK सिंह जी, उपस्थित सभी फैकल्टी मेंबर्स, स्टूडेंट्स और विभिन्न राज्यों से आए, विभिन्न देशों से आए हमारे सभी प्रतिभागीगण, उत्तर प्रदेश सरकार की तरफ से उत्तर प्रदेश की राजधानी लखनऊ में आप सबका बहुत बहुत स्वागत करता हूं, अभिनंदन करता हूं। बहुत देर से कार्यक्रम चल रहा है। आज का दिन मुझे लगता है कि इसके बाद छुट्टी करेंगे, कल विधिवत कार्यक्रम प्रारंभ होगा, ऐसा ही है ना? मुझे लगता है कि जिस ढंग से वक्ताओं ने अपनी बात रखी है, ये बहुत ही अहम मुद्दे पर हम सब एकत्र हुए हैं। अपने देश में और दुनिया में श्वास संबंधी रोगों के बड़ी संख्या में मरीज आते हैं। जैसा कि राजेंद्र प्रसाद जी ने अभी प्रारंभिक उद्बोधन में बताया कि OPD में बड़ी संख्या में मरीज आते हैं और एलर्जी से तो मुझे लगता है कि हर कोई ग्रसित है, जैसा कि डॉक्टर साहब ने कहा। लेकिन कुछ एलर्जी डॉक्टर साहब ऐसी है कि जो पास बैठने पर भी हो जाती है और वो टेस्ट में नहीं आती है, नहीं आती डॉक्टर साहब ना। हमने कई बार देखा आप लोगों को बात करते हो कि उससे एलर्जी लग रही है, आदमी ठीक नहीं है, लेकिन वो एलर्जी दूसरे प्रकार की होती है। मैंने इसलिए कहा कि आप लोग बोर हो गए, एकदम ऐसा बैठे हैं जैसे कोई बहुत गंभीर चिंतन मनन। ये तो प्रारंभिक दौर है, कल विधिवत पेपर्स लोग अपना प्रस्तुत करेंगे, उसमें रिसर्च भी होंगे, वैज्ञानिक दृष्टिकोण से आगे क्या किया जा सकता है उस पर भी चर्चाएं होंगी। आज तो एक दूसरे से मिलने का, इंट्रोड्यूस करने का और प्रारंभिक उद्बोधन आप सबको मिला है। तो मुझे लगता है कि KGMC प्रारंभ काल से ही पूरे देश दुनिया में चिकित्सा जगत में एक नई लाइन खींचने में सफल रहा है। यूनिवर्सिटी बनने के बाद भी ये क्रम जारी है और दुनिया में जितने भी आप देखते होंगे जो विख्यात चिकित्सा विज्ञान में आपको व्यक्ति मिलेंगे, वो कहीं न कहीं से KGMU से जुड़े रहे हैं। और मुझे कहने में ये गौरव हासिल है कि KGMU ने अपने स्थापना काल से लेकर अब तक देश दुनिया को चिकित्सा विज्ञान में बड़ी सफलताएं देने का काम किया है। और मुझे लगता है कि इस आयोजन के बाद यहाँ से दिन भर जो आप रिसर्च करेंगे कल, उसके बाद पेपर्स प्रस्तुत करेंगे, तो देश में, दुनिया में एक नई लाइन आप खींचने में सफल होंगे। मैं कार्यक्रम की सफलता के लिए शुभकामनाएं देता हूँ। और डॉक्टर राजेंद्र प्रसाद जी और डॉक्टर बेहरा जी ने, डॉक्टर सिंह साहब ने कुछ बातें हमारे लिए कही हैं, हम आप लोगों की बात से सहमत हैं। डॉक्टर साहब, आप जो भी पेपर्स यहाँ तैयार करेंगे कि OPD से लेकर के और गहन चिकित्सा तक में हम सरकार की तरफ से क्या कर सकते हैं, जैसे कुछ उपकरण आपने उपलब्ध कराने के लिए कहा है, उनको हम उपलब्ध कराएंगे। और यदि मेडिकल कोर्सेज में कुछ परिवर्तन करना है, भारत सरकार को निवेदन करना है, तो आप एक अपनी तरफ से हमें आप पत्र लिखेंगे और उस पत्र को हम, जो केंद्रीय हमारे स्वास्थ्य मंत्री आदरणीय जगत प्रसाद नड्डा जी हैं, उनके साथ मीटिंग करके उसको हम हर संभव प्रयत्न करेंगे कि पूरे देश में वो लागू हो जाए। क्योंकि आप सब जो काम कर रहे हो, वास्तव में आप भगवान के दूसरे रूप माने जाते हैं और इस रिसर्च के माध्यम से यदि हमारी आने वाली पीढ़ी को आप तैयार कर रहे हैं तो बहुत अच्छा ये निर्णय है आप सबका। मैं इसको हर संभव प्रयत्न करूंगा पूरे देश में लागू हो। बच्चों को, MBBS के जो छात्र हैं, शुरुआत से ही इस क्षेत्र में ठीक से अध्ययन करके अपने प्रदेश और देश की सेवा कर सकें। मैं बहुत अधिक समय न लेते हुए आप सबको इस कार्यक्रम की सफलता के लिए शुभकामनाएं देता हूं और सरकार की तरफ से इस बात का भरोसा दिलाता हूं कि कहीं भी कोई परिवर्तन यदि नीतियों में भी करना है तो हम तैयार हैं। यदि कहीं कोई लगता है कि विशेष रूप से कुछ अतिरिक्त रूप से कुछ संसाधन उपलब्ध कराने, उसके लिए भी हम तैयार हैं। लेकिन आवश्यकता है कि आधुनिक युग में जैसे जैसे हम प्रकृति के साथ छेड़छाड़ किए हैं तो हमको नई चुनौतियों का सामना करना पड़ रहा है। जैसे कि आप सब जानते हैं कि आए दिन फेफड़े के रोगी, दमा के रोगी, अस्थमा के रोगी मिलते हैं, तो उससे हम क्या कर सकते हैं? सबसे बड़ी चुनौती हमारे सामने पर्यावरण प्रदूषण है, उसको भी हमें चिंता करनी पड़ेगी। मुझे लगता है कि आपके रिसर्च का एक पार्ट होना चाहिए कि आने वाले दिनों में जिस ढंग से प्रदूषण की समस्या के कारण हमारे फेफड़े ग्रसित हो रहे हैं, उसके लिए हम क्या करने वाले हैं। आपने दवाई का इंतजाम किया, हम बीमार न पड़ें उसके लिए भी हमें एक पैरेलल व्यवस्था करनी पड़ेगी और ये सब हमने खुद किया है, कोई दूसरा हमारे लिए नहीं किया। जैसे जैसे हम प्रगति किए तो हमने वायु प्रदूषण किया, जल प्रदूषण किया, ध्वनि प्रदूषण किया और धीरे धीरे उस बीमारियों ने हमें ही घेरा है। आप KGMC के सामने वाली सड़क से जब गुजरेंगे तो यहाँ भी आपको कहीं न कहीं कुछ निर्माण होते मिलेगा। तो निर्माण के लिए जो आवश्यक संसाधन होने चाहिए, एक चादर लगाते हैं कि धूल सड़क पे न जाए, वायुमंडल में न जाए, तो उसके लिए हमको जागरूक होना पड़ेगा। और इसके लिए मुझे लगता है कि समय समय पर आप सबको ही अगुवाई करनी पड़ेगी कि बीमार हम कैसे न पड़ें और बीमार न होने के लिए क्या क्या करना चाहिए। हम जितने लोग बैठे हैं, ये इस सेमिनार से संबंधित तो नहीं है, लेकिन सामान्यतः हम देखते हैं कि 40 के बाद कोई न कोई बीमारी सभी को घेर रही है। उसका कारण क्या है और निदान क्या है? हमारी दिनचर्या है। आप देखते होंगे कि रात भर हमारे बच्चे जग रहे हैं, जो MBBS के स्टूडेंट्स होंगे, जो पोस्ट ग्रेजुएट के स्टूडेंट जिनकी ड्यूटी ज़्यादा नहीं यहाँ लग रही है, और रात रात को जग रहे हैं, 3 बजे 4 बजे सो रहे हैं। तो जब 4 बजे 3 बजे हम सोएंगे तो जल्दी 8 बजे नींद खुल जाए तो बड़ी चुनौती है हमारे लिए। और जब 8 बजे हम क्लासरूम में जाएंगे तो मुझे नींद आएगी, 2 घंटा बैठेंगे तो कुछ ना कुछ हम प्रॉपर काम नहीं कर पाएंगे। तो हमें प्रॉपर नींद भी चाहिए, 8-9 घंटे की नींद भी चाहिए युवा को। उसके लिए हम क्या कर सकते हैं? दिन में तो सोने का अवसर नहीं है, जो प्रॉपर नींद नहीं लेंगे तो हम काम कैसे करेंगे? नींद चाहिए। खाने की सबसे बड़ी चुनौती हमारे सामने है। ये कई ढेर सारे आप हम हॉस्टल के जो आपके हॉस्टल्स हैं, जो बच्चे यहाँ पर पढ़ रहे हैं हॉस्टल्स में, आप सोचिए कि कितने बच्चे बाहर का खाना खा रहे हैं। ये जो स्विगी और जोमेटो के लोग हैं, वो जो यूनियन है, वो लोग हमें मिलते हैं, हम उनसे पूछते हैं रात में कहाँ कहाँ आप जाते हो, तो सर्वाधिक वो हॉस्टल की ओर जाते हैं। सर्वाधिक वो ऐसी कॉलोनी में जाते हैं, पेइंग गेस्ट रहते हैं, जहाँ बच्चे पढ़ रहे हैं, जहाँ कलेक्टिव ढंग से बच्चे रह रहे हैं, वहाँ ज़्यादा जाते हैं। जाते कॉलोनीज में भी हैं, लेकिन उन जगहों पर वो लोग अधिक रात में डिलीवरी भोजन की कर रहे हैं, जहाँ युवा हमारे रहे हैं, जो पढ़ रहे हैं, जो काम कर रहे हैं। तो उसकी तरफ भी हमें ध्यान देना होगा। जो वो खाना खिला रहे हैं टेस्टी तो हो सकता है, लेकिन अच्छा नहीं हो सकता है, हमारे लंबे जीवन के लिए अच्छा नहीं है। वो बीमारी हमें कहीं न कहीं परेशान करेगी। तो भोजन है, पानी है, कई जगहों पर हम बैठते हैं तो वहाँ पर क्रॉस वेंटिलेशन नहीं होता। हम अस्पतालों में जब जाते हैं भ्रमण पर देखते हैं कि 1000 वहाँ पेशेंट है, उनके परिजन हैं, और एक एग्जॉस्ट फैन भी नहीं लगा हुआ है। तो ऐसी जगहों पर हमें प्रॉपर हवा भी आनी चाहिए, प्रॉपर हमको सन लाइट भी आवश्यक है। आप जिसकी जांच कराइए विटामिन डी की कमी निकल रही है, आप 90% जांच कराइए B12 कम निकल रहा है। उसका क्या कारण है? तो बीमारियां हम खुद बुला रहे हैं। हम भोजन वो नहीं ले रहे हैं जो आवश्यक है, भोजन वो ले रहे हैं जो मुझे टेस्ट में अच्छा लग रहा है। तो डॉक्टर साहब, मैं आपसे कहूँगा कि एक कोई ऐसा कार्यक्रम भी आयोजित करिए कि बीमार न पड़े लोग। उसके लिए आप क्या कर रहे हैं? ये तो बीमारी का निदान तो आप करेंगे, कुछ चिकित्सक हैं, आपके गुरु लोग सब बैठे हुए हैं, डॉक्टर वैद, लेकिन आपके भी गुरु निकलेंगे। बहुत मेहनती है, बहुत जिद्दी आदमी है, जो ठान लेंगे करेंगे जरूर। पेचकस लिए रहते हैं, स्क्रू कसे रहते हैं, है ना डॉक्टर साहब? पुराने गुरुजी बैठे, पूछिए जरा। क्यों डॉक्टर साहब लिए रहते हैं पेचकस ना? डॉक्टर राजेंद्र प्रसाद जी को मैं देखता हूं, इतने ऊर्जावान व्यक्ति। डॉक्टर जैन साहब, मैं सामान्यतः सभी कार्यक्रमों में जाता हूं, जो मुझे बुला लेता है मैं चला जाता हूं। तो डॉक्टर साहब को देख करके लगता है कि निखिल को भी ऊर्जा इन्हीं से लेनी पड़ती है। निखिल इनका बेटा है, लेकिन निखिल से ज्यादा मेहनत करते हैं। और अध्ययन करते रहते हैं। मेहनत मतलब फिजिकल लेबर के साथ साथ बुद्धि का उपयोग करना, उसे लिपिबद्ध करना, विभिन्न सेमिनार्स में जाना, अपने सभी स्टूडेंट्स को ऑर्गेनाइज किए रहना। डॉक्टर साहब जिस पर उंगली रख दें वही इनका स्टूडेंट निकलता है पूरे देश में। और अपने अनुभव को डॉक्टर साहब मैं सल्यूट करता हूं, ऐसे सभी अपने सीनियर्स को। जो आप लोग बैठे हैं ये हमारी प्रॉपर्टी है, हमारी एसेट है। आपने जो ज्ञान प्राप्त किया अपनी मेहनत के बदौलत, 40 साल 50 साल का अनुभव कोई कम नहीं होता है। 50 साल आपने पूरे देश प्रदेश को दिए हैं, तो आप अगर स्वस्थ रहेंगे तो हमारे देश को और भी कुछ मिलने वाला है। जो आपने ज्ञान प्राप्त किया वो पढ़ करके भी नहीं मिल सकता है। तो मैं आप सबको सल्यूट करता हूं जितने हमारे सीनियर्स हैं, और मुझे पूरी उम्मीद है यहाँ से जो तथ्य सामने आएंगे, पेपर्स निकलेंगे, वो प्रदेश देश के लिए, दुनिया के लिए बहुत लाभकारी होंगे। और मैं सरकार की तरफ से इस प्रतिबद्धता को दोहराता हूं कि हम अपनी नीतियों में परिवर्तन करेंगे। संसाधन की जो भी आवश्यकता होगी उसके लिए हम आपके साथ करबद्ध रूप से खड़े हैं। हर स्थिति में प्रदेश को, देश को अच्छे, दुनिया को अच्छे चिकित्सा विज्ञान में नए रिसर्च की आवश्यकता है, नई विधाओं की आवश्यकता है, और मुझे लगता है इससे परिणाम बहुत ही सार्थक आएंगे। बहुत बहुत धन्यवाद, आभार।
Thank you so much, sir, for your kind and inspiring words. Your presence has truly graced this evening. Every great event stands on the shoulders of teamwork, dedication, and heartfelt effort. To express gratitude on behalf of the organizing committee, I invite the organizing secretary of ICAAICON 2025, Professor Dr. Ved Prakash, sir, for the vote of thanks.
थैंक यू डॉक्टर हर्षिता। जब हम लोगों को कोई आवश्यकता होती है, और हम लोगों को तो बहुत सारे मरीज मिलते हैं जो अपना कष्ट बताते हैं, लेकिन हम लोगों का कष्ट सुनने के लिए पूरे प्रदेश में इतने बड़े स्तर पर अगर कोई एक हैं तो वो हैं हमारे मुख्य अतिथि माननीय उप मुख्यमंत्री श्री ब्रजेश पाठक जी। और मैं एक वाकया आपको बताना चाहता हूँ। पिछले दिनों जब लंग ट्रांसप्लांट के लिए बात हुई, ऑनरेबल वाइस चांसलर ने जब इस प्रस्ताव को आगे बढ़ाया, हम लोगों को कहा कि आप लोग इस पर काम करिए, और हम लोगों ने काम प्रारंभ किया। कई स्टेज पे काम अटकते अटकते आगे पहुंचा, और मैं माननीय जी से मिला, अनुरोध किया। आपको विश्वास होगा कि उन्होंने यहाँ से तो कराया ही, हर कमेटी से पास कराया, चीफ सेक्रेटरी साहब की अध्यक्षता कमेटी से पास कराया, उसके बाद दिल्ली में उसको ले जा कर के पूरी सरकार के साथ केंद्र सरकार से वहाँ पे प्रस्ताव रख कर के बात की और उसको सैंक्शन करा के लाए। इस तरह के हमारे उप मुख्यमंत्री जी हैं, जिसे ठान लेते हैं उसे पूरा ही करके छोड़ते हैं। हमारे पास तो सर छोटा सा पेचकस है बस, लेकिन आपके पास तो बहुत बड़ी मशीन है सर, और जो ऐसी मशीन है कि जहाँ लगा के कस देंगे तो पूरा दिल्ली तक वो उसकी मजबूती वहाँ तक हो जाती है। इससे हर आदमी, हर नागरिक मुझे लगता है उत्तर प्रदेश का वाकिफ़ है, क्योंकि आपके दरबार में कोई भी जा सकता है, कितना भी गरीब से गरीब अगर मिलेगा। मेरे पास अगर सबसे ज़्यादा रेफरल, सबसे ज़्यादा गरीब के अगर कोई आते होंगे तो एक ही जगह से आते हैं, वो माननीय जी के आवास से, माननीय जी के ऑफिस से। वहाँ से सबसे गरीब आदमी जो पहुँच नहीं सकता कहीं तक, वो वहाँ तक पहुँच सकता है। ऐसे हमारे माननीय जी जो कि इतने व्यस्ततम समय में से हमारे बीच में आए, मैं बहुत बहुत आपको धन्यवाद देता हूँ कि हमेशा आपका पैट्रोनेज रहा है KGMU के ऊपर, और विशेषकर विभाग के ऊपर आपकी विशेष कृपा रही है। मैं आपको बहुत धन्यवाद देता हूँ सर। हमारे कुलपति महोदया, जब भी कोई भी बात हम लोग लेकर के जाते हैं, चाहे करिकुलम की हो, चाहे हमारे जो भी समस्याएं हैं उनको लेकर के कभी मिलते हों, बहुत ही पॉजिटिव एटीट्यूड के साथ उन्होंने जो जस्ट है, जो सही है, वही किया। कभी हम लोगों ने इधर उधर का अनुरोध किया होगा तो माना नहीं उन्होंने, लेकिन जो सही है उसको वो ढूंढ जरूर लेती हैं पूरी फाइल में से, और करती वही हैं जो सही होता है। ऐसी हमारी कुलपति जी हमारे बीच में हैं, हमेशा उनका पैट्रोनेज रहता है। बहुत बहुत धन्यवाद देता हूँ आपको मैडम। हमारे बीच में जो गेस्ट ऑफ ऑनर हैं प्रोफेसर D बेहरा सर, मैं अगर कहूँ कि गौमुख कहिए या जहाँ से गंगा निकलती होंगी, और यदि पल्मोनरी मेडिसिन के सुपर स्पेशलिटी कोर्स के लिए अगर कोई गौमुख है तो उसको स्थापित करने वाले, उसको निकालने वाले प्रोफेसर डी बेहरा साहब, प्रोफेसर जिंदल साहब, प्रोफेसर मलिक साहब, जिन्होंने चंडीगढ़ पीजीआई से इसकी शुरुआत की। 30 वर्ष पहले इसकी शुरुआत हुई और आज ये वहाँ से चल कर के पानी उत्तर प्रदेश तक पहुँचा है। तो टेल पे हम लोग हैं और पहला कोर्स उत्तर प्रदेश का इस संस्थान में प्रारंभ करने के लिए हम लोगों ने जो प्रयास किया उसमें सफलता मिली। ऐसे हमारे बेहरा साहब जिन्होंने लगातार हम लोगों को इसके लिए सहयोग दिया, एनकरेज किया, मैं आपको बहुत धन्यवाद देता हूं सर, हमेशा आपका सहयोग रहा है। प्रोफेसर राजकुमार, एलर्जी की अगर बात होती है देश में तो पटेल चेस्ट इंस्टीट्यूट, जहाँ के डायरेक्टर हमारे पिछले डायरेक्टर हमारे राजेंद्र प्रसाद सर जो हमारे टीचर हैं वो रहे, उसके बाद अभी डायरेक्टर हैं प्रोफेसर राजकुमार, और लगातार उन्होंने इतना काम किया है एलर्जी पर। मुझे लगता है कि आज अगर तंबाकू क्विटिंग की बात होती है, जब एयर पोल्यूशन की बात हो रही है, तो मुझे लगता है कि जो क्विट लाइन सर्विसेज हैं पूरे देश में, अगर आप बीड़ी का बंडल आप पाएंगे तो उस पर पटेल चेस्ट इंस्टीट्यूट का नंबर पाएंगे। कोई भी किसी दुकान से आप खरीदिए उस पर क्विट लाइन सर्विसेज का नंबर मिलेगा सर। उसको डेवलप करने वाले प्रोफेसर राजकुमार, मैं आपको बहुत बहुत बधाई देता हूँ, बहुत बहुत धन्यवाद देता हूँ कि आप हमारे बीच में समय निकाल करके आए, सफल बनाया। कुलवाल साहब हमारे बीच में है प्रेसिडेंट, बहुत बहुत धन्यवाद आपका। AB सिंह सर, हमारे टीचर ऑफ टीचर, बहुत बात हो गई है, हमारे प्रसाद सर को सब जान गए हैं, सब जानते हैं। अब तो बल्कि कई डायरेक्टर तो जब उनके स्टूडेंट हैं या डायरेक्टर रहे तो डायरेक्टर ऑफ डायरेक्टर्स की बात होती है, हम टीचर ऑफ टीचर्स की बात करते हैं। सूर्यकांत सर, चूँकि आप कह रहे थे कि आप ही ने सिखाया है, लेकिन मुझे लगता है कि आपने भी कम नहीं सिखाया है सर हमें। और जब हम लोगों ने, जब मेरी थीसिस के गाइड भी आप थे, और मुझे लगता है कि थीसिस गाइड जो होता है वो इनर एंड आउट सब कुछ जान जाता है अपने स्टूडेंट के बारे में। मुझे लगता है कि मेरे बारे में सबसे ज़्यादा सूर्यकांत सर ही जानते हैं। मैं बहुत बहुत धन्यवाद देता हूँ, बहुत बधाई देता हूँ आपको सर कि आप हमारे बीच में हमेशा रहते हैं सर। प्रोफेसर BK जैन, सीनियर मोस्ट टीचर हम लोगों के बीच में है। हमें जो लाइफ टाइम अचीवमेंट आपको मिला है सर अवार्ड, उसके लिए बहुत बहुत बधाई, आपको धन्यवाद देता हूँ। अचल गुलाटी सर जो वाइस चांसलर हैं जयपुर में, आप NMC के भी प्रेसिडेंट रहे हैं, आप हमारे बीच में हैं, बड़े एक्सपर्ट हैं एलर्जी के ENT की तरफ से, आपको धन्यवाद देता हूँ कि आप हमारे बीच में आए। हमारे KB नागेंद्र साहब जो बेंगलुरु से चल के आए हैं, अरोड़ा साहब हमारे बीच में हैं, सजल डे साहब हैं एम्स के हेड ऑफ डिपार्टमेंट रायपुर से, और तमाम जो फैकल्टी देश विदेश से हमारे बीच में हैं, कथुरिया साहब बैठे हैं, सबको, और जितने भी हमारे यहाँ के लोग हैं, KK सिंह साहब हमारे मीडिया सेल यहाँ की संभालते हैं, सीनियर हमारे साथी हैं, सबको मैं बहुत बहुत धन्यवाद देता हूँ कि आप सब यहाँ पे आए। और मुझे लगता है कि काफ़ी समय हो चुका है, फिर भी आप लोगों को एक तरह से ऊर्जावान दोबारा से करने का काम हमारे मुख्य अतिथि जी ने किया। मैं मीडिया बंधुओं का भी धन्यवाद देता हूँ, और जो हमारे पार्टनर्स हैं जो यहाँ तक हम लोगों को पहुँचा के लाए हैं, ऐसे हमारे ल्यूपिन, सिप्ला, ग्लेनमार्क और तमाम हमारे साथी, सबको धन्यवाद देता हूँ जिससे ये प्रोग्राम सफल हुआ। ओवरवेलमिंग रेस्पॉन्स के लिए आप सभी का धन्यवाद, बहुत बहुत धन्यवाद।
Thank you, sir, for beautifully expressing our collective gratitude. As we come to the close of this memorable evening, let us all rise for the national anthem. I cordially invite Ms. Shweta, Mrs. Priyanka, Mrs. Alia, and Mrs. Roli to grace the podium with their beautiful voice.
जन गण मन अधिनायक जय हे भारत भाग्य विधाता, पंजाब सिंध गुजरात मराठा द्राविड़ उत्कल बंग, विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंग, तब शुभ नामे जागे, तब शुभ आशीष मांगे, गाए तब जय गाथा, जन गण मंगलदायक जय हे भारत भाग्य विधाता, जय हे जय हे जय हे जय 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 हे।
Thank you everyone for your gracious presence. We now look forward to welcoming you all to the scientific sessions of ICAAICON 2025, scheduled from 31st October to 1st November at the Atal Bihari Vajpayee Scientific Convention Center. All dignitaries, esteemed faculty members and guests are requested to kindly proceed for high tea. Thank you.